Hello, good evening, doctors. Will able to, yeah. Hi, Basla. Jai Shriram. How are you? Is everything fine? Guys, quick check in the chat box. Like, uh, are you able to listen to me clearly? Yeah, good evening, Subhashri. Yeah, good evening. Hi, Basla. As like it was like it's written here. Like most, we'll start with OG, then we'll move on with Pedia, Aptal, then ENT, Derma, surgery, and Artho, if time possible. Then we'll do anesthesia also. Fine. Yeah. Good evening, Anonymous. Yeah. Hi, Priyanka. Hi, Patrick. Hi, Baisla. Then yeah, don't worry. Like because at this moment you'll be having a bit fear. It's a usually a normal one. So don't worry. Just keep on going. Just few more days left. Most probably soon around 15 um, we'll get the admit card and everything will go smoothly. Fine. So like sorry Lokesh, like it will be from the channel in, so I can ask them I to reduce them. Okay. Patrick, unnoted PDF. Actually, I shared them the unnoted PDF. I'm not sure whether they will be means like they'll be posting this PDF in group or not, but you will get the unnoted one. Fine. Yeah, like don't worry. Means like it's better to happen now because like if the exam like most probably it won't get postponed. Okay, so don't worry. Just prepare for now. Fine. Hi Ria. Hi Kusum. Yeah, fine. Yeah, with the same note, we'll move on to our parts. And finally, like just before addressing this session, let me tell you like for to whom this session might be helpful. Like, fine. Yeah, don't worry, anonymous. Don't be scared. Okay, just cool. You're answering so good means you have done a good preparation. Just keep going for a few more days. Like you'll be coming with flying colors. Fine. No, it won't be postponed. Don't worry. No, I didn't told it will be postponed. Postponed. Yeah, today will be the last session. Yeah, there will be no postponement. That's what I also want this to be um like happening as soon as possible. Okay, so don't worry, just keep on going. Okay, there will be no means like because FMG it won't get postponed. Okay, you can think about any other exams, but FMG it won't be. Yeah, sure. Like don't worry, we'll meet. Sure, we'll meet for meet again. Okay, don't worry, anonymous. Like fine, and this session will be helpful for those who will be preparing for the first time because they will be knowing like what are the things they need to know about these images and this part are most important things they might be preparing for the exam. And second one, like these are those peoples like who will be so who will be scared of these exams and they'll be having this mindset what to do in the meantime, like whatever I'm studying it's not getting in. For those it's like a relaxing kind of session, you can watch and you can enjoy it, and meanwhile you can learn a bit. Fine, you can learn a bit. Fine. Then there is also the third kind of people like who already studied everything and who are just chilling out, and for them also it will be a confidence booster session. Okay, you can also attend the sessions and it will be helpful for you. Fine. Sir, revise nahi ho pa raha hai. Like no, don't worry, like whatever you have done, like just go. If you're not unable to remember anything, just go superficially, like just flip through the pages. If you just flip through the pages it will be enough. Okay, it doesn't, you now you don't need to do this proper revisions. Now you need to do this flip through revisions or the superficial revisions. Okay, fine. Then with this note I will start our today's session. Fine. If you're able to see, this is the first image. Like if you're able to see this first image, then you'll be able to address that this there are multiple muscles which will be responsible, which will be yeah, which will be given in these images, or sometimes they will ask you what is the name of this image like muscle which won't be cut during this episiotomy. Could anyone tell me which of the following muscles won't be cut during this episiotomy? Yeah guys, yeah, they are pelvic supporters. Yeah, yeah guys, tell me which of those muscles. No, like urethra means like urethra won't be damaged. Like I will tell you, like what are the things. Fine. Just remember, there are different types of muscles. You'll be doing means different types of muscles in the pelvis. And from this, you need to remember just few more things. Like if you do a episiotomy, the episiotomy will be the cut from here. Fine. And if you do cut from here, you will be able to see this. You will be cutting this muscle known as bulbospongiasis. But if you see this muscle, which is what, which is this ischio-cavernous, this ischio-cavernous will be spared. Like in most of the times, this ischio-cavernous will be spared. Okay. So don't get confused. Fine. And means and we'll talk about this episiotomy in a more concise manner during the subsequent slides. Fine. And then if you're able to see this, all of this, most of these perineal muscles, they will come and attach to this structure. It is known as what? Perineal body. Fine. Will you able to see me, guys? Is there any network error? Yeah, fine. Yeah, fine. Then it's cool. Fine. Yeah, that's cool. That's nice. That's good to hear. Fine. Yeah, fine. Yeah, sounds slow. Is it fine? Yeah, hi, Anil. Hello. Is the sound is okay now? Hello, Dr. Anchal Singh. Hello. Yeah, fine. Yeah. Then we'll move on to our sessions. Fine. Yeah, fine. That's good. Fine. Then if you're able to see these structures, means this is our urethra and this is our vaginal opening. And then if you do a episiotomy, means initially it will be cutting this vaginal mucosa. Then it will be cutting this muscle, which is what, which is this bulbospongiosis. And just remember this one point about this structure, which is what, which is this ischio-cavernous. It won't be cut during this episiotomy. Fine. Just remember these things. And all of this muscle, sir, eat the mic. Nice joke, but then how you will able to hear? Like you will be hearing my peristalsis, not my voices. Fine. Then all of this superficial transverse muscle and also the deep transverse perineal muscles, all of them they will come and join at this level of this perineal body. Just remember. Fine. And this is the only one point you need to remember about this image. Next, if you're able to see, there is a swelling over this vulva. Swelling over this vulva. The patient is presenting with a painful swelling over the vulva, and just a superficial examination, we are able to identify this swelling. What is the name of this cyst was? What will be this cyst? Yeah, correct, anonymous. It is what? It is the Bartholin cyst. And for Bartholin cyst, we know it can go into the repeated inflammation and infection. So we'll do this marsupialization. Means we'll do, yeah, correct, anonymous. We'll do this marsupialization. Okay. Whereas if you're able to appreciate, this is also a type of cyst, but if it is of more deep in origin, and you will means means and you will be means and doing the PV examination, you will able to see feel this cyst in a more deeper structures. So if you're able to do this, feel this structure in a more deeper part, it will be what will be known as what? It is the Gartner's cyst. Okay. Gartner's cyst, which is actually what? Which is a cyst which will be the remnant mm, from this embryogenetic parts like mesonephric duct. Okay, just remember. Fine. This is how you will able to differentiate these two. Then there is a patient who is been presenting to you. Means at a 17 years, a female is presenting with features of amenorrhea, means which is the primary type of amenorrhea, and she's having cyclical abdominal pain, and along with this, yeah, so along with this cyclical abdominal pain, yeah, correct, Glyn's correct, anonymous, correct, Kansick. For cyclical abdominal pain, she will be presenting with. And on examination, you'll be able to see this bulge out. You'll be able to see this bulging of this hymen. And this will be what? This will be what? This will be the imperforate hymen. Imperforate hymen. And for this imperforate hymen, we use this in type of incision known as cruciate type of incision. Fine. We'll use this type of incision known as cruciate type of incision. Just remember. Correct answer? Correct. Yeah. There will be a bluish hue or a bluish bulging membrane. Fine. Yeah. Correct, Anil. Fine. With this understanding, we'll move on to the next part. If you're able to see this one, what is the name of this cannula? What is the name of this cannula? Yeah. It can cause endometriosis, but in a later part of life. Fine. What is this name of this cannula? Cannula. What is this name of this cannula? Yeah, correct, guys. It is what it is known as was Leach Wilkinson cannula. And we'll use this Leach Wilkinson cannula for a investigation known as hysterosalpingography. Fine. And this is how it does it done. Okay, fine. Yeah, correct. Glimpse, anchal, bisa, location, kinds. Fine. Yeah, don't worry. Like we have means today we'll study more instruments so that you won't be means you will have a clarity like which things will be asked and like what you would know about it. Fine. And means we'll use this in means we'll use this cannula for this investigation known as histosalpingography. And during this histosalpingography, you will be able to see if there is a just like uterus, it will be like means like the counter of the uterus must be like this. Whereas if you're able to see appreciate just a one one uterus, what will you think of? What is the name of this thing? Yeah, this will help you in NEET PG also. Yeah, correct. Yeah, it will be what it is known as what unique carnivate uterus. It will be what it is the unique carnivate uterus. Yeah, correct. Yes, and this is how this unique carnivate looks like because um because both of because uterus it will be formed from the two ducts and it need to join medially. If it doesn't, if one duct if it regress, the only one will form which lead to this formation of this unique carnivate uterus. Fine. Next. Yeah, yeah, correct, Anil. Next, if you're able to see this type of arc formation, and it is what it is known as what arcuate uterus. It is known as arcuate uterus. Fine. And we know the most common type of Mullerian anomaly, it will be what? It is the septate uterus. Okay, it is the septate uterus. And means like most on ultrasound and on the most of the investigation, the septate uterus and the bicarnate uterus, both of them they look similar. But if you're able to see, if the distance between them, if it is more than 4 centimeter means it will be what? It will be the bicarnivate uterus. It will be the bicarnivate uterus. Fine. If it is less than 4 centimeter, it will be the septate uterus. Yeah, correct, Ria? Yeah, correct, Anonymous. Correct, Lokesh. Fine. And then, if you're able to see, for this bicarnivate uterus, we'll use this method, means we'll use this method as a treatment known as Strassman, Strassman metroplasty. Fine. Whereas in the case of septate uterus, Whereas in the case of septate uterus, we'll do what? Hysteroscopic septal resection. Fine. Hysteroscopic septal resection. Okay, just remember this. Fine. Yeah, the angle will be more pronounced in the case of bicarnate uterus, where it will be less in the case of septate uterus. Yeah, correct answer. Fine. With this understanding, we'll move on to the next part. If a HSD image which shows this type of beaded type of the beads are the beaded type of fallopian tube. This beaded fallopian tube will be seen in a case of which condition? Yeah, correct, Anil. Which image is not clear? Mm. This is what this is. If there is a beaded appearance of this fallopian tube, it will be what? It will be the TB of this salpinx. Fine. Yeah, correct, Anil. Achal, Lokesh, Kans. Yeah, it is histosalpingography. Yeah, correct, Ria. Correct, Baisla. Correct, Larshini, and correct glimpse. Yeah, correct. It will be what? It will be the TB. Fine. And we know this type of TB, it won't spread via sexual intercourse. It will be spread via this hematogenous part. Hematogenous. Okay, just remember hematogenous. Fine. And there will be different types of like unnoted PDF. I already shared them. Like if possible, they will share you back, or else will give you the unnoted one. Fine. Next one, if you're able to see, there is a filling defects, and there is a history of, like any procedures, for example, suction and evacuation, or like mostly of DNE, like dilatation and curettage, any history, then it will be suggestive of what? This will be suggestive of Asherman syndrome. Asherman syndrome. Fine. Asherman syndrome. Yeah, correct glimpse, correct woodcutter. Yeah. Yeah, because of this excessive curettage, because we need to stop this curettage when you're able to see this grating sound or when there is a formation of bubbles. If you keep on doing this, you will go and damage the basal layer. This will lead to this formation of adhesions known as overzealous curettage. Yeah, correct. Like walking like more means more more consciously. Fine. And with this understanding, we'll move on to the next part. If you see a female who is having these features of irregular menstruality, irregular periods, along with these features of this acanthosis, Acanthosis nigricans, along with this feature of this string of pearls along with this central stroma. Okay, central stroma. Okay, peripherally along with the peripherally arranged follicles. Yeah, correct. FMG aspirant, Anil, Glimpse, Baisla, and Lokesh, Govindraj, Priya, Kinds. Yeah, you are getting it correct. It is what it will be. It is like if there is a two of these features, or if there is any both ultrasound feature or any hormonal feature, it will be suggestive of this PCOS. Yeah, it is the criteria which we use for this PCOS. It is known as what? Rotterdam's criteria. Okay, because at least any of these two will be present, either any biochemical changes or any hirsutum like androgenic changes along with this, means with or without this ultrasonic changes, like any two. Fine, it is what it is, the Rotterdam's criteria. And could anyone tell me what is the drug which we use to treat the infertility in a case of PCOS? Yeah, Stanley withdrawal syndrome, also known as, correct, Lokesh? Like what is the name of this drug which we use for infertility in a case of, yeah, correct, it is what it is, the drug which we use for infertility. Okay, it is what it is, the letrozole. Letrozole. Yeah, correct. Previously we used clomiphene citrate, but now we use this letrozole. Okay, okay, Akash. Yeah, treat. Yeah, yeah. We need to treat symptomatically also. Correct, correct. Anchal. Yeah, largely just remember previously we used to use clomiphene citrate, but now we are using the letrozole. Fine. And next we can do one more procedure in a case of PCOS, because there will be a thick stroma formation known as laparoscopic ovarian drilling. Okay, laparoscopic ovarian drilling. Okay. Yeah, correct. The anil. Yeah, that is the pathophysiology. Correct. Yeah, Lokesh, it is one of the complications. And if you're able to see the same, means around the same kind of appearance. But in history, they will be given like there is she's in treatment for infertility. Okay, infertility, and she have been administered with this HCG. What is this syndrome? Like means there is no any different, now there is no any differentiation between the NEAT and FMG. Like the pattern will be the same, but the just the negative mark is the difference. Okay, so don't worry, just keep on hammering, you will be coming with flying colors. Okay, don't worry. Fine, this is the ovarian hyperstimulation syndrome. Okay, it is what it is, the ovarian hyperstimulation syndrome. Correct, Amal, correct, Anil, correct, Lokesh, Baisla, uh, Lashini, and Glimpse, Anchal. Yeah, we're getting it correct. Next, if you're able to see, if there is a patient who is presenting with the features of infertility along with increased or this progressive dysmenorrhea, okay, along with this dyspareunia, on an examination, on a laparoscopy examination, fine, and like, yeah, there will be more than 9 follicles, correct, yeah, on an examination you'll be able to see this gunpowder or this burn powder deposition, or you'll be able to see this chocolate cyst. It will be suggestive of which of the following conditions? Yeah, correct. Yeah, there will be third space loss. Correct, Anil. Yeah. In the case of OHSS, yeah, correct. Anonymous Lokesh Baisla. Yeah, this will be what? This will be what? This will be the endometriosis. And we know this endometriosis, it is the presence of endometrium outside the uterus. Outside the uterus. And yeah, yeah, we can give GnRH. Yeah. One of the causes is the retrograde menstruation. Yeah, correct. Anonymous, correct, FMG aspirant. Next, if you're able to see, means if they ask you what is the most common site, of endometriosis. Okay, most common site, it will be what? It is the ovary. Yeah, it can be associated with the mutations also. Correct. Fine. It is the most common site. They will ask. Then it will be the ovary. Correct, FMG aspirant. Next, if you're able to move on, then if you're able to see some irregular, means if there is some irregularities of this uterus, irregularly enlarged uterus, which is more than or equal to, or more than, means are more than 14 weeks. Okay, or more than 14 weeks, or any weeks. Okay, which is irregular in nature. It will be what? It means along with this features of dysmenorrhea, along with some other features, like then it will be suggestive of which one? No, it's more than 14 weeks. Like, because we know adenomyosis, it is, if it is, it must be less than 14 weeks, right? If it is more than or any weeks, fine, this will be suggestive of this fibroids. Okay, and we know fibroids, the most common degeneration it will undergo, it is what? It is the hyaline degeneration. Okay, it is the hyaline degeneration. And like least commonly it will undergo this carcinomatous changes. carcinomatous changes, and in old age it can undergo this calcification. Calcification, this is what, this is the calcification of this fibroid. Fine, fine. Yeah, figure calcification we classification we use. Yeah, whereas in this type of, if there is a pregnant lady who is having these features of this painful, means the fibroids which are getting aggravated, which are getting painful during the time of pregnancy, because they will undergo this type of degeneration known as red degeneration. Okay, and what we do this conservative management. Yeah, correct, Anil. Correct, Kansak. Correct. Yeah, fine. Next, if you're able to see, there is a symmetrical, means this is um how this differentiate between this fibroids and this adenomyosis. If there is any symmetrical enlargement of this uterus, because here the endometrium will go and deposit inside the myometrium. Presence of endometrium into this myometrium. Fine. And this is what, this is the adenomyosis. There will be a symmetrical enlargement. Okay, there will be a symmetrical enlargement with this. Sir, we didn't get yesterday PDF. No, I think so. It's shared in your group. Just check it out, because I already shared, like yesterday night only. It has been shared. Okay, just check. Yeah, fine. Yeah, there will be on pathological examination. You're able to see this leaks of myometrial blood, and on ultrasonography you'll be able to see this dash and dot appearance. Fine. And just check Unisol, like check your groups. Fine. Okay. And if it will be a symmetrical enlargement which is not more than or equal to 14 weeks. Okay, just remember. Next, if you're able to see some kind of uterine mass which will be having, yeah, which will be having a feeding vessel. Okay, if it is having a feeding vessel, then it will be suggestive of, yeah, endometrial polyp. Okay, it will be suggestive of a endometrial polyp. Okay, fine. Then we'll move on to few infections. If you're able to see this type of strawberry vagina, means this is what, this is strawberry cervix, along with, if there is any greeny frothy discharge, frothy discharge, it will be suggestive of which of the following condition? It will be suggestive of this. What, this is what, this is the trichomoniasis. And we know trichomoniasis, it produces which type of motility? Yeah, correct, Ria. It produces what? It produces this twitching motility. It produces this twitching motility, and to treat we'll use this metronidazole. Okay, we'll use this metronidazole. And if you're able to see this type of cells, means there is a lactobacillus which are being adherent to the epithelial cell, it will be what? Yeah, correct, doctor. Correct, Lashini. Correct, Zivi. And Johnson. Correct answer. Yeah, correct. Then this is what? This is known as what? This is known as clue cells. Clue cells. Fine. And this is what? This is the diagnosis. What? This is the bacterial vaginosis. Fine. And for this also we'll use this metronidazole. Fine. Yeah, correct, Johnson. Fine. If you're able to see, there is this abundant lactobacilli which is being adherent to this um, epithelial cells. Fine. And next, if you're able to see this cardioid discharge, cardioid discharge, cardioid discharge, what you will think of? Okay, okay, sorry. Then I will just cross check with them once the session is once we get a break. I will just cross check with them. Okay, don't worry. Yeah, in Candida we'll be able to get this cardioid discharge. Okay, cardioid discharge will be seen in a case of candidiasis. Candidiasis. Fine, just remember. Fine. Next, if you're able to see this type of verrucous growth or this warty lesions which are huge, what you will think of? What is the diagnosis you will think of? Yeah, guys. Yeah, no, it is condyloma acuminata. Just remember, FMGe aspirant, it is acuminata. Fine. Yeah, it is what the first one. It is what, it is the condyloma acuminata. Okay, and it will be seen in a case of which infection? Yeah, correct, Patrick. It will be seen in a case of HPV infections. Fine, especially of 6 and 11. Okay, HPV of 6 and 11. Next, if you're able to see some solid, means if there is no verrucous, if there is some kind of solid like masses, okay, like a nodular masses, then you will think of this condyloma lata. Okay, condyloma lata. And we know this condyloma lata, it will be seen in a case of, it will be seen in a case of which infection? It will be seen in a case of secondary syphilis. Yeah, correct. Zivi? Yeah, correct. Yeah. No, that is HPV 16, 18. It is what it leads to this cervical cancer. Whereas, okay, just remember. Whereas this condyloma acuminata, it will be by this 6 and 11. Fine. Yeah, correct, Anil. Correct, Johnson. Correct, Jonter. Correct, John. Yeah, we're getting it correct. Next, if you're able to see this, yesterday also we saw in CPC this violin string, violin string appearance or this perihepatic adhesions. It will be seen in a case of which condition? It will be seen in a condition known as Fitzhugh, Fitzhugh cutis syndrome. Okay, it is known as Fitzhugh cutis syndrome. Just remember. Yeah, correct ZV, correct FMG aspirant Lokesh, Ria, and Unisol Gaming, and Johnson. Correct. Yeah, fine. Then we'll move to some pregnancy changes. If you're able to see this type of um, this type of appearance, which is known as what? A black line running over the means running over the abdomen. What do you will think of? Yeah, it is what? It is not linea alba. Means see, it's a black line. So it will be what? It is a. If you're able to see this, means black line means the side one it will be a white. Okay, it will be like more post pregnancy. So it will be what? Yeah, it will be what? It is the linea nigra. Okay, linea nigra. If you're able to see nearby one which is white, which is the alba. Fine. If you're able to see this black one, it will be the linea nigra. Okay, just remember. Yeah, correct direction. The next one will be what? It is known as what? Cholasma. Okay, and is the facial changes in the pregnancy. Fine. Next, if you're able to see this type of bluish or this violet discolorization over the cervix and the vaginal wall. It is what is this name of this sign known as? Yeah, guys. What is the name of this sign known as? This is known as what? This is known as Chadwick sign. This is known as Chadwick sign. Just remember, it is known as what? Chadwick sign. Okay. Yeah, correct, Ria. It is known as what? Chadwick sign. Next, if you're able to move on, means you need to know about this twinnings. Fine, yeah, correct Johnson's, correct ZV. Okay. If you're able to move on, you'll be able to see this type of twinnings. Okay. Just a minute, guys. Yeah. Sorry for the interruption. If this image, like, means this is what how this twinning happens. Fine, yeah, Ria, yeah, Sharma, you are getting it correct. Yeah, these are the two signs. Like, fine, before that, you just remember how this twinning happens, like how this dichorionic diamniotic and these other twins are being formed. If you are able to see, if there is a separation before the third day, and then it will be what? It will result in the dichorionic diamniotic twins. Like, for example, you are meeting for your first friend in a cafe. Okay, then initially you don't know them. Okay, then you will start talking. Then once you start talking, then you know them. So on the first day, if you're both of you are getting coffee or any things, you will be paying separately. So remember, if it is first 3 days, it will be a dichorionic diamniotic twins. And later on, you know, like when after 3 days you or 4 days you are seeing them in continuous, then means one will pay and other they will think, okay, it's not good to pay with a stranger, so he will send off. So the payment will be a single, but actually he will return back. So it will be a monochorionic and diamniotic twins. But after 8th day, you become this thick friends, and you know who will be having the money. So the money one will be paying. So after 8th day, the who will be having this money, he will be paying it off. So after 8th day, it will be a monochorionic and monoamniotic pregnancy. Whereas after 14th day, it will be what? It will be the conjoined ones. You will become more and more close friends. Just remember these things so that you will be able to answer this questions is being asked in exams. Next, you will be able to see this type of twinnings. Fine. Yeah, most common type of this conjoined ones, it will be what? It is the sarcophagus type. Fine. Next, you will be able to see this type of sign. Means this is known as what? Lambda sign. Okay, this is known as what? Lambda sign. And this lambda sign, you can remember by this mnemonic known as uh, okay, yeah. Lambda sign also known as twin peak sign. Okay, fine. You can remember by this mnemonic known as Moti or also known as Laddu. Okay, means if someone is chubby, you will call them means lovely known as Moti or Laddu. Fine, just remember. Yeah, correct. Yeah, correct, Govindraj. Yeah, if you're able to see, so it is known as, if you see this lambda sign, L for lambda sign will be seen in a case of dichorionic diamniotic pregnancy. Fine. Whereas next sign, if you're able to see this small thin, so it will be what? It is this T sign. It will be seen in a case of monochorionic pregnancy. So remember that as Moti Laddu. So monochorionic pregnancy, it will be having this T sign. Okay, just remember. Yeah, correct, Baseline. Yeah, correct, Ria. Then we'll move on to the types of placenta. If you're able to see this type of placenta, why it is important is that everyone has their own significance. Yeah, thank you, Nityanand. Yeah, thank you. Yeah, fine. If you're able to see this type, if there is a placenta, if there is a main placenta, along with this, if you're able to see a small secondary lobe, okay, are also known as succensurate placenta. Fine. This will be what? This is the succensurate placenta. And we know if there is any presence of this succensurate lobe, they may present you with PPH. Fine. Yeah, correct concept, correct Ria. So they can present you with PPH. Fine. They mostly have secondary PPH. Okay, so we need to remove this placenta very carefully and we need to examine them very carefully. Fine. Next, if you're able to see this premature separation, if you're able to see this cord should be separated here. But if there is any premature separation of this cords before joining to this placenta, then it can lead to this. This is which type of placenta? Yeah, guys, this is which type of placenta? Guys, be active. Yeah, correct answer. It is known as what? It is known as velamentous velamentous insertion of cord. And if there is any velamentous insertion of this cord, it can lead to this vasa previa. Fine, it lead to this vasa previa. Okay, now don't confuse it with battledore. Fine, and marginal. Just glimpse. Will just wait. I'll show you the battledore one. If you're able to see this, this is the marginal means if there is around this margin, this is what this is the battledore placenta. But if you're able to see this umbilical cord, it is attached to the placenta till the end. But here it is being separated prematurely. So this is how this battledore placenta looks like. And if there is if there is a if there is in a margin, if there is in a thick margins, so it will be what? It will be the yeah, sure, Shubham. You will get the PDF for sure. Like I will just communicate with them in the break, and you will get this PDF for sure. Okay, don't worry. Fine. And if there is with thickened margins, it will be what? It is the circummarginate placenta. And if you're able to see this type of thickening, this is known as what? This is known as circumvallate placenta. Means if instead of over, means ending here, if it is ending near to that or in the middle, it is known as what? Circumvallate placenta. Okay, yeah, correct, Ria, correct, Johnson. Fine. Okay, don't take stress about the PDF. Like you will get for sure. Like I don't know where the glitch is. I will ask them and I will share you as soon as possible. Okay, don't worry. Fine. And next, you will able to see this type of manure. And what is this name of this manures? Yeah, they are known as what? Leopard's manure. And then first, you will able to feel this fundus. If you are able to feel this fundus, you will able to know which part is the presenting. Means if you are able to see this small irregularities, means the baby's sacral lesions and the limbs in the fundus part, means the head is in the downside, so it is a cephalic presentation. Next, this then you will need to know this lie, means whether the lie is a longitudinal one or the transverse one or the oblique one. So you will keep this hands on the side and you will able to see what is the lie. You will able to locate the lie. Yeah, correct, Shubham. Baisla, correct, Rose. Yeah, yeah, first one is known as fundal grip, second one is known as lateral grip. Fine. And you will know this type of lie. If it is parallel, means if it is parallel to this female pelvis, it will be what? It will be a longitudinal lie. If it is perpendicular, then it will be a transverse lie. Fine. Then you will able to see this type of grip. What is the name of this grip? It is known as Pavlik's grip. Yeah, correct. Like first three will do on seeing the patient's leg, whereas four will do by seeing the patient's leg. Yeah, correct. Yeah, this is what this is known as what? Pavlik grip. This is known as Pavlik's grip. Okay, just remember this is known as Pavlik's grip. Next one, to see this engagement, okay, whether the head is engaged or not, we'll use this grip which is known as pelvic grip. Okay, pelvic grip or this fourth leopard grip, fine, or this fourth leopard maneuver, which we'll use to see whether it is engaged or not. If it is engaged, your hands won't meet up. If it is engaged, your hands won't meet up, or if it doesn't engage, your hands will meet up. Just remember these things. This is how you will able to differentiate this different types of leopards maneuver. Fine. With this understanding, we'll move on to the parts of or the types of female pelvis. If you're able to see, this is how this normal oval shaped female pelvis, which is the gynecoid type, which is the most common type also. Fine, it is the most common type also. Next, if you're able to see this type of this heart shaped pelvis or this triangular shaped pelvis, it is known as what? It is what it is the yeah, correct, Rose. It is the most common type. It is the gynecoid. It is what it is the android pelvis. And we know this android pelvis can lead to this one type of complication known as deep transverse arrest. Okay, it can lead to this complication known as deep transverse arrest. Next, if you're able to see this flat pelvis, it is known as what? It is known as platypod pelvis. If there is any flat pelvis, it is known as platypod pelvis. Okay, fine. And if you're able to see this vertically, epidiametrally over this type of pelvis, it will be known as anthropoid pelvis. And you will be able to see a typical type of delivery in a case of anthropoid pelvis. It is known as what? It is known as phase 2, phase 2 pubis delivery. Phase 2 pubis delivery. Fine? Yeah, correct. Yeah, there will be a persistent occipito-posterior. Yeah, correct. Correct, Govindraj? Yeah. And that can lead to this deep transverse arrest. Yeah. Yeah, correct, Rose. Yeah. And next, if you're able to see this only one, this is this the in normal patients, you'll be able to see this two wings of this the two ala of the sacrum. If you're able to see if there is one wing of this ala or one ala is absent, so it is which type of pelvis? What is the name of this pelvis known as? Or if there is any one ala absent, it is known as which pelvis? Yeah, it is known as which pelvis? Yeah, correct, Govindraj. Then others expecting your answers. Yeah, it is known as what? Nuggles pelvis. Whereas if both of them they are absent, if two of them are absent, it is known as what? Robert's pelvis. It is known as Robert's pelvis. Just remember. Fine. Next, we'll move on to the next part. Like this is how this episiotomy which is being done. Usually, before we used to do this midline episiotomy. Now, mm, mm, yeah, yeah, correct, Govindraj. Correct, Hasanar. Fine. If you're able to see, means there are two types of episiotomy. There is a medial episiotomy and there is a mediolateral episiotomy, fine, or the middle episiotomy and the mediolateral episiotomy. Now the most commonly done is the mediolateral episiotomy, because if you do middle episiotomy, means for extension we cannot do more extension. If we do more extension, there will be a perineal tear and there will be involvement of this anus also. So to prevent this we'll use this mediolateral episiotomy. Yeah, correct, Kansik. Correct, Govindraj. Correct, Lokesh and Ria. Yeah, correct. Yeah, in medial lateral there is a no risk of rectal injury, and we can extend it as more as J or a T. Okay, just remember. Okay, more as J and T. Fine. And the disadvantage is that there is a more blood loss. Fine. And if you means if you didn't do this episiotomy, means, or if you didn't do this episiotomy on time, fine, then there will be a then there will be this can lead to this complication known as perineal tears. Okay, perineal tears. And this perineal tears, it is of different degree. If you're able to see, just this vaginal mucosa, it's being turned, means if this toning of this vaginal mucosa, it will be what? It will be the first degree. Correct, Rose? Yeah, correct. Correct. Initial. Correct. It's correct. Yeah. Then second means in a case of second degree, we are able to see this vaginal mucosa. Along with this, there is a tone in the perineal membranes or perineal muscles. If there will be a toning of this perineal muscles. And in a case of third degree, there will be involvement of this anal sphincter. Fine. If there is an involvement of this anal sphincter, this third degree is of two types, A and B. If there is a less than 50% involvement, it is of A. If it is more than 50% involvement, it will be as 3B. Fine. And if there is any mucosa of this rectum which is being involved, then it will be classified as the fourth degree one. Okay, just remember, it will be classified as the fourth degree one. Okay, these are the four. Yeah, correct, Baisla. Correct, Priyanka. Yeah, fine. These are different types of perineal tears you need to remember. A, less than 50%. B, which is of more than 50%. Fine. Next one is able to see, these are the movements which are being happening during the case of normal labor. Fine. In the case of normal labor, initially there will be a formation of this bag of membranes. Once the bag of membrane is being formed, then the head will start descend down. Once the head start descend down, then it will go under this rotation. Okay. Once then it will go under this internal rotation, and once there is an internal rotation, the baby will come under, means come outside by this complete flexion. Okay, complete extension. Once it comes into this extension, it will goes this procedure known as restitution, in which previously which is did the internal rotation, now it will being relieved by this external rotation. Then there will be delivery of this anterior shoulder, and finally there will be a delivery of this posterior shoulder. Okay, this is how this normal delivery occurs. Fine, yeah, can say. And if you're able to see, once the baby is being delivered, okay, then means once this anterior shoulder of this baby delivers, then we'll perform this active management. There are active management in this third stage of labor, in which we'll give what? We'll give this oxytocin. Okay, oxytocin. Just remember, we'll give this oxytocin. Fine. And once the oxytocin, yeah, correct, Rose. Once the oxytocin is given, then we'll do this cord clamping, and along with this, we'll remove this placenta. Fine. And this placenta can be removed by, yeah, it's given as IM, like fine, it's given as IM. Then this placenta can be removed by two methods. Like if there is any central separation, if there is a lateroplacental cut and the central separation occurs first, then it is known as Schullett's method. Then it is known as what? Schullett's method. And if the separation starts from the side, it is known as Matthews Duncan's method. It is known as Matthews Duncan's method. Yeah, Krishna Rawat, yeah, you are a kind Rawat, you are exactly prescribing the dose itself correct. Yeah, that's correct. Fine, correct, Baisla. And then there are two methods, Schullett's and the Duncan's method. Then sometimes, if there is, if in sometimes the shoulder, the baby will not unable to deliver its shoulder. Fine, because for example, if there is any macrosomic baby, fine, or if there is any, like mostly if there is any macrosomic baby, if the shoulder is not able to deliver, then it can lead to a condition known as shoulder dystocia. Fine, shoulder dystocia. Fine. And if there is any shoulder dystocia, what we'll do is we'll do two maneuvers. One is known as Meg-Roberts maneuver. If this maneuver fails, then we'll move on to the next maneuver. Means we'll bring the patient to the corner of the table and we'll flex their hip and we'll give this suprapubic pressure. Fine. Yeah, suprapubic pressure. Just remember, we'll do this maneuver known as first. We'll do this Meg-Roberts maneuver to deliver this anterior shoulder. Fine. And if this things fails, then what we'll do is how this baby came out means then we will rotate and we'll keep this head inside. So okay, we'll push the head inside and we'll do this maneuver known as Zavanelli maneuvers. Okay, we'll do this maneuver known as Zavanelli maneuver. We'll do this maneuver known as Zavanelli maneuver and we'll undergo the C-section. Okay, C-section. Okay, this is one of the this is done in a case of shoulder dystocia in a case of macrosomic baby. And next, if you're able to see, if there is a breech baby and you deliver till the chest, okay, or you deliver till this umbilicus, then the hair, then to deliver this head, you will use this maneuver known as Mauricio Snelly Weep maneuver, in which you will just put your fingers into the mouth and you will do the malaflexion and you will take out the baby. So this is known as what? This is known as Mauricio Snelly Weep maneuver. Okay, just remember this maneuver. Just it will be a just remember smile because we smile with mouth, and here we'll put our fingers into the mouth. Just remember. Fine, we'll able to remember this. Then if the head is not coming and this whole till the shoulder is being delivered, then we'll do this maneuver known as or techniques known as, yeah, there is a malar flexion and shoulder flexion. Yeah, correct guys. If you're able to mm, do this in a arc fashion, we'll use this we'll deliver this baby in a arc fashion known as Burn Marshall techniques. Okay, Burn Marshall's technique. Okay, we'll do this techniques known as Burn Marshall's techniques. Yeah, correct, Rosalifa. Next, if you're able to see, mm, if you're able to see, means if it is a still baby is not, means if previously if in a case of breech, if the baby is not delivering, then we can do one more maneuver in which we'll rotate the baby of this will hold the trunk and will rotate the baby. It is known as what? It is known as Loveseth's maneuver. Okay, it is known as Loveseth's maneuver. Okay, just remember it is known as Loveseth's maneuver. And to deliver that, in a case of any extended breech, okay, yeah, correct, Rose. Yeah, full moon. This is what, this is the Pinnats. This is the Pinnats method. Okay, in which if there is any extended breech, you want to deliver this legs, then you will go inside and you will just flex the leg. You will keep a finger on the popliteal fossa and you will flex and you will bring the leg out. So it is known as what? Pinnats maneuver. Okay, these are the maneuvers which is means like because they can be given image as an image and they will ask. Fine. Yeah, hi Amikit. Fine. And you will able to see this is where there is a premature separation of this cord, like because there is a premature separation of this cord and this cord, this is what, this is the velamentous insertion and this can lead to vasa previa. Okay, vasa previa. And remember, in the case of vasa previa, the blood will be from this baby. Fine. Okay, don't forget. Yeah, correct, Rose. It can lead to this vasa previa. Fine. With this understanding, we'll move on to the next part. Next, if you're able to see, okay, means if the placenta is low lying, if the placenta is low lying, it can result into the huge blood loss. Okay, okay, so this if the placenta might be mostly in a superior aspect. If it is towards the cervical os, it will be what, it will be either it can be low lying or it can be covering the os complete or partially. So it is what, it is the placenta previa. Okay, Okay, we'll consider them from the marginal. So if this touching this margin, so it is what it is the marginal placenta previa. Okay, or if just obstructing half of the os, so it is what it is the partial placenta previa. And if it is completely obstructing, it is what it is the complete placenta previa. And we know in a case of placenta previa, we won't do this, we won't go for a normal labor, we'll do cesarean section, right? In a case of partial or complete placenta previa, just remember. Okay, we'll do elective cesarean section, or in a, if there is an emergency, we'll do this cesarean section even, fine. And then normally this placenta will be like this, and because of this presence of this membrane known as a correct location, correct Baisla, if there is any presence, because of this presence of a membrane known as Nitabux membrane, Nitabux Nitabux membrane, fine. And if there is any absence of this Nitabux membrane, this placenta can go more deeper, and it can result into this three condition known as AIP, known as accreta, increta, and percreta. Okay, accreta, increta, and percreta. Yeah, and one of this, like the most common cause, this most common cause, it is what is the previous history of placenta previa. Okay, so remember the placenta previa, it's one of the complication. It can result in um, it can result in this one, which is this morbidly adherent placenta, just remember. Okay, so previous history of placenta previa, and or if there's any previous history of any morbidly adherent placenta, or sometimes it can happen because of this previous history of LSCS. Okay, just remember this can lead to this morbidly adherent placenta known as accreta, increta, and percreta. Okay, yeah, yeah, thanks. Yeah, correct, Rose, correct, Larshini, yeah, you are getting it correct. Then if you're able to see, if there is a, if there is a pregnant female around the 20 to 25 weeks, if she's coming with a tender abdomen, if she's coming with a tender abdomen along with this pallor out of proportion, okay, pallor out of proportion, okay, okay, and a tender and tense abdomen, this will be because of this condition known as, what is this condition? Yeah, guys, it's, yeah, it is the next one is the cavalier. Yeah, correct. Yeah, correct, Rose. Yeah, it is what it is. It is seen in a case of abruptio placenta. Okay, it is seen in a case of abruptio placenta. Okay, because are the premature separation of this placenta, and it's of two types. Either she can come with this pervaginal bleeding present, or she can come without any PV bleeding, which is known as what? It is known as concealed variety, or it is known as what? Revealed variety of revealed type of placenta, means an abruptio placenta. And sometimes this abruptio placenta can go and invade this myometrium. This is lead to this type of uterus, a correct Priya and Priyanka. Yeah, a correct correct full mean, like it can lead to this type of uterus known as cavalier uterus. Okay, cavalier uterus. Okay, just remember it can lead to this uterus known as cavalier uterus. And we know, like mostly if there is any case of abruptio placenta, if the abruptio placenta will go with normal vaginal delivery, right? Okay, only if the fetus is in distress, will go for cesarean section, otherwise will go for normal vaginal delivery, fine. And if there is any DIC also, will control the DIC and will go for normal delivery. Okay, if there is any fetus distress, or if there is any maternal means or more morbidity, and those situations will go for LSCs, just remember, fine. Next, if you're able to see, if a female who is presenting with more second trimester abortion, correct Baisla? Yeah, if you're able to see a female who is having this more second trimester abortion, and on scanning, you're able to see the length of cervix, it is less than 2.5 centimeter. Fine. Length of is less than 2.5 centimeter. What is the name of this procedure you will do? Or the name of this circlage you will do? It is what it is known as what? McDonald's. What is the name of this circlage? Yeah, guys. Yeah, it is what it is the McDonald's circlage. Fine. Which will be seen in which will be done in a case of incompetent cervix. Okay. Next, we are able to see this type of suture. Means in a case of PPH, okay, in a case of PPH, we'll start with oxytocin, then we'll go for methogen. If there is any contraindication for this methogen, we'll use carbaprost, and if nothing helps, we can go for arterial ligation. If this also fails, or previously, or if there is no limited setup, or resource limited settings, we'll use this type of sutures known as B-Lynch sutures. Yeah, correct, Priyanka, Ria, and Baisla, and Rose, you are getting it correct. It is known as what? B-Lynch suture. Okay, it is the B-Lynch suture which we will use for PPH. Yeah, correct, Ria. Next, if you're able to see this in ultrasonography, we'll able to see this snowstorm kind of appearance. Snowstorm appearance. Along with this, if you're able to see this type of small grape nodules, what you will think of? Yeah, correct, full moonlight. It is known as what? Yeah, identiform mole. Yeah, correct, Rose. Correct, Rajarajeshwari. Fine. The correct, Ravat. It is what? It is the moles. So it is what? It is the molar pregnancy. And there will be two types of moles. It is completely mole. It will be what? It is a complete mole. And if there is a mole along with this fetal part, it will be what? It is a fetus. It will be what? It is a partial mole. Fine. It is a partial mole. Okay. And in the case of the partial mole, just remember the chromosome number will be 69XX. Okay. XXX or XXY. Just remember. Fine. Whereas here XXY mostly, and here if you see this complete mole, it will be 46XX. Remember, like there will be less likely to have a XY part. Fine. Yeah, partial it will be, just remember, if you flip this P, it will be 6. If you flip this 6, it will be 9, so it will be a 69. Just remember, if you are getting confusion with it. Fine. Yeah, correct for moonlight. Like most commonly in a case of complete molar pregnancy, it will be what? It will be the 46XX type. Fine. Because mostly it will be from the maternal origin. Okay, um, there will be no like male counterpart. Fine, just remember. With this understanding, we'll move on to the next part. If you're able to see, this is what this how this WHO partograph looks like. Okay, where we monitor this, yes, cervical dilation along with this horse. Fine, where we also monitor this fetal heart rate. Fine, fetal heart rate, and we'll do this CTG. Yeah, there is a more chance of carcinoma. It can results into the choriocarcinoma in a case of complete mole. Correct. Yeah, fetal tissue will be present in the partial. Just a minute. Fine. Next, if you're able to see this dip or this tip of this fetal heart rate deceleration along coincides with this means contraction, then it will be what it is known as what? Yearly deceleration. And we know this yearly deceleration, it is an absolutely normal one. Okay, it is an absolutely normal one, which will be because of this head compression. It will be because of this head compression. Fine. And if you're able to see, if there is a uterine contraction, and if the fetal deceleration, it will be followed by this contraction, it will be known as what? It is the late deceleration. Remember, if someone died, if someone died, we call them as late. So remember, so if late means the baby is in a, means is in a some difficult situation, or baby is gonna die. So it's because of this. Remember, like baby is gonna die. So because of this uteroplacental insufficiency. So just remember, so the most serious one, it will be the late deceleration, which leads to this uteroplacental insufficiency. Fine. Remember. Yeah, correct, Baisla. Yeah, we need to check for 15 seconds, and usually like there will be 5 to 15 boxes, or 5 to 15 increase in the heart rate, or there is a 5 times of B2 bit variability we need to check. Fine, just remember. Next, if you're able to see this variable type of deceleration, means there is no coincidence with this contractions. It will be seen in a case of umbilical cord compression. It will be seen in a case of umbilical cord compression. Just remember. Next, this is how this to means this how this CTG is being recorded. If you're able to see, this is the uterus probe, which is used to know this tone of this uterus. Next are these contractions of this uterus known as, okay, topography. Next, this is what, this is the probe which is used to hear the fetal heart rate. Okay, yeah, correct, Rose. Next, if you're able to, we'll move on to a few contraceptive methods. If you're able to see, this type of method means in which the beads are used to calculate the days. Okay, what is the name of this method? Yeah, beads method, or it is also known as which method? Yeah, guys, waiting for your answers. It is known as which method? Otherwise also known as, yeah, yeah, correct. It is also known as Tirumala method. It is also known as Tirumala method. Okay, fine. Okay, it is one of the type of natural contraceptive methods. Next, if you're able to see this, how this male condoms looks like, and male condoms will be provided from the government, are branded as from the government as the name of Nirod. Okay. Next, if you're able to see, this is how this female condoms looks like. And if you're able to see this female condom, it will be having this two rings. The male condom will be having a one ring, whereas this female condom will be having this two rings. And and this female condoms like there are FC2 types of condoms which will be given by this government for free of cost for these commercial sex workers. Fine. Yeah, correct, Govindaraj. Yeah, Larshini Govindaraj. Yeah, correct. Yeah, and this FC2 types of female condoms will be provided to this commercial sex workers. Okay, especially for the females. Fine. Yeah, correct, Priyanka. And next, if you're able to see this type of cap, it is known as what? It is the Dutch cap, also known as diaphragmatic cap. That one of this most problematic thing in the case of diaphragmatic cap is that mm, cap is that it must be fitted by this physician. So it will be a difficult one, and it should be removed because to prevent this any bacterial contamination or prevent this toxic shock syndrome. Yeah, correct, Kans. Fine. And next, if you're able to see this type of like just checking this cervical mucus, okay, type of cervical mucus thickness. Okay, this method is known as checking the cervix mucus known as Billings method. Fine, it is known as the Billings method. Just remember, it's known as Billings method. Next, if you're able to move on to the next part, you can see some oral contraceptive pills, and this oral contraceptive pills, okay, oral contraceptive pills will be given by this government in the two variants. One, it is known as Mala N and Mala D. Okay, remember Mala N for no money. Okay, okay, D for dollar, and it is paid. So remember, it is a paid one, it is a free one, and both of them they will be containing this 3 microgram of ethinyl estradiol and 150 microgram of the progesterone. Just remember. Then for this, yeah, we'll be having this ethynyl estradiol and the levonorgestrel. Okay, just remember. Fine. Next, if you're able to see this images, if you're able to see this image, you'll be able to see that there are white color tablets and black color tablets. And these white color tablets, they are the hormone tablets. Whereas this black color tablets, they are actually what? They are this iron tablets. So we need to start taking, means we need to counsel the patient, they should start taking from this white tablets, and they need to continue, okay, and continue till this whole cycle. And in the last 7 days, they need to take this iron tablets, okay, iron tablets. Okay, just remember the white one will be the hormone tablets, whereas this black one which is will the iron tablets. Okay, just remember. Fine. Next one, if you able to see this type of injections, okay, which is branded as Antara, which will be made up of this medroxyprogesterone acetate. Okay, it will be given as an injection. Okay, which will be given as once in a 3 months. Once in a 3 months. Okay, just remember it will be given as once in a 3 months. Next, if you able to see this band, which is branded as Chaya. Previously, it is known as Saheli. Okay, now it is branded as Chaya, which will be having this common known as Senchromafin. Okay, Senchromafin. Fine. Which is the Senchromafin, which is and the component is what it is the ormilaxafin, which is a means if for initial first 3 months, it should be taken twice a week. For us, for the next three, like once a week. Just remember, once a week from the after 3 months, whereas before 3 months it should be taken twice a week. Just remember, it will be written here also. You can able to see. Fine. Next, if you're able to see, there are few intrauterine devices. If you're able to see these first generation devices, they will just mainly act by this foreign body reaction. Okay, and this is what? This is the Lippel's loop. Okay, this is what? It is the Lippel's loop. Next, if you're able to see this copper windings on these arms also, correct? If you're able to see this copper windings in the arms, it will be what? It is the 380A. Fine, because you will be able to see this copper windings and the arms also. Fine, and it will be for having this CUT 380A, and it will be having this lifespan for 10 years. Fine, it will be having this lifespan for 10 years. Yeah, correct, Baisla. Yeah, correct, thanks. Correct, Priyanka. Next, we will be able to see this multi-load 375, and it can kept for how many years? It can kept for 5 years. Just remember, it can be kept for 5 years. Next one, this is the Myrina. Okay, this is the Myrina. Okay, and this Myrina, the whole composition, it is a 52 milligrams, whereas it releases every day, it releases 20 micrograms. Just remember, it is made up of 52 micrograms, whereas every day it releases 20 micrograms. Fine. And for and for and for tubal ligation, we use this type of procedure. Okay, we'll use this type of procedure, which is known as what? Modified Pomeroy's technique. We'll use this method known as modified Pomeroy's techniques. Next, there's also this type of implants. You'll be able to see 1, 2, 3, 4, 5, and 6. 6 stylistic capsules are being subdermally implanted. Okay, fine. Yeah, means you can keep it, means like Mirena, it can be like up to 5 years, but they'll tell, but mostly it will be up to 3 years. Yeah, correct. It is the 3 years of Mirena. Just remember. Fine. And if you're able to see the 6 stylistic capsules, which is implanted into the subdermis, it is known as what? It is the Norplan. It is the Norplan. Just remember. Fine. Okay. With this understanding, we'll move on to the next part. If you're able to see this one, it's used to collect the samples from the ectocervix. It is what? It is the Ayres spatula. Ayres spatula. And if you want to take from the endocervix, you will use this second one, which is what? Which is the cytobrush or this endobrush. So this cytobrush. Okay. And the last one, if you're able to see this one single one, which can take from this endocervix also, ectocervix also, and from the transition zone also. It is what? It is the cytobroom. Okay. Just remember, broom brooms everything. So broom brooms everything. Okay. So cytobroom, it can take from ectocervix, endocervix, and also from the transition zone. Yeah, correct. Yeah. Fine. Just then, if you're able to see on application of acetic acid, if there is any color changes, it is this method is what it is known as visual inspection under acetic acid. If there is any malignancy, it will coagulate, or it will make use of this acetic acid. So we can screen for malignancy using this visual inspection under acetic acid, and it is a screening tool which will be more cost effective in nature. Then if you are able to see this type of test, in which a Q-tip is being inserted into the bladder. Okay, and we tell the patient to cough or cough. Okay, if there is a mobility, if there is a large mobility, and if there is any pulsated release of this urine, this will be because of this. Or if there is any release of this urine after this any increased abdominal pressure, it will be what? It is the stress urinary incontinence. Okay, it is the stress urinary incontinence, and the test is what? It is the Q-tip test. Okay, yeah, means we use this VAA and the cytobrush to rule out this CA cervix. Correct. Next, if you are able to see, means to know this type of fistulas, whether if they are from this ureter, or is it from this bladder, or is it from this urethra. Okay, fine. If we means first we will use to dye, means first what we will do is that we'll fill this bladder with this blue color dye. Okay, if the first one, if it is being soaked just by the urine, not with this blue color, then it will be what? It will be the ureterovaginal. If the second one, if the first one is being soaked by the blue color one, then it will be what? It is the vesicovaginal fistula. Okay, vesicovaginal fistula. Okay, then, or if the third one, if it is being soaked by this either urine or from the dye, it will be what? It is the ureterovaginal fistula. Okay, remember the most common cause for this vesicovaginal fistula, it is what is the most common cause in India. It is what? It is the obstructed labor. Okay, remember, it is what? It is the most common cause. It will be the obstructed labor. Fine. These are the things you need to remember about this type of test, and in case of fistulas. Fine. Next, we'll move on to this part. Okay, if you're able to see this, they are used in a case of abortions or MTP. Okay, abortions are MTP, or we'll call it as more properly as medical termination of pregnancies. Fine. For this, initially, this is how this menstrual regulation. This is how this menstrual regulation syringe looks like. Fine. This is how this menstrual regulation syringe looks like. Yak Kanzik, Yak Baisla. The next one, it is what? It is the manual vacuum aspiration syringe. Okay. Okay. And it can develop up to the pressure of 600 to 660 millimeter Hg of pressure, and it can hold up to 60 ml of fetal contents. Okay, and it can hold up to 60 ml. Next, for this syringing, we'll use this type of cannula. Based on this, the size will be decided based on the week of pregnancy. So it will be what? What is the name? It will be what? It is the Karman's cannula. Okay, it is known as what? Karman's cannula. Will use based on the gestational age of the fetus. Fine. Yeah, means like mostly the The volume it will be of around 60 ml and the pressure will be maintained from 600 to 660. Fine, just remember. Fine. It is known as Carbon's cannula. This is what the next one, the cannula which we attach, it is known as what? This is the Carbon's cannula. Next, if you were to move few instruments, like who all have instruments, you can see it through. If you are able to see this non-traumatic type of scissors, they are what? They are this episiotomy scissors. Right? But they are what? They are this episiotomy because they are usually having this blunt edges to be non-traumatic. Next, this is what? This is the head dilator. These head dilators are used to pass inside the cervix to know how much it is being dilated. So in a case of incompetent cervix, we can use this and we can diagnose the condition of incompetent cervix. Fine. Next one, if you are able to see this type of cup, it will be seen in a case of ovum forceps. Okay, to take this fetal tissue during suction or during dilatation and curettage. Okay, we'll use this and we'll take the tissues. Fine. Next one, it is the uterine curate. Okay, during this dilatation and evacuation, we'll curate the uterus with this. Okay. Next, it is what? It is the cuscous vaginal speculum, which will be what? Which will be the self-retraining. Okay, it will be self-retaining cuscous vaginal speculum. Fine. Next one, it will be what? Yeah, ovum holding forceps, it won't be having a lock. Correct. Kinds. Next one, this is what? This is the valcellum forceps, which used to grasp the cervix during any procedures. Fine. Next, you need to remember about this few forceps. Yeah, there's also one more image. I'll just add on. Okay, you need to just remember about this few forceps. Fine. If you're able to see this type of blade, okay, if you're able to this type of perineally curved blades, it will be seen in a case of Pepper's forceps. Okay, if you're able to see this small pelvic curve, if you're able to see this small pelvic curve, it will be seen in a case of Kellan's forceps. So if you're able to see this distinct perineal curve, it will be seen in the case of Pepper's forceps, whereas this small pelvic curve, it will be seen in the case of Kellan's forceps. Fine. Next one, you need to know about this outlet forceps. This is how this outlet forceps looks like. If you're able to differentiate these three types of forceps, it will be means like most of them they will be asked within these three types of forceps. Okay, so just don't forget about this orientations of this forceps. Fine. Next, if you're able to see this type of retractor, which is being used during the cesarean section. What is this name of this retractor? Yeah, moonlight. Yeah, we'll see this outlet forceps also. Yeah, Baisla. Yeah, it is known as what? Known as Dines retractor. It is known as what? Dines retractor, which will use to prevent any bladder injuries. Fine. Yeah, it means all look the same. Just see this curviness of this blade, okay, and this blade and this outlet forceps. You are able to see this distal blades. Okay, no, you try to differentiate. If means if you're not able to remember this, just try to see in the morning times. Okay, you'll be able to identify the differences. Fine. And next, this is how this Sims speculum looks like. Sims speculum looks like. Fine. Fine. With this understanding, we are concluding this obstetrics and gynecology. We are moving on to this. Yeah, it's the sim speculum. We are moving on to this pediatrics. And in pediatrics, it will be done in a few minutes only, like because there are few slides or few images which are being asked repeatedly. Fine. You're able to see what is this? This is what? This is an incubator. This is what? This is an incubator. And in incubator, you need to know the mechanism of heat gain and heat loss. If we see incubation, in the case of incubator, the mechanism of heat gain, it will be what? Absgyno. Yeah, it's done by Isla, finally. Yeah, it's in a NICU setup. Yeah, it's incubator. Yeah, no, next one I will show you the warmer. First one, it is the incubator, fine. The mechanism of gain, it will be what? It will be by this method known as convection. By this convection. Okay. Whereas the mechanism of heat loss, it will be by this radiation. Okay. Next one, it is the radiant warmer. It is the radiant warmer. Okay, and this main mechanism of heat gain, the heat gain, it will be by this thing known as radiation, and loss here it will be by this convection. Okay, convection. Next, we will be able to see this therapy in which the baby's eyes and this scrotal regions are being covered. It will be what? It is what is this thing? It is known as phototherapy. It is known as phototherapy. And we know the most common mechanism of this phototherapy, it is what? Mechanism phototherapy is what? It is the most common mechanism by it to act. It is what is known as what? Structural isomerization. Structural isomerization. It will convert this lumirubin, means like bilirubin, into this variant known as lumirubin. Okay, bilirubin into means unconjugated bilirubin into this lumirubin. Okay, remember. Okay, yeah, means there will be a structural isomerization also. There will be a optical also, but mainly it will be the structural isomerization. Just remember. This is how this neonatal resuscitation which is being done, and we know it will be for in a case of neonatal resuscitation, like there will be a three chest compression and a one breath. Okay, 3:1. It is done in a ratio of 3:1. Just remember. And mostly in a case of infants or newborns will use around 250 ml of will use amber bag which is of 250 ml. Like cans 30 is to 2, sorry, 30 is to 2, it will be for the adults. Just remember. Fine. For adults it is 30 is to 2. Whereas in the case of infants and children, it will be a 3:1. Fine. And next, there are some transient conditions you need to remember of. Fine. Yeah, correct. Full moonlight. Yeah, you are getting it correct. In in the case of there will be few transient conditions. This is known as what? Erythema, toxica. And next, if you are able to see some this type of pustules, it is known as pustular melanosis. Pustular melanosis. Okay. And this one, if you are able to see this type of appearance, which is what is this one? No, milia I will show you. It's not milia. Don't confuse it with milia. Fine. The third one, it is not hemangioma. They will. What is this? No, it is not hemangioma. Third one, guys, don't confuse. Yeah, third one, it is not hemangioma. Hemangioma means it's a benign blood accumulation, benign blood neoplasm. Okay, fine. So it will be a bulging out, means it won't be a flat like this. Okay, it will be bulging out. Fine. So this is a kind of stain. Okay, yeah, means it's around the port vein, but it is known as what? It is known as salmon patch. It is what? It is known as salmon patch. You'll able to see this port vein stain in a case of, that is a different one that is we see in a case of Sturge syndrome. Whereas this is known as salmon patch, also known as stalk bite, also known as angel's kiss. Okay, they will have this multiple names for the same thing. It is known as what? Salmon patch. Just remember. Next, you're able to see this type of acne kind of appearance known as neonatal acne. Okay, and then if you're able to see this type of appearances of this type of small lesion over this palate, it is known as what? Epstein Epstein piles. It is known as Epstein piles. Just remember, it is known as Epstein piles. Fine. With this understanding, we'll move on to the next part. If able to, for identification of this gestational age, we'll use this type of sign. Known as this type of sign is known as scarf sign. Okay, scarf sign, because we use the system known as extended Ballard scoring for to know this exact gestational age of this child. So, in which a part is this scarf sign. Fine. Next, this is what? This is known as was Palladai theory. Okay, Palladai feeding. This is which is being done here, and there is also one more type of feeding which is known as Katori spoon feeding. Okay, just remember. Fine. Yeah. Then this is how this NG tube, nasogastric tube, which we use if the initially, means if it is less than 28 weeks, we'll use total parental nutrition, because there will be a immature gut itself. So we'll give total parental nutrition. If it is around 28 to 30 weeks, the gut will be mature, but the swelling reflex won't be developed properly. So at those moments, we'll use this between 28 to 30 2 weeks. Okay, we'll use this NG tubes. Whereas around this 34 weeks, the baby goes swallowing, but the rooting reflex, because when they touches this nipples, means around this when they touches this nipples around this 34 weeks, there will be no rooting reflex. Means the baby won't turn, and they won't start sucking. So we use this type of feeding known as Palladai feeding around this 34 weeks. Okay, if it is more than 34 weeks, the baby can feed itself, because the rooting reflex will be developed. Okay, so don't worry. Fine. With this understanding, we'll move on to this next part. Yesterday also we saw this. This is what is known as Shakir stick. It is known as Shakir stick. Next, if you're able to see this type of fluid accumulation in the lobar fissures, or this fissure sign, All this sun ray appearance. Sun ray appearance. Were you able to see the sun ray appearance? The correct full moonlight, correct location. Were you able to see the sunlight appearance? Yeah, guys. This will be seen in a case of condition known as transient tachypnea of newborn. Means like most commonly it is seen in a case of cesarean section delivery, because in a case of normal vaginal delivery, the baby's chest will be pressed and whatever the fluid inside the lungs, it will be come out. Okay. Yeah, correct by slide is the TTP. Fine. And if you're able to see this kind of white out or this GGO or this white out lung fields, it will be seen in a case of respiratory distress syndrome. Okay, it will be seen in a case of respiratory distress syndrome. Correct full moonlight. Next, if you're able to see a baby which is being or the newborn which is being recently delivered, and if you're able to see this type of scaphoid abdomen, okay, along with some respiratory distress, and an image you'll be able to see this type of hyaline membrane disease. It is also known as correct. The respiratory distress syndrome, it is also known as hyaline membrane disease. And if you're able to see this type of bubble loop shadows inside the thoracic cavity, it will be what? It is the correct Gopinath, it is known as what? Congenital diaphragmatic hernia. And we know the most common type of this congenital diaphragmatic hernia. It is what? It is known as what? It is the Bok-Delix type of. It is the Box-Delix type of hernia. Okay. It is the most common type. It is most commonly at the left posterior membrane defect. Okay. Just remember. Yeah, correct. Hence, Bisla, full moonlight. Yeah, correct location, correct area. Yeah, it is what it is the Bok-Delix one. Next, if you able to see this type of, if an infant or a newborn which is being is being feeded by this from the external sources for a long time, okay, or aggressive formula feeding, it can result into this condition known as nectarizing enterocolitis. And in nectarizing enterocolitis, you need to remember these two signs, okay, in these two stages like 2A and 2B. 2A, it will be having this gas, means it will be having this gas in between the bowel lobes, okay. Yeah, Morgagnis will be the anterior and right. Yeah, correct full moonlight. Yeah, correct location, correct Gopinath. And if you're able to see mm, this gas in between this bowel loop, it is known as what? It is the it is stage this NEC stage 2A. Whereas stage 2B, there will be presence of gas inside this like portal vein. There will be presence of gas in the portal vein. Okay, just one more. And next, some cardiological malformations. If you're able to see this figure of 8 or the snowman appearance, this will be seen in a case of which condition? Yeah, correct. Rian full moonlight. Yeah, this figure of 8 or snowman appearance, it will be seen in a case of correct Ravat and Ria. It is what it is the TAPVC, like mostly of a supracardiac variant of TAPVC. Next, if you're able to see this type of egg on string appearance, will be seen in a case of which condition? Yeah, it will be seen in a case of transposition of great arteries. Next, if you're able to see this type of formation of three appearance, or this three appearance, and along with this notching of the ribs, this will be seen in a case of coarctation of aorta. Okay, notching of ribs will be seen in a case of coarctation of correct. Yeah, correct Khan. Yeah, correct Baisla. Yeah, correct Kans. Fine. Next, if you're able to see this type of boot-shaped heart, it will be seen in a case of tetralogy of Fallot. And remember, the severity of this tetralogy of Fallot, it will be decided by which of the following? It will be decided by this pulmonary stenosis. It will be decided by this pulmonary stenosis. Okay. Yeah, correct by slide is the boot shaped heart. Okay. Yeah, car in boot. Yeah, correct Lokesh. Yeah, correct Gopinath. Correct by slide. Fine. Next, we'll move on to the next part. If you're able to see this open box appearance, okay, this will be seen in a case of Epstein anomaly, and most commonly they will be associated with pre association with this lithium intake. Okay, lithium intake during the pregnancy. Yeah, correct. Correct full moonlight and correct Ria and Baisla. Yeah, correct. Fine. That is lithium. Next, if you're able to see this type of next, if you're able to see this type of um, anterior neuropore defects, where there is any absence of this clavarium, it is what? It is the anencephaly. Anencephaly. Okay, it is due to this failure of closure of this anterior neuropore. Next, if you're able to see some mass at the sacral region, it will be what? It is the sacrococcygeal. It is the sacrococcygeal teratoma. This is sacrococcygeal teratoma. Yeah, correct Gopinath. Yeah, correct location. Dr. Khan. Yeah, it's correct. Next, if you're able to see, yeah, it's not encephaly, Dr. Khan, it is anencephaly, right? Next, if you're able to see there is an absence of this neck. If there is an absence of neck, it is known as what? Absence of neck, it is known as anencephaly. It is known as anencephaly. Just remember, it is known as anencephaly. Yeah, correct. Now it's correct, Dr. Khan. Yeah, correct. Then we'll move on to some part. If you're able to see a child who is presenting with a history of chronic diarrhea, and along with you will able to see some history of chronic diarrhea. Okay, along with this, you will able to see rash along this orifices, and there is a acrodermatitis also. And dermatitis along this hands. What you will think of? Yeah, it is think of, don't confuse it with impetigo and hand foot mouth disease. It is what? It is our classical. It is what? The classical zinc deficiency. Acrodermatitis. So classical zinc deficiency. What is this disease known as? Guys, what is this disease? The name itself tells it is known as acrodermatitis. Acrodermatitis enteropathica. Okay. Okay, it's known as acrodermatitis enteropathica. Correct, full moonlight and Nitin. Okay. And next, if you're able to see a child who is sitting in a lateral, and this child belly, you'll be able to see some edema. So if you draw this K, you'll be able to draw this edema, belly edema. So if you're able to see this belly edema, along with this flaky paint dermatose, flaky paint dermatosis, along with the sign known as flag sign. Okay, flag sign means there is a alternate black and white, kind of appearance, which is known as flag sign, which will be seen in a case of kwashiorkor. So all of these things will be seen in a case of kwashiorkor. Okay, remember, yeah, kwashiorkor. It's mainly a protein deficiency. Correct, Lokesh Baisla. And next, in a case of, we know, in a case of marasmus, there will be a baggy point appearances. Okay, there will be monkey faces. Just remember, fine. Next, when we look on to this deficiency, it means most of these things you need to differentiate from the X-ray. They'll give it this child with the X-ray. It is the features of these three classical features, which are known as CSF features. Okay, there will be a cupping. You'll be able to see this formation of this cup, which is known as cupping. Next, if you're able to see, there is a splaying, and there is a fraying also. So, if you're able to see this cupping, splaying, and this fraying, all of this will be seen in a case of which condition? All of this will be seen in a case of rickets. All of this will be seen in a case of rickets. Yeah, correct, Gopinath, Baisla, and full moonlight, and Kans, Ria, you are getting it correct. It is due to the deficiency of vitamin D leading to this rickets. Okay, correct. Next, we will be able to see this type of ring formation. And there is some periosteal hemorrhages. Periosteal hemorrhages mimicking a pseudo paralysis, and you will able to see this white line of fruncles. Means you'll able to see this type of lines known as white line of fruncles. All of this will be seen in a case of scurvy. Okay, all of this will be seen in a case of scurvy, which is due to this vitamin C deficiency. Fine. Ring epiphysis is known as Wimberger's ring, and next it is known as, it will be having this white line of fruncles. Okay, yeah, correct, Nitin. Sai, yeah, correct, you're back. Yeah, correct, Baisla and Khan. Yeah, it will be seen in the case of scurvy, which is due to this vitamin C deficiency, because we know vitamin C helps in this collagenation. Fine. With this understanding, we'll move on to the next part. If you're able to see, there is this formation of these milestones. Okay, initially, these milestones, they will progress from the in a cephalocaudal progression. Fine. Okay, in a cephalocaudal means they will start from this head, and they will go and they will progress towards the toe. Fine. And initially, if you're able to see, initially the child will start to hold his neck. Okay, it is known as neck holding. It will come around this 3 months. Okay, the neck holding will be around the 3 months. Next, if you're able to see, once it's hold the neck, it will try to roll over. Next, remember, on 6 months it try to sit. Okay, on 6 months, yes for yes, it will sit, but it doesn't sit simply. It will be sits, it sits with support. Okay, whereas around the 8 months it will be sitting without support. 9 months it will be standing. Once it sits without support, of 9 months it will be standing. It will be standing without support. And 12 months means, sorry, it will 9 months it will be standing with support, and around 12 months it will be standing without support. Once it start standing without support, okay, around the 12 months it will start walking, but around 15 months it will be start walking alone, because it will initially around 12 months it will be standing without support but walks with some kind of support, whereas 15 months it will walks without support. Remember, 18 months it will start running. Okay, it will be start running around 18 months, so it will be running at 8 months. Okay, 18 months. Okay, and 2 months it will go up and down by this 2 feet. Okay, with 2 feet it will go up and down. Fine. And around 3 years it will go alternate feet just upstairs, means it can keep 1 feet here, 1 feet down. Okay, around 3 years, but it will be just going upstairs, it don't know how to come back. Around 4 years it will, means it know, means it can come down with alternate foot. And you can see around 4 years, if you draw this four, it's like standing in one leg, or also known as hopping. So around 4 years it will be a hopping. So just remember, in this part, say in this case, 6 months it will be a sit with support, 9 months sitting without support, and 12 months it will be means 9 months there will be a standing with support, and 12 months there will be a standing without support. Fine. Next, if you're able to see this fine motor milestones, around this 4 months there will be this bidextrous grasp. Okay, 4 months there will be a bidextrous grasp. Yeah, correct, Baisla? Yeah, around 6 months there will be a S for S. It will be a unidextrous, means single hand, so it will be a unidextrous grasp. And around 9 months there will be immature grasp, and 12 months it need to cut the cake. So it need to cut the cake, so it will have this mature pincer grasp. Okay. Yeah, there will be two things, craveling and creeping. So craveling comes first, followed by this creeping. Yeah, yeah, correct, guys. Fine. Next, around 18 months, it will start scribbling. Okay, and it will draw some lines. And around 15 months, it build two blocks. And around from 18 months, it build three blocks. And whatever it is, whatever the next upcoming year, you can multiply with three. So around 2 years, it will build a blocks of 6 blocks. Fine. Just remember these few things, and we know there are few drawings it can make. Around 3 years, it can draw a face, okay, and ears. So remember, around 3 years, it can draw a circle. Then on the neck, it will wear a cross. So around 4 years, it can draw a cross, and around 4.5 years, it can draw a rectangle, and around 5 years, it can make a skirt. So it is around 5 years it can draw a triangle, and around the 6 years it can draw this rhomboids. Okay, just remember. Yeah, correct side. Like around 4 years it will make this cross. Okay, just remember. Next, if you're able to see, in the case of social milestones, you just remember at 3 months it will recognizes this mother, and 6 months, yes for yes, it will be a stranger anxiety. Okay, it will be having the stranger anxiety, and 9 months it will be waving the bye bye. Okay, and 9 months it will be waving this bye bye. Okay, and 18 months it will do this thing known as domestic mimicry, or copying the tasks of these parents. Okay, just remember. Okay, these are the things you need to know. Next, if you know about this language milestones, around 3 months it will cooes. 3 months it will be producing this cooing sound. Fine. And 6 months it will be a single, so monosyllables. S for S, it will produces this single or this monosyllables. And 9 months it produces this bisyllables. 12 months it can speak 1 to 2 words. Okay, like bisyllables like mama, papa. Okay, and 18 months it produces it can tell 8 to 10 words. And around 3 years it can know three things, their name, gender, and age. Fine. And 4 years they can tell you story. Remember, if four people, if they unite together, if you see four people means who are sitting together, then they will make some stories. So remember, at 4 years it can make some stories. And if you don't unable to remember all these things, it's okay. Fine, you just remember these three things, like which is being repeatedly tested. Fine. If you see a 6 year child, okay, means like, sorry, 6 months, 6 months, fine. Remember, yes for yes. If 6 month child, it is a single child. Remember, if someone is single, okay, single means it need to support. It means he should be having a support to sit. So remember, means he uses one hand to support and sit. Okay, so 6 months if single, so it will be sits with support. Okay, and if it is sitting with support with one hand, only one hand will be free. So it will uses this mobile phone, means or he or she will uses this mobile phone using only one hand. So she will be having this unidextrous grasp. Okay, as she is single, she or he, they won't talk to their boyfriend or girlfriend. So they will be talking to these two peoples who are what? Who are this ma and pa. So they will tell this monosyllable. They will use this monosyllable words. Okay, just remember, they will use this monosyllable words. And if they go to the family, like because after sometimes everyone, if someone comes new, they will come ask about their child's marriage. So he'll be having this anxiety known as far as they will be having this stranger anxiety. Okay, they'll be having this stranger anxiety. These are the things you need to remember about this 6 months. Next, if you're able to see this 3 years, if you see this 3 years, remember this it 3 for C, it copies a circle, okay, and it can write a tricycle, okay, tricycle, and it know three things. It know three things, which is what? Which is this age, name, and gender. Okay, age, name, and gender. Next one, it is the 18 months. If they will ask this 18 months, okay, remember 18 months, we know around 18 years we'll get free from everything. So we'll get free from our home. So remember, in our home, like we'll be living within a particular limit. So means will there is a drawn limit. So if there is a drawn limit means someone need to draw. So if means at 18 months the child able to draw a line, okay, or the draw a limit, and at 18 months it will crosses the line by running. So at 18 months it will runs, okay, at 18 months it will runs, fine. And if it runs out of the home, it need to do some tasks. Either it need to study, then it need to work, and it need to take care of herself, okay, or he or she, they need to take care of their self, fine. So if they come, they need to means around 2 to 3 pages it will turn, and it will study around 18 months. Next, it will go and build blocks. It can build blocks of 3, okay, it can build blocks of 3, and it can do a thing known as washing, like it can mimic their parents, like washing clothes, like washing the dishes, known as domestic mimicry. It can do around 18 months, it can do a thing known as domestic mimicry, okay, domestic mimicry. Just remember these things, okay. These are the milestones which are being repeatedly tested, so don't forget these things, and don't forget about this motor milestones and a grass motor milestones and the fine one, okay. These are the things they're asking in a more recent patterns, fine. Next, with this understanding, we'll move on to this ophthalmology part, fine. Once ophthalmology and ENT done, we'll have a short break, fine. And most probably we'll conclude this session today on time around 12:15 to 12:30, fine. If you see this image, okay, this is what is this chart? This is used to assess this visual acuity. Yeah, correct, Baisla. Yeah, okay, okay, Somesh, okay, Sai, fine. If you see this image, it is what? It is the Snellen's chart. Snellen's chart. Okay, this is what? This is the Snellen's chart. Fine. And what is this next chart? It's already written. It is what? It is the ETDRS chart, which is the most specific one, because you can able to see this angulations of this letters. So it is what? It is the ETDRS chart. Next, if you want to means do this visual acuity, you will go for these two charts. Whereas if you want to know this contrast sensitivity, then you will be able to do this chart. You need to use this chart known as Pelly-Robson chart. Pelly-Robson chart. Okay. Okay, there are also some other types of chart for visual acuity. For example, if some uneducated people are there, then we'll use this type of C known as landlord's rings. Okay, okay, landlord's rings also we will use, and then for children we'll use this pictures type of uh, charts. Okay, just remember. Okay, and this contrast sensitivity is being tested by this chart known as Pelly-Robson chart. Fine. Next, this is for color vision. We'll use this type of charts known as Ishihara chart. Okay. Yeah, Allen chart will use this picture which is being used for this children's. A correct, Robert. Fine. And this was what Ishihara chart. Ishihara chart. Okay. Means like either there will be written as letters we need to identify, or else they will ask us to identify this pattern. Means where it starts and where it's going ends. Okay. This is also Ishihara chart. Okay. Just remember. Next, if you able to see few instruments, in ophthalmology, we'll use few instruments. Initially, whenever the patient comes, initially we'll make them to sit in this system known as biomicroscope. Okay, biomicroscope. Okay, which is known as what? Slit lamp biomicroscope. So the slit lamp biomicroscope. Fine. And we know, yeah, Ishihara is for color blindness, and we know this slit lamp examination uses this slit type of rays, and we'll check mostly from this mostly from starting from this outer eyelashes to this anterior chamber. We can use this means anterior chamber to even the posterior chamber. We can able to visualize using this slit lamp, using its normal magnifications. Whereas to see this posterior part or this more defined posterior chamber, we'll use this 90D lens. So posterior part of this posterior chamber, to see this posterior chamber or the posterior part, will use this 90D lens. Next, if you're able to see, we'll attach a no, like, yeah, there is no such things. Okay, don't believe in that. Right? Then if you're able to see, okay, don't believe in this. Don't worry. Like the study, like exam will be happen on time. Okay, don't worry. Don't get biased. Fine. Next one, if you're able to see, yeah, yeah, don't worry. Like don't means like don't believe in those things. Like don't worry, your exam won't get postponed. Like you will be having this exam on time. Okay, just prepare yourself for it. Okay, don't worry. Fine. This is what this is the Goldman applyation tonometry. Okay, it is the Goldman applyation tonometry. Okay, which is what this is the gold standard tonometry method. Fine. Next one, this is what this is the direct tonometry, means like direct ophthalmoscope, in which you will able to see this 15 times magnified view of central retina. Okay, central retina. Okay, and this one will produces this. Which type of image does it produces? Yeah, admit card will be issued on 15. It will produces this virtual, erect, and a magnified image. Okay. Next one, you'll be able to see this is what this is the indirect ophthalmoscope. This is how this indirect ophthalmoscope looks like. Fine. And for this indirect ophthalmoscope, we'll use this plus 20D mirror. Fine. And it produces 5 times magnifications. And with this, we'll able to, yeah, means the patient will be at this arm length of the arm length. Fine. And it will be a, and here you will able to see this inverted images. Fine. You will able to see this inverted, but this real images, real and magnified image, a correct size, correct bisla. Fine. You will able to see in the case of indirect ophthalmoscope, and you will able to see this borders of this retina, which is known as what, ora serrata. Fine. Next, this is what this is the gonioscope, which is used to know this angle of this eye, to know whether this angle is open, to differentiate between this open angle glaucoma and this closed angle one. Yeah, correct. Yeah, correct location. It is the gonioscope. It is especially what it is a 1, 2, 3, 4. It is a 4-mirror gonioscope. Okay, just remember it is a 4-mirror gonioscope. Next, if you able to see some other methods for eye measurement, this is what this is known as was tonopin. Okay, which is used for irregular corneas. Irregular corneas. Fine. Next, you able to see this is what this is known as what rebound. This rebound tonometry, it will be used for this rebound tonometry. It will be used for self use. Okay, self measuring. Next, you able to see this Placido's disc. Yeah, correct, Somesh and Baisla. Lokesh, yeah, correct. You are getting it correct. Next, you able to see this one. This one is the Placido disc, which is means which is used to see this corneal curvature. Corneal curvature. Okay. Yeah, correct. Location, it is used to see this corneal curvature. Next, if you will be able to see this test, which is used to see this tear breakout time, it is not Schimmer's test. Schimmer's test, which is used to identify this dry eye. Fine. Yeah, correct, guys. Next, this is a stain which is also used for this Sika, means the dry eyes, which is what, which is this rose Bengal stain. Okay, rose Bengal stain. Okay, it is known as what, rose Bengal stain. Yeah, correct, Gopinath, correct, Somesh, correct, Baislas. It is what it is the, in the previous one it is the Schimmer's test. Next, we are able to see this image. Okay, this image, in which if the patient is complaining or coming with some history of any trauma to the eye or any aberrations or something, some sand has been went into his eyes. So on OPD basis, you will able to just do a stain on a fluorescent stain, and you will able to see this aberration marks. So in a case of slit lamp, you can be able to see this to appreciate this type of corneal aberration. You will be able to see. You will use this test known as fluorescent test. You will be able to do this stain known as fluorescent stain, and you will be able to see this corneal aberrations for this corneal aberrations. Fine, just remember. Yeah, correct. Khan. Next, these are these muscles of this eye. Like there are 7 extraocular muscles. Okay, there are medial rectus, lateral rectus, superior and inferior rectus, whereas lateral rectus will be supplied by this 6th cranial nerve, and there will be inferior oblique and superior oblique. Superior oblique by this fourth cranial nerve, whereas others will be supplied by this third cranial nerve. Fine. And there is also one more muscle known as levator palpebrae superiors. Fine. Yeah, correct. Gopinath, Lokesh, Baisla. Yeah, correct. Fine. And if you're able to see, if you're able to see, the patient is unable to abduct the eye. If there is no abduction, then means the patient will be typically presenting, and history they will be given as like eye in and face out. Eye in and face out position. This eye in and face out position will be seen in a case of sixth nerve palsy. Okay, sixth nerve palsy. Okay, which is what this is the LR palsy. Okay, it will be seen in a case of canal of sixth palsy. Yeah, correct Sai, correct Gopinath, correct Lokesh, correct Khan, and correct. Fine. Next, if you're able to see, if you're able to see, means this eyeball which is being rotated out and on the lower aspect. Okay, and the patient also having these features of ptosis. As he is having these features of ptosis, then that only the examiner is lifting his eye. Okay, eyelid. So it will be this due to this involvement of which cranial now. Yes, yes, Somesh, correct. Yeah, Khan, yeah, yes, I. It is what is the involvement of third cranial nerve. It is the involvement of this third cranial nerve. Okay. Whereas remember, in a case of fourth cranial nerve, like there will be, it will produce this less pronounced symptoms, and this eye will be moved towards the inner side, and the patient will be there. The history they will mention the patient unable to do means unable to go up and down in this using the or having some difficulties in using the staircase. Okay, there will be mention of this. Yeah, correct. Khan Baisla, Gopinath. Yeah, correct. Then if you are able to see this kind of, if you're able to see to identify this trophias, as a squint, you will do this type of test known as Hirschberg test, where you will able to identify this based on the location of this reflection. Fine. If it is away, it will be what? It will be the esotropia. If it is towards, it will be what? It is the exotropia. Means it will be the opposite one. Okay. Fine. Yeah, correct. Lokesh and the Khan. With this understanding, we'll move on to the next part. Okay. So you're able to see this type of cobblestone papillae. Along with this spots around this limbus known as Horner Tantar spots. Along with this there is a features of ropey discharge. What you will think of? Yeah, correct. Gopinath Lokesh, yeah. Sai, yeah, Baisla. It will be something you will think of this vernal keratoconjunctivitis. And we know this vernal keratoconjunctivitis, it is a which type of hypersensitivity reaction? Yeah, can be seen. It is a which type of hypersensitivity reactions? Yeah, guys, answer. Yeah, it is what it is the type 4 hypersensitivity reaction. No, sorry, it is not type 4, it is the type 1 hypersensitivity reaction. Yeah, Somesh. Yeah, it is not type 2, it is type 1. Yeah, Lokesh, it is correct. It is what it is the type 1 hypersensitivity reaction. Next, if you are able to see this type of pits, which are known as Herbert's pits, and this line is known as Alts line, and then there is a Sago grain follicles. Sago grain follicles. All of these things they are seen in a case of which condition? They will be seen in a case of correct. They will be seen in a case of trachoma. Okay, they will be seen in a case of trachoma. Remember, they will be seen in a case of trachoma. Yeah, correct. Sai, yeah, Lokesh. Yeah, correct. Yeah, we'll use this Fisto classifications starting from the follicles. Fine. Yeah. Yeah, correct, Praveen. It is the trachoma. Next, if you're able to see this formation of this Plichten nodules. Plichten nodules. It is what? It is the Flectonular conjunctivitis, which is what? Which is the deposition of this TB basically, or this superficial reaction of this TB, which is what? Which comes under this type 4 hypersensitivity reaction. Next. Okay. Yeah, safe strategy will use. Yeah, correct, Praveen. Next, if you're able to see this type of elastotic degeneration. Okay, elastotic degeneration of the conjunctiva. This will be seen in case of which of the following condition? Yeah, correct, Baisla. Yeah, correct, Gopinath. It is what? It is known as what? Pterygium. Yeah, it is on the nasal aspect. Yeah, correct. Yeah, for a more accurate answer. Yeah, and if you're able to see some kind of iron deposition over this pterygium, It is known as Stoker's line. It is known as Stoker's line. Just remember, it is known as Stoker's line, and this pterygium can result in the production of irregular astigmatism. It can produce this irregular type of astigmatism. Next, if you are able to see this type of ring-shaped ulcers, along with this means there is a history of contact lens users. What you will think of? Who is used to wash this contact lens on the water? What you will think of? Which disease you will think of? Yeah, correct. Sai, it will think of acanthamoeba keratitis. Acanthamoeba keratitis. Okay, you will think of acanthamoeba keratitis. Next, okay. And if you are able to see a single ulcer, if you are able to single well-defined ulcer, yeah, correct, Gopinath. Yeah, correct. Yeah, for treatment of this pterygium, we'll use this conjunctival grafting. Fine. Yeah, it is mainly because of this bacterial. It is because of this bacterial corneal ulcer. Okay, and the most common cause of this bacterial corneal ulcer, it is what? It is the Pseudomonas. It is the Pseudomonas. Fine. Next, if you're able to see this fuzzy margin, along with this formation of this is a big one. There is a formation of this fuzzy margin, along with this formation of this satellite nodules. Okay, this will be along with, there is a history of, yeah, characteristic, yeah, there is a history of mm, trauma with vegetative matter. This will be seen in a case of which of the following? Yeah, it will be seen in a case of fungal corneal ulcer. Yeah, correct. Yeah, Sai. Yeah, Gopinath. Yeah, Kainz. Yeah, Baisla. Yeah, Praveen. Yeah, Dr. Khan. Yeah, Somesh. This is a fungal corneal ulcer, and you will be able to see this type of deposition or this collection known as hypopia. Okay, hypopia. Okay, collection of this pus. This is known as hypopia. Next, if you are able to see this type of dendritic type of corneal ulcer, this will be seen in a case of which of the following? Dendritic, yeah, it is a dendritic ulcer, correct location. It is because of any viral, especially of HSV origin. Like mostly of HSV will cause this viral type of keratitis or viral corneal ulcers. Okay, just remember. Yeah, correct. Yeah, there will be decreased corneal sensation, so they will close this eyes, and when they open, there will be a huge trauma to this cornea. Fine. Yeah, correct. Baisla, Sai, and Kans. Fine. Yeah, cobalt. Yeah, correct. Yeah, this is the cobalt filter. Means when you use this slit lamp, there will be different types of filters. Okay, we'll use this filter known as cobalt filter. Okay, this is being asked in recent INSET exam. Fine. Next, if you're able to see this type of sign, which is seen on looking downwards, what is this sign known as? What is this sign known as? Yeah, guys. Yeah, the diagnosis you just made, it is what? It is the keratoconus. Conus. What is this sign is known as? Yeah, it is known as what? It is known as, yeah, correct, Gopinath, Kainz, and Somesh, Ruchika. It is what? It is known as what? Munsense. It's known as Munsense. Okay, and we know in the case of keratoconus, there will be a excessive curvature of this cornea, and this will lead to this production of this type of striae known as, what is the name of this striae? We'll able to see here. It's not Wilson. Remember we saw Wilson on yesterday's session, right? It is keratoconus. This produces which type of striae? This produces this Vox striae. Remember, it is a correct location. Produces this Vox striae. Okay, just if you flip this form this type of conus, and if you flip this, it will produce this Vox striae. Just remember, and there will be one more reflex will produce known as scissoring reflex. Okay, scissoring reflex, and there is, okay, just remember, it also produces one reflex known as scissoring reflex. Okay, yeah, yeah, Dr. Khan, yes, you are getting it correct. Next, even in the case of uveitis, we will able to see this collection of this capes along this triangle. What is the name of this triangle known as? It is known as arch triangle. It is known as arch triangle. Okay, it is known as arch triangle. This collection of this capes, it is known as what? Arch triangle. And if there is a large, if there is any granulomatous uveitis, it can produce this type of large capes known as, yeah, correct. It is correct. It is known as what? It is known as mutton fat capes. It is known as mutton fat capes. Yeah, Lokesh. Yeah, it is what? It is the arch line. Yeah. Yeah, there is two types of iris nodules you will be able to see, which is actually not shown here. There are basacus and Kopis nodules. Okay, fine. Next, if you are able to see on healing this uveitis, if there is any iritis or iridocyclitis, it produces this type of pupil, which is known as festooned pupil. Okay, this is known as what? Festooned pupil. Fine. And Yeah. Thank you, Afzal Malik. Yeah, I hope you are enjoying it. Yeah, fine. Yeah, this capiz will be seen in a case of anterioitis. Fine. And next, if you're able to see this type of like headlight in a fog appearance, this headlight in a fog appearance will be seen in a case of toxoplasmosis. It will be seen in a case of toxoplasmosis. Just remember, it is in the case of toxoplasmosis. And yeah, this anterioitis, it is most commonly associated with this ankylosing spondylitis, which is what, which can be associated with this means which is associated with this ankylosing spondylitis, which is is having this HLA association of HLA-B27. Okay, just remember. And this positivitis, just by this toxoplasma, will produce this appearance known as headlight in the fox appearance. Yeah, correct, Somesh. Yeah, correct, guys. Yeah, correct, Dr. Khan. Next, if you're able to see, if there is any cyclitis or iritis which is being healed, it can produce two complications. It can lead to this formation of synechi. If it attaches to this posterior part, which is this lens, it can lead to this condition known as posterior synechi. Okay, this posterior synechi can attach to this lens. It can result to this condition known as secondary cataract or this complicated cataract. Fine, it can result into this cataract known as complicated cataract, which is because of this diseases. Fine. Next, if you're able to see, come to these types of cataract, you will see this type of whitish around this whitish hue. You will be able to see this type of cataract, which is what, which is the mature cataract. And once this mature, it can become this hypermature cataract. And this hypermature cataracts are two types. Okay, this is what this inner cortex which is being liquefied. Okay, so that this nucleus which is being fallen down, it is what, it is the Morgagnian type of hypermature cataract. This is known as what, Morgagnian's cataract. Fine. And if you're able to see this type of cataract, this forming this having this maximum type of visual handicap, it is what, it is the posterior subcapsular cataract, which will be having this maximum visual handicap. Fine, just remember. Next, you're able to see this type of snowflake. Yeah, Gopinath, yeah, Somesh. Yeah, Sai, yeah. It can lead to this phagolytic glaucoma. Phagolytic glaucoma. Yeah, correct. Okay. Yeah. Yeah, yeah, Lokesh. Yeah, thanks. It is what is the snowflake cataract. Okay. It will be seen in the case of diabetes mellitus. Next, this is what? This is the Christmas tree cataract, which will be seen in the case of myotonic dystrophy. Next, if you're able to see this cataract, this is the sunflower cataract. Okay. Which will be seen in a case of Wilson's disease. Yeah, correct, Praveen. Correct. Um, thanks. This is the rosette cataract. Rosette cataract, which will be seen in a case of blunt trauma. Okay, blunt trauma. Remember. Next, if you're able to see this ectopia lentis, okay, if you see this ectopia lentis means dislocation of the lens because of this improper formation of this holding filaments. Yeah, wow. Thank you for this nice description, Somesh. Yeah, correct, correct, Gopinath. And next, if you're able to see this ectopia lentis and the superior-temporal, which will be seen in a case of Marfan syndrome. Okay, it will be seen in a case of Marfan's syndrome. Fine. Yeah, correct, Gopinath. Next, and during this cataract surgery, we need to stain the capsule. So we'll use this stain known as tryptan blue, and we'll use this forceps known as when we'll do this procedure known as capsulorhexis. For this, we'll use this forceps known as capsulorhexis forceps. Okay, just remember. Yeah, Dr. Khan, yeah, we're getting it correct. Next, if you're able to means we need to differentiate this cortex from the nucleus. So for that, will do this thing known as hydrodissection. Okay, hydrodissection to differentiate this cortex from the nucleus. Correct? Yeah. Next, if you're able to see, means to differentiate this part of this nucleus, we'll use this procedure known as hydrodelineation, in which you're able to see this glow. This glow will be seen in a case of hydrodelineation. Okay, try to differentiate this hydrodelineation from this hydrodissection. Okay, just remember, delineation means done in nucleus. Done in nucleus. Delineation means done in nucleus. Whereas dissection, it will be done from the capsule to the nucleus. Okay, just remember. Okay, don't get confused. Next, this after cataract surgery, there might be few complications. This is known as what? Erschling pulse this rings formation known as Somers rings. This is what this both of them will be this complication known as secondary cataract, also known as post-capsular opacification. Okay, post-capsular opacification. Next, sometimes we will able to see this accumulation of fluid inside this macula known as macular edema, known as Irwin gas syndrome. Okay, Irwin gas syndrome. Next, there are two types of IOL, means type of post-chamber IOL will place. There will be a unifocal type, and there can be a multifocal type. There can be a unifocal one, or there can be a multifocal one. Yeah, correct, Somesh? Yeah, correct. Yeah, will in a case of phaco surgery, we'll use this foldable IOL. Yeah, correct, Dr. Khan. Next, if you're able to see, these are the exudates. If you're able to see this type of hard exudates will be seen in a case of non-proliferative diabetic retinopathy, and you will be able to see this a kind of neovascularization, which will be seen in a case of proliferative diabetic retinopathy. And for this neovascularization, we'll use this. Yeah, correct. Sri Sai, CR we are upcoming. We are having in upcoming slides. Ruchika, just wait. Fine. In the case of proliferative diabetic retinopathy, we will be able to see this kind of neovascularization, and for this, there is a factor which is being responsible known as VEGF, vascular endothelial growth factor. To against this, we'll use this drug known as bevacizumab and ranibizumab. Okay, just remember these two drugs are remembered as bevafarani. Fine. Next, this is the soft exudates, which will be seen in a case of hypertension. Okay, for this type of neovascularization, yeah, a correct, Rushika? We'll use this type of procedure known as pan-retinal photocoagulation. Okay, we'll do this procedure known as pan-retinal photocoagulation. Fine. Next one, you are waiting for this image, right? This is what it is. It is the cherry red spot, which will be seen in a case of CR Vivo. Fine. You will be able to see this tomato splash appearance. You will be able to see this tomato splash appearance in case of CR Vivo. Okay, this is the pizza pie repair. Yeah, they are ophthalmic emergency. Yeah, CRAO, it is an ophthalmic emergency, correct? Yeah, correct, Sai Khan. Yeah, you are including with the answers. Yeah, Praveen and Ruchika. Yeah, it can be associated with some other diseases like Tay Sachs, name and pick. Okay, this cherry red spot, so it is non-specific one. Then this pizza pie type of retinitis will be seen in a case of CMV retinitis. It will be seen in a case of CMV retinitis. Fine. Next one. If you're able to see this pale optic disc along with this retinal pigmentation. Okay, this will be seen in a case of retinitis pigmentosa. Okay, retinitis pigmentosa. Fine, it will be seen in a case of retinitis pigmentosa. Yeah, it will be because of this CMV retinitis, which is because of a viral infection post HIV patients most commonly seen. It will be at the level of CD4 count less than 50. So to treat this, we'll use a drug known as valganciclovir. Okay, or ganciclovir. Okay, just remember. Yeah, correct, Gopinath. In the case of retinitis pigmentosa, we'll use this. We'll see this classical findings. Fine. Next, if you able to see this, if you able to see this retinal calcification, retinal calcifications will be typical for this retinoblastoma. Okay, just remember it will be typical for this retinoblastoma. Okay, yeah, correct, Dr. Khan. And next, if you are able to see this buphtalmos, along with these features of photophobia, blepharospasm, along with features of um, continuous lacrimation. Okay, all of this thing will be seen in a case of congenital glaucoma. All will be seen in a case of congenital glaucoma. Yeah, Dr. Khan, correct. Yeah, Rose. Yeah, it is the increased lacrimation will be seen in a case of congenital glaucoma. And we know in a case of glaucoma, the cup to disc ratio initially there will be around, it will be around 0.3. If it is more than 0.3, around more than 0.7. Okay, it will consider as this is a optic changes because of glaucoma. Fine, just remember. Then if you're able to see this streamy hard cornea along with vertically oval pupil, which will be seen in a case of angle closure glaucoma. This will be seen in a case of angle closure glaucoma. Yeah, correct? Yeah, it will be more than 0.7. And for this angle closure glaucoma, We'll do this procedure known as laser iridotomy. Okay, okay, to relieve this pressure. Fine. Okay, guys. For this optic changes, they'll be preceded means they'll be later on they'll be having this visual field defects. Initially, there is a blind spot, and initially around this there will be development of this paracentral scotoma. Initially, there will be development of this paracentral scotoma. Yeah, that will be because of this anterior shallow chamber, the angle closure glaucoma will have happens. Fine. There will be a paracentral scotoma followed by this nasal stepping. Okay, this one is nasal stepping. Around this nasal side, there will be stepping, and there will be a formation of this arcuate scotoma followed by this Bajoran scotoma, extended Bajoran scotoma. Fine. And there will be a tunneling of this vision, and then last there will be a complete vision loss. And last there will be a complete vision loss. Yeah, Rose? Yeah. Yeah, correct. Initially there will be arcuate, they can extend as double arcuate. Yeah, correct. The last to be the most resistant, it will be the temporal field. Fine. That's why able to see this temporal field is least affected, whereas this nasal stepping is the first one to be affected. Fine. Next, if you're able to see this child who is having this increased lacrimation, okay, increased lacrimation, and you will able to see this type of plaques. It will be due to this congenital dacrocystitis. Okay, congenital dacrocystitis. Okay, due to this congenital dacrocystitis, most commonly due to this nasolacrimal duct obstruction, most common at this valve of Hasner. Okay, most commonly at this valve of Hasner. Yeah, correct, Somesh. Yeah, yeah, correct. Yeah, correct, Lokesh. Fine. And we know initially we'll tell them to do massage, and if it is relieved, it's okay. If not, we'll do on first year on 1 year, and after 1 year, we'll do what we'll do. We'll do syringing first or the probing first. Yeah, it's waiting for your answers. Yeah, initially we'll do syringing followed by this probing. So okay, so after 1 year we'll do syringing, and after 3 years we'll do this probing, and the final one it will be the that means it will be the definitive surgery. If it is doesn't heal, it will do this definitive surgery and make it open into the middle meatus instead of inferior meatus. Fine, and this is the chronic dacrocystitis. Fine. Next, if you're able to see this thing due to this inflammation, it is what it is known as what style, also known as external hordeolum. Fine. Next, if you're able to see this inner swelling, it is known as what? It is the internal hordeolum. And we know external is because of this gland of Zeiss involvement, whereas here it is because of this Meibomian gland involvement. Meibomian gland involvement. Yeah. Yeah, Rose, it is a style and it will be painful. Yeah, correct, guys. Next, if you're able to see this chronic one, it is the what? It is what? It is the calizion. Okay. And this is what? This is the calizion clamp. Okay. And this is what? This is the calizion scoop which we are using to scoop out. Okay. Which is using to scoop out the contact. Fine. Yeah. It will be away from the lid margins. So it will be away from the lid margins, while it will be at the level of lid margins. Fine. Next, we will be able to see there are two things, which is what? If the lid is everted, it is known as ectropion. Okay. For which we do this Zomneski procedure. And if it is turned inwards, it is known as what? Entropy. This is ectropion. Okay. Just remember these two things. Fine. Next, this is what? This is the thyroid ophthalmopathy. Thyroid ophthalmopathy. And remember, this is in a case of thyroid ophthalmopathy. Yeah, correct, summation Weissler. Yeah, it is most common as the Graves' disease. And in the case of thyroid ophthalmopathy, the first muscle to be involved, it is the inferior rectus. The most common muscle to be involved, it is the inferior rectus. And we know, okay, the most common one, it is the inferior rectus. And there are different signs, okay, different signs, the Darlimple signs. Darlimple sign. Fine. And next, if you're able to see this teardrop sign, fine, this teardrop sign will be seen in the case of orbital floor fracture. Okay, orbital floor fracture, and they'll be having these features of die features. Fine, there will be a diplopia, diplopia, there will be a infraorbital anesthesia following by this, means eyeball they will go inside, so there will be a enophthalmos. Because why there is a diplopia? It's because, yeah, yeah, correct, Gopinath. Rose Baisla Somesh. Yeah, why there is diplopia? Because the inferior apex it will be trapped. Fine. Next we'll come on to few other pupillary signs. If there is a constricted irregular pupil, okay, okay, constricted irregular pupil, okay, which is which will be positive, means which will be positive for this um, like accommodation reflex, means accommodation reflex positive and the pupillary reflex absent. It is what? It will be suggestive of which of the following people? It's just a light showing. It is what? It's which type of people which will be having this constricted and irregular people. It is what? Yeah, correct guys. It is known as what? It is the Aryle Robertson people. Just a minute, guys. Yeah, fine. It is what? It is the Aryle Robertson people. And next, if you're able to see, if you're able to see this people, if you're able to see this pupil, you will able to see there is a enlargement, means there is a dilation. Okay, this type of pupil it is having this dilation. It is known as what? Unilateral dilation. Unilateral followed by a viral infection. It is what it is. Which pupil? It is known as what? Yeah, correct, Rose. Correct. Kinds. It is what? It is known as what? Aedes people. Pupil. Remember, Aedes people. It is seen in ladies. Okay, and this is what? This is the Aryle Robinson pupil. Okay, next one. Okay, if there is a relative afferent pupillary defect, it will be seen in a case of optic neuritis. Fine. And if you're able to see this kind of small ptosis, yeah, Aedes ladies, yeah, correct, guys. Aedes will be seen in ladies, correct. Initial gaming, if you're able to see this ptosis, and if you're able to see this constriction of the eyes, just this meiosis, okay. And if there is also anhydrosis, it will be seen in a case of Harness syndrome. It will be seen in a case of Harness syndrome. Just remember, it will be seen in a case of, yeah, myasthenia gravis. It will be bilateral, but here, if you're able to see, it is a unilateral one, so it will be typical for this Harness syndrome. And you will able to appreciate this is a normal people, this is a constricted people, so it is a meiotic people. Okay, just remember. Okay, don't get confused. Those, yeah, neurogenic. It is the third one. Next, in this image, you'll able to appreciate this visual field effect. In this, you just need to know just one, like one or two only, which is you need to differentiate. If you're able to see, if there is any lesion at this optic chiasma, it will produces this heteronymous type of anopia. Heteronymous anopia, which is known as what? So, which is a bitemporal heteronymous hemianopia. Just remember, it is a bitemporal and heteronymous, not the homonymous. Whereas others, it will produce this homonymous defects. Fine. This macula means if there is any occipital lobe involvement, if there is any occipital lobe involvement, it will produce this macula sparing type of visual field defect. Fine. Yeah, guys, hope you are getting it correct. And this is what, if there is any superior quadrilateral anopsia, it is also known as pie in the sky, which will be seen in a case of temporal lobe involvement, which is the damage to this temporal lobe fibers. Whereas this one, pie in the floor, will be seen in a case of parietal lobe, parietal fibers damaged. Okay, just remember. Yeah, correct base law, Lokesh, I were getting it correct. Fine. Yeah. Next, if you're able to see, if both of this thing, if both of this light, if they are falling into the same axis, then it is just a myopia. But if there is a two different axes, if they are falling, then it will lead to this type of visual field defect. They are known as what? They are known as astigmatism. Okay, they are known as astigmatism. Fine. And there are few other visual means there are few other defects. Like for example, in the case of myopia, which type of lens we use? Yeah, guys, which type of lens will use in the case of myopia? Concave lens or a convex lens? Yeah, myopia, we know it is a nearsightedness. Fine. Okay, for this we need to make this race, means like we know we will see just the near one, we won't, means we'll see just the means we will see the near one, sorry, like it is known as nearsightedness because, and we use this concave lens so that to spread this waves which are being formed, means coming from the far, okay, from the far part, means from this far vision which are the lights coming, we will use this concave lens and will make them to divert. So we'll use this concave lens in a case of myopia, whereas we'll use this convex lens in a case of hypermetropia or hyperopia. Okay, just remember. And if there is any change in the axis, so it will be known as astigmatism. Okay, there are different types of astigmatism. There might be a simple one, there might be a complex one. A correct basal and rose, yeah, correct. Fine. With this understanding, we'll move on to the ENT part, and after ENT, we'll take a break. Fine. Fine. This will be a means will be more 10 minutes, like around 10 to 15 minutes. We'll take the ENT and we'll have a break from 10 o'clock. Fine. Is it okay, guys? Yeah, okay, boys. Yeah. Yeah, okay from your end. Fine. Then we are moving up. Yeah, correct. Okay, Sonam. Okay, sorry, so much. Fine. And in here, in external ear, yeah, okay, yeah, kinds. In external, you need to know this nerve supply. Nerve supply means if you hold your ear like this, means if you hold your ear like this, means this anterior part and the posterior part and this angle of this mandible, all of these three, it will be supplied by this nerve which is known as greater auricular nerve. Okay, this lobule, it will be supplied by this greater auricular nerve. Just remember, and this angle of this mandible, it will be supplied by this greater auricular nerve. Okay, the posterior surface, it will be supplied by this lesser occipital nerve, and here the anterior superior part of this pinna, it will be supplied by this, auriculotemporal nerve. Okay, whereas this near to this external auditory canal, it will be supplied by this branches of this 10th cranial nerve. Okay, these are things you need to know about this nerve supply. Next, if you be able to see, this is how this otoscope looks like. Means until like ophthalmoscope with a different magnifications, this otoscope will be having a single magnification, just remember. Fine. And we know it's um our external canal, it's not a straight canal, so we need to, yeah, correct, yeah, correct, guys. like no, it's not gan, it's auriculotemporal nerve which is being damaged during this period surgery. Okay, like, yeah, okay, just remember. And next, yeah, GAN also can be get damaged. Like that's why they will tell, like during shavage, during shaving, he won't able to feel these um sensations over this angle of mandible. Okay, fine. Yeah, we need to, means, so for otoscopic examinations, we need to pull this ear upwards and outwards. Okay, just remember, we need to pull this ear upwards and outwards. Fine. Next, we'll move on to some external conditions. Fine. Yeah. Yeah, there is also syndrome known as, in which if there is an involvement of this ATN, it can lead to this cross innervation. Okay, and it can lead to the syndrome known as Free syndrome. Fine. Yeah, yeah, correct, correct, correct. Ravat. Fine. If you're able to see this type of ear, it is known as what? It is known as cauliflower ear. Okay, cauliflower ear, which is actually what it is the, because of this repeated trauma, it will lead to this pinna perichondritis. Yeah, perichondritis. Okay, fine. Next one, if you're able to see just this inflammation over this ear, it is what? It is the otitis externa. Okay, and if you're able to see this otitis externa, along with this formation, of this mycotic or this mycotic air inside, it is what? It is the otomycosis. Okay, if there is any external otitis externa along with otomycosis, it is known as what? It is known as Singapore ear. It is known as Singapore ear. Okay, it is also known as swimmer's ear. It is also known as swimmer's ear. Okay, whereas this exostosis, it will lead to this type of ear known as surfer's ear. It will lead to this ear known as surfer's ear. Next, if you're able to see this thing, there is a chronic ear discharge along with this formation of this granuloma, and there is a history of diabetic patients. So this is what? This is which type? What is the name of this otitis externa? Yeah, guys, it is known as malignant otitis externa. And the causative organism, it is what? It is what? It is the Pseudomonas. Okay, this is the pseudomonas. Fine. Yeah, guys. Yeah, Baisla. Yeah, Rose, you are getting it correct. Next, if you see, this is how this normal tympanic membrane appears, and this is the normal cone of light. And we know in right here, it will be at the level of 5 o'clock position. It will be level of 5 o'clock position. Okay, fine. Next, if you able to see, this is the retracted tympanic membrane, how it looks like. Next, this is the tympanic membrane perforation, like mostly because of this chronic CSOM. Yeah, 5 at the level of right at the level of 5 o'clock, left at the level of 7 o'clock position. Correct, Lokesh? Fine. Next, we able to see this irregular perforation of the tympanic membrane along with this some bleeds. So it will be representing of traumatic tympanic membrane rupture, and management will use for management will you do this conservative management. We'll do this conservative management. Next, we'll insert this type of sorry. Okay, for any of this in a case of ASOM or in some conditions of glue here, we'll use this instrument which is known as what? Which is the grommet. Okay, we'll insert this thing known as grommet. Fine. Next, if you're able to see in the case of ASOM, if there is an accumulation of this pus and it will produce this type of bulging out tympanic membrane known as, along with this visible vessels, it is known as what? Cartwheel appearance seen in the case of ASOM. And next, this is what? This is the tympanic membrane perforation. Okay, and leading to this means and starting of this ossicular getting eroded. Fine. Yeah, acute SOM. Correct, Rose. Fine. Next, you are able to see this white mass begin this intact tympanic membrane. Intact tympanic membrane. This will be seen in a case of congenital cholesteatoma. This will be seen in a case of congenital cholesteatoma. Next, we are able to see this flamingo pink sign. Flamingo pink. Pink, it is known as what? Schwartz sign, and it will be seen in a case of otosclerosis. It will be seen in a case of which condition? It will be seen in a case of otosclerosis. And this represents the presence of an active disease. Okay, if it is there is an active disease, we can give sodium fluoride and we can treat the patient. Okay, correct baseline and correct dose. Fine. And next, you need to know just few things. This is how this normal ossicles looks, because sometimes they will ask you some most basic questions. This is how this stapes looks, and this is how this malus looks, and this is how this incus looks. Okay, incus will be having this broad one. So remember, this is the incus. Okay, don't get confused. Yeah, in a case of otosclerosis, you will get this AS type of cough. We'll see in upcoming slides there. Fine. Next, if you're able to see, if there's any just half of this ossicles are being eroded, we'll use this partial ossicular uh, prosthesis. Fine. Whereas if there's complete erosion, we'll use this total prosthesis, which is known as TOR prosthesis. Fine. Next, we'll do this type of tympanoplasty. Yeah, yeah, means like malleus in case it will be from this first arch, which is they are known as like Meckel's cartilage, whereas stapes it will be from the second arch. Fine. Don't get confused. Yeah, correct, Rose. Fine. Next one, if you're able to see this type of tympanic membranes, like if you just replace this tympanic membrane, it is known as myringoplasty. It is the type 1. Whereas in type 2 and type 3, there will be some ossicular damages. Okay, type 2 and type 3, there will be ossicular damages. You need to remember about this type 3. In type 3, okay, you will go and place this tympanic membrane or this tympanic membrane graft into this directly into the footprint of this stapes. Fine, fine. You just remember about this type 3 one. Okay, this will be enough for your exams. Okay, fine. If you're able to see this fluid levels along with these air bubbles means begin this tympanic membrane. In which one of the following conditions you will be able to see this type of tympanic membrane findings? Yeah, guys. In which condition you will be able to see these findings? Yeah, in the case of serous otitis media, also known as glue. Okay, glue. Fine. Okay. Next, you will be able to see some curves. Fine. Some curves will be, means like pure tone audiometry will be able to see. If there is, this is how this normal PTA graph looks like, and if there is any gap between this air conduction and bone conduction, it will be known as what? Yeah, correct. Mahir brother, you are correct. This is what this is known as what? AB gap, which is seen in a case of conductive hearing loss. Fine. And if you're able to see, if you're able to see dip in this both BC curve and AC curve, it will be what? It will be the sensory neural hearing loss. And if there is a dip at the level of 4000 hertz, it's because of this, especially because of this type of known as noise induced hearing loss. It will be because of this noise induced hearing loss. It's also a type of sensory neural hearing loss. Yeah, correct, Rose. There will be no AB gap. But if you're able to see, means there is a AB gap and there is a decrease in uh, like AC and BC also. So this will be seen in a case of mixed type of hearing loss. This will be seen in a case of mixed type of hearing loss. And if you're able to see just a dip in this bone conduction curve at 2000 hertz, it is known as which notch? It is known as Cohat's notch, which will be seen in a case of otosclerosis. It will be seen in a case of otosclerosis. Okay. A correct bacilla, a noise is hearing loss. It is at the 4000 hertz, known as Boyer's notch. Okay, it is known as Boyer's notch. Okay. Yeah, correct. Rose, it is known as Kahatsa. This one is known as Kahatsa. Next, this is how this normal curve appears. Okay. This is how a normal curve. Okay. Okay, if you're able to see this, how this normal curve appears. Whereas in a case of otosclerosis, this will produce a small curve. This will produce the small type of curve. So this is what this is seen in a case of AS type of graph, which is seen in a case of otosclerosis. Next, if you see any ossicular disruption, this ossicular disruption produces this type of distant curve. This distant curve it will be produced by this. This distant curve will be produced by the ossicular disruption or like if there is any dislocation of these ossicles. Next, if you are able to see this type of normal A curve, which is around this means which is shifted to the left side, it will be seen in a case of which is known as the type C curve, which is will be seen in a case of Eustachian tubal obstruction or any retracted tympanic membrane. Fine. Next, if you are able to see this type of flat curve, which is known as what? Which is known as type B graph, which will be seen in a case of if there is any fluid accumulation in a conditions like blue ear. Fine. And this is what this is the type C curve, which will be seen in a case of retracted tympanic membrane or any Eustachian tubal obstruction. Fine. And next, for child, yeah, okay, congratulations means like all the best for your first attempt, Mayur. Okay, don't worry, like you will come with flying colors, and everyone who will be means attempting the sessions, like I will be always wishing you to have a success ahead. Like I'm coming out with flying colors in this upcoming FMG exam. Okay, don't lose hope. Like it's just a few more days ahead. Like okay, don't think that everything is getting forgotten means you are forgetting everything. Don't worry, everything will be stored in your subconscious mind. It will help you out in the exams. Fine, don't worry. Fine. There are two tests we'll use to do. Like this is the bera. Okay, this is known as what? Bera. Okay, brain stem. Yeah, correct. Okay, so miss, yeah, nice to hear from you. Fine, this is what? This is the bera, which is the diagnostic tool or this confirmatory test for any um hearing loss in infants. Fine, we can use this screening tool known as auto acoustic emissions also. Fine, just also remember. But this is the bera one. And just remember this bera charts. Just remember about this fifth, which is the more prominent curve, which will be produced by this lateral lemniscus. Yeah, I remember you so much. Fine. And in the case of BPPV, you will able to do this two maneuver. Okay. One is known as this dix haplix maneuver, which consisting of these two parts. Okay. It will be having these two parts, which will be used for this diagnosis. Okay. Dix will be used for this diagnosis. Okay. Next one, which is this Epley's maneuver. Okay, Epley's maneuver, which consisting of 5 steps. Yeah, correct. FMG aspirant, it will be consisting of five steps, and those correct, it will be consisting of 5 steps, and it will be used for this treatment. Okay, for the management. Okay, just remember. Next, if you will to see, this is the ironed out mastoid, which will be seen in a case of mastoiditis. Okay, it will be seen in a case of mastoiditis. Okay. Next, you will be able to see means this is the HRCT, which will be saying the same. Means in the case of mastoiditis, you will be able to see this fluid accumulation. Yeah, which will be showing this acute mastoiditis. Correct, Ross. Correct, Baisla. Fine. And you will be able to see this contrast enhanced MRI. which is this gadolinium enhanced MRI showing this ice cream cone. Okay, ice cream cone appearance. Fine. This will be seen in a case of acoustic means like vestibular schwannoma, also known as acoustic neuroma. Okay, and if it is bilateral, it is most commonly seen in a case of NF2. It will be associated with this NF2. Just remember. Fine. Yeah, guys. Then we'll move on to few instruments. Fine. If you're able to see, this is known as what? Seagull's speculum. It is known as what? Seagull's speculum, which we'll use to know this test known as seagullization. Next, this is known as what? This is known as this Jobson harness probe. Okay, this is known as what? Jobson Horny probe. Okay, which is used to remove any foreign bodies, which is used to remove any foreign bodies in the EAC. Fine. Yeah, the most common cause of mastocytitis, it will be what? It will be the infection which is being tracking from the CSOM. Okay, it is the most common cause of mastocytitis. Okay. Next one, there are two forceps you need to remember. If it is a straight one, it will be what? It will be the Walsum forceps. If it is a curved one, it is known as what? Ash forceps. Okay, and Walsum's forceps it will use for this nasal bone reduction, whereas this Walsum forceps will use for will use for this cartilaginous part. Fine. Like there is no any specific organisms, it mostly the mixture of organisms, like mostly it can be a like pseudomonas origin. Okay, I'll just confirm in the break and I will let you know, Rose. Fine, but like what I remember is it is most commonly pseudomonas family. Once I will confirm and I will let you know. Fine. Then this is what this is. If you're able to see this type of electrode which is being placed in the brainstem, it is what it is known as what? Auditory brainstem implant. Fine. This is known as what? Auditory brainstem implant. Next, if you're able to see, this is what? This is the laryngoscope which we are using, which is the McIntosh type of laryngoscope. Next, this is what? This is the indirect laryngoscopic mirror, which is we are used to do for, which we are doing for this indirect laryngoscope. Fine. And we know indirect laryngoscopy, with indirect laryngoscope, we will not able to appreciate few structures like below the vocal cord and this anterior commissure, and below this epiglottis and this anterior commissure of this epiglottis. Just remember a few things. Fine. Next, this is what? This is which process? This is known as what? Bloom-Singer prosthesis. And this is what? This is the electrolarynx. Fine. And this is what? This is the BAHA, bone anchored hearing aid. Okay, this is the BAHA, which is known as bone anchored hearing aid. If there is an EAC atresia, you will be able to see there is no external acoustic canal. So if there is an EAC atresia, it is the indication for BAHA. Yeah, correct, Somesh? Fine. Then we'll move on to the larynx. If you're able to see, this is how this normal larynx looks like. Fine. If you're able to see this type of nodules, bilateral nodules. Okay, bilateral nodules between this anterior one third and the posterior two third, it will be known as what? It is the vocal nodules, also known as singers or screamers nodules. Fine. It is also known as singers or the screamers nodule. Next, if you're able to see this unilateral one, if you're able to see this unilateral one, it is what? It is the vocal polyp. It is the vocal polyp. Just remember, it is the vocal polyp. Fine. Next, if you're able to see this omega shaped epiglottis, which will be seen in a case of laryngomalacia. Laryngomalacia. Next, if you're able to see this mouse nibbled appearance, mouse nibbled appearance of vocal cord will be seen in a case of TB epiglottis. Okay. Next one. This is what? This is the respiratory papillomatosis. Fine. Yeah, it will be between this anterior one third and the posterior two third. Just remember. Fine. And this is this. Sometimes they will mark you this part, and they can ask you what is the means there is a fish bone which is being stuck over here, and which of the following nerve can be injured. Okay. Fine. The location will be mostly same. The nodules and the polyps location will be same. Whereas this nodules will be bilateral, whereas polyp will be unilateral in nature. Fine. And the most common nerve which is being injured here, it will be the internal laryngeal nerve. It will be the internal laryngeal nerve. Okay. Just remember these things. Fine. Next, if you're able to see this type of, there is a history of he's having by occupation. He's a trumpet blower, On examination, there is lateral extension. You will able to see some kind of air collection, and on pressing, you will able to see this like air which is being exiting known as by sign positive. This will be seen in a case of which condition? This will be seen in a case of laryngoscale. This will be seen in a case of laryngoscale. Okay, and we know there is a correct somesh, correct lokesh, correct Baisla. It is the laryngoscale. And next we are able to see within this muscle, which is this thyropharynges and this cricopharynges. Okay, between this thyropharynges and the cricopharynges, there is an area known as clearance area or clearance dehiscence. And this clearance area or clearance dehiscence, it can lead to this outpoaching structure known as Zenker's diverticulum. Okay, yeah, correct Praveen, and correct Baisla, correct Lokesh. Fine. Next, we'll move on to this phases. We'll able to see this typical phases where you will able to see this pinched nose, and there is a mouth breathing along with this pinched nose will be seen in a case of adenoid hypertrophy. Fine. Where else you will able to see this frog face deformity. Frog face deformity in a case of juvenile nasopharyngeal angiofibroma. Yeah, correct Logesh, Praveen, correct Neerpal. Fine. Yeah, it will be seen in the case of juvenile nasopharyngeal angiofibroma. And the artery which is being responsible, it is the sphenopalatine artery. Fine. And if able to see this anterior bowing of posterior wall of maxilla, it will be seen in a case of, the same juvenile nasopharyngeal angiofibroma. Just remember, it is known as what? It is known as Holman Miller sign. Okay. Yeah, correct Itpal and correct Praveen and correct Lokesh. Fine. Next, we are able to see if there is any uvula which is being having this edema, it is known as what? Quincke's disease. Whereas if there is any abscess if there is any abscess and which is being peritonsal abscess which is being pushing this tonsil towards the opposite side, it is known as quinsy. Okay, it is known as what? It is known as quinsy. Next, if you are able to see, there is a abscess inside, and along with this abscess, yeah, correct Praveen, correct Baisla, and along with this abscess, there is a outward swelling, and if there is any swelling inside abscess cavity and outside, this if there is two cavities, it will be what? It will be the parapharyngeal abscess. If there is any swelling inside and outside, it will be parapharyngeal abscess, and we know in a case of parapharyngeal abscess, the uvula will be in the midline. It won't be shifting to the opposite side. Fine. Next, if you are able to see, if there is any increase in this retropharyngeal shadow, it will be seen in a case of this increasing in this prevertebral shadow. It will be seen in a case of retropharyngeal abscess. It will be seen in a case of retropharyngeal abscess. Just remember. Fine. Next, if you are able to see this, just the below mandibular swelling, the correct location by Isla. If you are able to see this below mandibular swelling, it will be seen in a case of Ludwig's angina. Okay, it will be seen in the case of Ludwig's angina. Fine, just remember these things. Yeah, Quincy and Quincy, they are different. That's why just note like brought to your point. Quincy, remember, Quincy, it is a peritonsillar abscess. Whereas Quincke disease, you will able to see this uvular edema, it is what? It is the Quincke's disease. Okay. Okay. The small changes, will bring you a big drastic changes in your exam performance. So just don't forget these simple things. Okay, Rose? Fine. Next, if you're able to see this external nose, which is looking like a potato. So, or this also known as potato tumor. That is what it is. Which nose? It is due to which one? Yeah, it is what it is. It is due to the blockage of this ducts, which is leading to this condition known as rhinophyma. Okay. Next, if you are able to see this image, in which you will able to see this wide, roomy nasal cavity, along with this formation of this crusts. It will be seen in a case of which condition? Yeah, guys. Yeah, blockage in this sebaceous ducts. Yeah, correct. Praveen, Rose alpha. It is seen in a case of atrophic rhinitis. It is in a case of atrophic rhinitis. Yeah, correct. And this part is atrophic rhinitis. We'll do this operation known as modified Young surgery. Fine. It's combination of this both deformation of this external nose. It is seen in a case of rhinoscleroma. Okay, and there you will able to see this type of cells on these bodies. Okay, this they are known as Mikulicz cells and this Russell bodies. Mikulicz cells and Russell bodies. Okay, don't get confused. Yeah, atrophic rhinitis, we won't use a single drug. Okay, we'll use this. Will you give this cal means like sodium bicarbonate and this other means nutritious contents known as alkaline nasal douching. Okay, we'll do this procedure and we'll give nutrition to this mucosal layer and we'll make them grow. Okay, and so we won't give a particular drug. Okay, and we'll do this surgery known as modified Young's operation, in which will just means will close one nose and uh, will promote less airflow through this, so that it will get healed much easier. Okay, just remember. And if there is a history of trauma, and if you're able to see, this type of septal swelling, there is a history of trauma along with the septal swelling. Okay, this is due to the mhm, septal blood collections. Okay, yeah, sodium bicarbonate, sodium biborate. What? Okay, this is the septal hematoma. And we know in the case of septal hematoma, we need to do immediate aspiration of it. And if we means yesterday also we saw this is the rhinosporidiasis. Sporidiasis. Wow, okay. Yeah, correct Rosalfa, correct Baisla. Fine. Next, if you're able to see this image, yep, yeah, something is falling from this maxillary cavity. And on posterior nasal rhinoscopy, you'll be able to see some kind of mass. It will be what? It is the antroconal polyp. Okay, antroconal polyp, mostly it will be single. Okay, next. And an anti-rhinoscopy. This is what? This is the anti-rhinoscopy. Okay. And this is what? This is the Tudicum speculum. This is Tudicum speculum, which is used for anti-rhinoscopy. And an anti-rhinoscopy, if you're able to see this multiple polyps, which will be seen in a case of ethmoidal polyp. Okay, and this is how this nasopharyngeal carcinoma looks like. Okay, what is the origin of this nasopharyngeal carcinoma? A quick answer, guys. A quick check. What is this origin of this nasopharyngeal carcinoma? Yeah, guys, it is what? Yeah, it is the fossa of Rosenmuller. Yeah, correct, Rose. It is the fossa of Rosenmuller. Okay, Rosenmuller. Then just remember this triad you will be able to see here. Fine. Not distortion should be known as fossa of Rosenmuller. Next, it is this type of fracture which are known as this Leaford's fracture. Remember this Leaford's fracture, you just remember this Leaford type 1 means it will be separating this palate from the superior structure. So type 1, you just keep your one hand. It is the type 1 fracture. For this type 2 fracture, you just join these two hands and make this triangle. So if there is this type of fracture, if there is a triangular fraction, it is the Leaford's type 2. Whereas type 3, it is the craniofacial distension. So okay, it is the type 1, type 2 and the type 3. Okay, fine. And this is next one, it is the nasal bone fracture. This is the nasal bone fracture. Next one, if you're able to see, this is the nasal septal fracture. There are two types of nasal septal fracture. One is what? One is the jawway fracture. Next one is the chevlet fracture. This chevlet fracture, it is the vertical fracture, whereas this jawway fracture, it is a horizontal fracture. Okay, fine. This is known as what? This the jawway, it is this horizontal fracture, whereas this chevlet fracture, which is the vertical fracture. Okay, yeah. Type 2 and type 3, yeah, correct, Somesh. There is a type 2 and type 3, it can be associated with this feature known as traumatic CSF rhinorrhea. Fine. Next one, on base of this, okay, and at the floor of this orbit, you will be able to see this type of cells. Okay, there are some added cells to this paranasal sinuses. They are known as what? They are known as this Heller cells. Okay, on the floor it is known as what? Heller cells. And or if it is relation to this optic nerve, it is known as Onodi cells. If it is in relation to this optic nerve. Okay, and there are few views you need to remember. If you're able to see, This closed mouth along with this view, it is known as what? It is known as what? Water's view. Just to keep this water inside, you need to close the mouth. This is the closed mouth. It is known as water's view. If it is an open mouth, it is known as Pierce view. Okay. And if it is occipitomental view, it is what? It is what? It is which one? Which is it is known as Cardwell's view. It is known as what? Cardwell's view. Okay, it is known as Cardwell's view. Fine. Next, we'll move on to this. Just two more slides. Then we are done with the ENT. But then we'll have a good break. Fine. Yeah. Second one, it is the Cardwell. It is the Cardwell one. Fine. Next, if you're able to see this thumbprint appearance, okay, thumb appearance on a lateral chest, on a lateral spine X-ray. Along with this lateral neck X-ray, along with this there is a rising sun sign. All of this will be suggestive of which of the following conditions? Yeah, Lokesh, it will be suggestive of acute epiglottitis. Okay. Next one. This is what? This is the steeple sign. This is the steeple sign which will be seen in a case of croup or tracheobronchiolitis. Tracheobronchiolitis. Okay, this will be seen in a case of tracheobronchiolitis. Fine. Next one, you need to remember about this tracheostomy tube. Okay, this tracheostomy tube, if you are able to see, just you need to differentiate between these two tubes known as Jackson and this Fuell's tube. If you are able to see this Fuell's tube, it will be having this F type or this splitted one. So this Fuell's tube, it will be a flitted one and it will be having the two components, whereas this Jackson will be having this three components and it will be a complete tube. Okay. Next, these are the two types of plastic PVC tracheostomy tubes. This is the uncuffed one and this is the cuffed one. Fine. Next one. Remember this foreign bodies. You remember this esophagus. Remember, if you write this esophagus in this anterior view, you'll able to see this AP view. You'll able to see this complete coin. Okay, complete coin. It will be seen in the case of AP view. Fine. Whereas in the case of trachea, you will able to see this formation of slit. Yeah, cuffed is better than uncuffed. Means like it's based on the scenarios. For example, if it is a child, will prefer this uncuffed one. Fine. Whereas in adults, will use this cuffed one. Fine. Just remember. And one more thing is that for any chronicity, means like for any chronicity, we'll use this cuffed one. Fine. And this cuffed one, it will prevent this aspiration also. Yeah, correct, Rokesh. Yeah, Praveen and Somesh. Fine. Next one. If there is a patient who is presenting with this features of this vesicular eruption of this rashes along with this facial palsy. What you will think of? What is this condition you will think of? Yeah, guys. Yeah, Somesh. It is what? It is a classical. It is a classical feature of Ramsay-Hunt syndrome. It is a classical feature of Ramsay-Hunt syndrome. Next, this is the line which is known as Owen's line, which is being used for which of the following? Yeah, this is due to the seventh nerve, cranial nerve palsy. This Owen line which will be used for this identification, for this prognosis of this maxillary carcinoma. Okay. To know this prognosis, we'll draw a line from this medial epicanthus to this angle. Okay. Okay. So this line is known as Owen's line, which is used for this identification or this prognosis for this maxillary cancer. Okay. Maxillary cancer prognosis. Okay. Yeah, upper will be poor because it will be involving the structures like more sensitive structures of the side. Lower will be having a good prognosis. Yeah, correct, Somesh. Correct, Praveen. Okay, fine. And now we'll be having a break after this simple thing. Okay. Now till now means for this last 6 or 7 months you have been preparing for this exam day. On this exam day, don't get panic. Have a calm mindset because if you have a calm mindset, you will be halfway ahead. Means like your half battle has been won. So have a calm mindset, and for this rest of the few days, just revise superficially. Don't cramp up multiple things and don't give much stress. Okay, and have a calm mindset. Okay, and you will be absolutely coming with flying colors. Okay, and now it's exactly 10:15. We'll meet up at 10:30. Yeah, sure. Like the previous PDF, I will share in a break. Fine. Do you need this PDF in break? Because actually I don't have the access in the group to post. That's the issue. Yeah, Sujata. Means previous, I will tell them to post now. Fine. Means it will be around till 12:30. Fine. Yeah. It will be till 12:30. Like more 2 hours. Yeah, previous one I will tell. Yeah, sure. Yeah, I will tell them. Okay, fine. I see you after 15 minutes at 10:30. Hello guys. Hello. Mhm. Mm. Like for example, means it's not mobile, it's just struck. Mm. Mm. हाँ अभी कैमरा ओके और किया है और अभी आईपैड का भी कर लो एक बार. क्या मतलब? Hello. Hello, good evening, guys. Am I audible? Hello. Hello, guys. Yeah, actually, there was some small technical glitch. Okay, that's what we are working on. Yeah, sure. Yeah. Yeah, we are welcome back. And exactly around 2 hours, like less than 2 hours only, we'll try to complete it. Fine. And and we have lined up dermatology, surgery, and then followed by orthopedics. Fine. And if time permits, we'll do anesthesia. Okay. Okay, and this will be a plan, and without wasting much time we'll move on to that part. Fine. If you know if you see this anatomy of the skin, and you need to know about this few layers of the skin. Fine. Means, and in the basal layer, means in the basal layer we know there is this this cell which is known as melanocyte. Okay. Okay, and this melanocytes will be spreading their means dendrites along with this keratinocytes. Okay, and we know they'll be arranged in the yeah. Yeah, let's get sunburn. Yeah, Lokesh, yeah. Yeah, and if you see this keratinocytes and melanocyte, there will be one melanocytes for each 36 keratinocyte. Okay, just remember one melanocyte will be for this each 36 keratinocyte. Fine. And we know we studied this Langer-Hansel. Langer-Hansel, remember? Langer-Hansel's Langer for der. So Langer-Hansel will be seen in a case of derma, endermis, which is a means like epidermis, which is a normal cell. Okay. Well, whereas we know Langhans cell, which is seen in a case of TB, they are horseshoe shaped multinucleated giant cells. Okay, fine. This itself clear, I know. Yeah. Next one, yeah, Lokesh, yeah, you are identifying the next image. That is what is this? Tennis, tennis racket shaped granules, which are known as Berber granules, which are seen inside this Langerhans cell. So, if there is any Langerhans cell histiocytosis, we'll be able to see the abundance deposition of these granules. Okay, that's it. That we need to differentiate. Fine. And there is one of the marker. It is what it is. This CD107A. Okay. Sorry, no, sorry. CD1A and CD207. Okay, these are the two markers you need to remember about this Langerhans cell histiocytosis, are which it shows this Langerhans cells. Okay, with this understanding, we'll move on to the next part. Okay, and if you see, if there are few primary skin lesions and there are few secondary skin lesions. Okay, the primary skin lesions include include this nodules. Means if there is any there are two means there are two things. One is this known as papules, next one is known as nodules. If it is less than 5 centimeter and raised structure, it is known as papules. If it is more than 0.5 centimeter or if it is more than 0.5 centimeters and is raised, it is known as nodule. Means like more than 0.5 and raised, it is known as what? Nodule. If it is less than 0.5 and it is raised, it is known as papule. Okay, and if it is less than 0.5 centimeter and it is a flat lesion and a pigmented lesion, it is known as um, patch. Whereas if it is more, it is known as like less, it is known as macule. More, if it is known as patch. Okay, just remember. Okay, and if there is any pus inside, it is known as pustules. Okay, if there is any pus present, it is known as pustules. And we know wheals which are seen in a case of any allergy conditions, and it will resolve by its own. Okay, then there are some other conditions, like if you see some pinpoint bleedings. Okay, they are known as pinpoint bleedings, they are known as petechiae. Okay, whereas if there is any aggregations of this petechiae, it will lead to the formation of purpura. Okay, this is what this is purpura. Yeah, correct, Baisla. Next, if you'll see, there are some scaling lesions. There are some secondary lesions which include the scales. Okay, if you're able to see this fish scales, this type of fish scales will be seen in case of which condition? Yeah, Baisla. This is seen in case of which condition? We'll able to see this fish type of scales. Remember, this will be seen in a case of ichthyosis vulgaris. This will be seen in a case of ichthyosis vulgaris. Fine. Next, if you're able to see this greasy, greasy scales. Yeah, yeah, correct. Neurexin. If you see this greasy scales, okay, and the scalp, which will be demonstrating this seborrheic dermatitis. Okay, seborrheic dermatitis. Next, if you see some micaceous scales, okay, if you see some micaceous scales, this type of micaceous scales, it will be seen in a case of psoriasis. Okay, Yeah, correct. Yeah, correct, Lokesh. The seborrheic type of skulls, yeah, greasy skulls will be seen in a case of seborrheic dermatitis. Correct. Yeah. Mica skulls will be seen in a case of psoriasis. Fine. Next, some nail pathologists will look up. If you're able to see, if you're able to see this type of nails, this what it is, the clubbing. Okay, this one is what clubbing. Next, if you're able to see this type of spoon shaped, okay, spoon shaped nails, which is also known as what? Coilonychia. Coilonychia, okay, which is also known as spoon shaped nails. Okay, so we seen in a case of any iron deficiency anemia, and it is also associated with some other syndrome like Catterson-Pelli syndrome. Okay, just remember. Yeah, correct. Yeah, it is associated with this iron deficiency anemia and the post cricoidal webs. Okay, this can be associated. Next, if you're able to see this kind of ridge, okay, it is known as what? It is known as lines. It is known as lines. Okay, it is known as lines, and this lines are specific for which of the following diseases? A location neuroxin, a Baisla. The answer for this question. This is what? This is seen in a case of hand, foot, and mouth disease. This will be seen in a case of hand, foot, mouth disease. Fine. Next, if you're able to see this kind of whitish lines, it is known as Meese lines. It will be seen in a case of not lead poisoning. It will be seen in a case of arsenic poisoning. Okay, arsenic poisoning. Just remember, it is seen in a case of arsenic poisoning. Okay, yeah, correct, Baisla. Next, if you're able to see this type of degeneration, it is what? It is the pterygium. Okay, next, this is what? This is the pitting. This is the pitting. This is the pitting of nails. There might be a regular pitting, there might be irregular pitting. Regular will be seen in case of alopecia areata, whereas irregular will be seen in a case of psoriasis. Fine. Next, if you're able to see this type of half and half nails, they are known as Lindsay nails. They are known as what? Lindsay nails. They are known as what? Which nails? They are known as Lindsay nails. Yeah, Lokesh, correct. Yeah. Next, if you're able to see this type of sign, they are known as what? Oil drop sign. They are this type of sign known as oil drop sign, which will be typical for psoriasis. This oil drop sign will be seen in a case of psoriasis. Fine. Yes. With this understanding, we'll move on to the next part. If you're able to see, there are two types of effluvium, like anagen effluvium and tilagen effluvium. This tilagen, it is also known as tension effluvium, where you will get take tens when someone is pregnant. So, in a case of pregnancy, or in case of any chronic illness, okay, in such conditions you will be able to see this type of effluvium known as tinagen effluvium. Okay, whereas, okay, after any chronic disease or any diseases, fine. Whereas in a case of anagen effluvium, it will be after this chemotherapy. After this chemotherapy, you will be able to see this type of effluvium known as anagen effluvium. Fine. And there are we know alopecia areata. And if you're able to see, if there is any case of alopecia areata, means there will be a patchy hair loss along with this exclamatory mark. So there will be a patchy hair loss. Okay, along with there will be a patchy hair loss along with a, yeah, exclamatory mark sign of the hairs. Okay, just remember these points about this alopecia areata, and it is a autoimmune disease. Fine. And whereas others, like trichotillomania, because of this excessive hair pulling or this obsessive hair pulling disorders, okay, there will be a female pattern, there will be a central hair loss, whereas male pattern, there will be a side recession. Okay, just remember these things about this hair loss. Fine. Next, with this about this hair loss, we'll move on to some other conditions. Fine. And if you're able to see blockage of this apocrine sweat glands. We know there are two types of sweat glands, eccrine and apocrine, means eccrine sweat glands and apocrine sweat glands. If there is any blockage of this apocrine sweat glands, they can lead to this type of disease. Okay, apocrine sweat glands, they can lead to this type of disease. What is the name of this disease? This is known as Fox-Fordyce disease. Fine. And if there is any block along with this suppurative infection along with interconnecting sinuses, these will be seen in a case of what is the name of this condition? It will be, yeah, correct, Lokesh, rose alpha. Yeah, trichobazar may be there in a case of trichotillomania. Correct. Yeah, this type of suppurative infection along with interconnecting sinuses will be seen in a case of condition known as hidradenitis suppurativa. Okay, and these are the ectopic ectopic sebaceous glands on the lips. They are known as Fordyce spots. They are known as Fordyce spots. Fine. And if there is any blockage of this eccrine glands, it is known as what? This is known as milia. Okay. This is known as milia. Okay. Don't confuse this milia with this pustular melanosis. Okay. Just remember that. Fine. With this understanding, we'll move on to the next part. Few investigations you need to remember. This is what this. If you're using a glass light, yeah, Vaisla. If you're using a glass light and if you're pressing and you are seeing the changes. So this is what this is known as what? This is known as diascopic. Okay. Next, if you're able to see some kind of multinucleated giant cells in a smear taken around this dermatological lesion. So it is what? Yeah, correct, Rosalipha? Alphia. So it is what? It is the multinucleated giant cells. Okay, it is the multinucleated giant cells, and the investigation which is being done here, it is the Zank's smear. It is the Zank's smear. Fine. Next, if you're able to see, this is what, which test? This is known as what? Patch test, which is done for allergic contact dermatitis. And next one, this is what? This is the wood lamp examination. Okay. This is what? This is the, yeah, correct, location Baisla. Yeah, correct, Rose. And this is what? This is the wood lamp examination, which is means which is being used to see the characteristics, right? For example, in the case of erythasma, in the case of erythrasma, it will show which type of one? It will be a coral red color, whereas vitiligo will show which will show milky white. Okay, milky white. Okay, just remember vitiligo will show milky white. Fine. Yeah, correct, correct. Fine. Next, if you're able to see this on traumatic regions, if there is startage of these eruptions, this is known as what? This is known as what? Kobness phenomena. This is known as Kobness phenomena. Okay, fine. Yeah, correct, Rose. Next, if you're able to see, if you apply some tangential pressure, if the bulla ruptures, so it is known as what? Nikolsky sign. Okay, Nikolsky sign. And this Nikolsky sign will be seen in a case of Pemphigus vulgaris and pemphigoid. Okay, and pemphigoid disorders. Fine. Next one, this is known as Abse Hansen sign, which is also known as bulla spread sign. Means if you same apply some tangential pressure, the bulla will keep on spreading. So it is known as Abse Hansen sign, also known as bulla spread sign. Okay, just remember. Next, if you're able to see some pigmentary disorders, okay, hyperpigmentary disorders especially. Yeah, correct, Rose and Vaisla. Next, if you're able to see, this is what? This is known as what? Melasma. And we already saw in a case of pregnancy, if there is same melasmatic changes, it is known as what? Cholasma. Okay, chiasma will pronounce it as. Fine. Next, if you're able to see this kind of hypertrichosis, it is known as what? Becker's nevus. Fine. If you're able to see this type of blackish nevus, which is from the birth, it is known as congenital melanotic nevus. Fine. And this is what? This is the, if there is an ophthalmic involvement, it is what? Yeah, correct, Rose and Baisla. It is known as what? It is known as nevus of Ota. Okay. And if there is any involvement of this around the supraclavicular region, just a hyperpigmentation, it will be what? Nevus of Ito. Okay. This is what it is, the nevus of Ito. Okay. Guys. Next, we saw yesterday also, like this is what? This is the albinism child, and they'll be having this oculocutaneous albinism features, and it is due to this deficiency of which enzyme? It is due to the deficiency of, yeah, Lokesh, it is due to the deficiency of tyrosinase. Okay, tyrosinase. Next, this is what? This is the vitiligo. Okay, and if there is any some pigmentation like a vitiligo along with this forelock, okay, white forelock, it is what? It is the Piebaldism. Okay, it is what? It is the Piebaldism. Next, it is what? It is the contact leukoderma. It is the contact leukoderma due to bindi. Okay, due to this bindi, there is a contact leukoderma. Yeah, this Piebaldism which was seen in Indira Gandhi. Yeah, it is due to this chemical known as PTBA. Fine. And this is what? This is the hair dye. Hair dye, it is due to this chemical known as PTBC. Okay, PTBC. Okay, just remember. Okay, hair dye is due to the chemical known as PTBC, and you will be able to see this hypopigmentation over here. Fine. Next, this is what it is, few disorders. Like for example, yeah, if you're able to see this type of parakeratosis and hyperkeratosis, presence of the nucleus along with hyperkeratosis, it is known as parakeratosis and hyperkeratosis of this corneal layer. Okay, along with this neutrophils, neutrophils of this dermal papillae. Okay, and 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 there is a presence of this silvery micaceous scales. Okay, especially on the external surface. All of this they are features of psoriasis. Okay, and if it is if there is a psoriasis which is occurring in the pregnancy, pustular psoriasis of the pregnancy, it is known as which disease? Yeah, guys, answer. A quick responses for this question. The the psoriasis or the pustular psoriasis which is being happening in the pregnancy, it is known as what? Remember, it is known as what? It is known as impetigo herpetiformis. Yes, sure. Yeah, like these are the important images and points. Okay, just remember. Yeah, it is known as impetigo herpetiformis. Fine. And remember, it will psoriasis involves this extensor surface and will be having this silvery white micaceous scales. And if there is any raindrop, like it is known as guttate psoriasis. Guttate psoriasis. And once you remove the scale, if there is any bleeding, if there is any bleeding after removing the scales, it is known as what? What is the name of this sign? It is known as Aspitz sign. Aspitz sign. Okay. Next, if you're able to see lake of pus are also known as pustular psoriasis. It is known as what? Von Zumbachki reaction. Von Zumbachki reaction. It is known as what? Von Zumbachki reaction. Just remember. Fine. Yeah, correct. Lokesh Baisla and Rosalfia. Fine. Next, if you means mostly we studied the psoriasis will involve this external surface. If it involves this in like this flexor surface, so fine. Is it okay? Is it okay, Baisla? Is it fine now? Yeah, I think so. Yes. Then, like if it is occurs on the flexor surface, it is known as what? It is known as what? Inverse psoriasis. Psoriasis. If there is some kind of red complete body which is being turned, is it okay? Is it okay, Rose Alpha? Yeah, okay, fine. Yeah. Then this is what this is the inverse psoriasis. Next one, this is what? This is known as erythrodermic psoriasis. Okay, this is what is the erythrodermic psoriasis. Next, this psoriasis will lead to this type of arthropathies, which is the psoriatic arthritis, which involves mainly the DIP joint, which is known as what? Which is known as this pencil in cup deformity, and for this treatment we'll use this methotrexate. Methotrexate. Remember, only one disease will use this. Will use the steroid in the case of psoriasis. Okay, like especially in the case of in the case of pustular psoriasis of the pregnancy, we'll use the steroids. Whereas in other cases, we'll use this immunomodulators and the methotrexate. Okay, remember. Yeah, correct location, Rosalfia. Yeah, we're getting it correct. Next, if you will see this white lacy pattern on the oral cavity, along with this purpular plaques which are pruritic in nature and this flexor surfaces. Okay, this will be a features of, it means like there is also this polygonal in shape. This will be features of lichen planus. Okay, lichen planus. Okay, and you'll able to see this thing known as pterygium. Okay, you'll able to see this thing known as pterygium. Next, in lichen planus, you need to remember about this bodies known as civate bodies. You'll able to see this type of bodies in lichen planus known as civate bodies, and it involves the flexor surfaces. Fine. And next, if there is a ball, if a if a claw catching this ball appearance, it is seen in a case of condition known as small pin-shaped lesion known as lichen niditis. It is known as lichen niditis. Okay, remember. Fine. Next, if you're able to see if you're able to see this type of if you're able to this type of inverted or the field tree appearance or the Christmas tree appearance, and along with that, if you're able to see this type of this type of rings, which is are also known as patches, known as mother's patches. where you will able to see mother's patches with one drop rings and the correlate scales of the cigarette pepper scales, where you will able to see, yeah guys, it is known as pityriasis rosea. Okay, you will able to see in a case of pityriasis rosea. Just remember, fine. Yeah. Next, if you're able to see, if a young male who is, yeah, if there is a young male who is having these features of this flaccid bulla, flaccid bulla, on an examinations, under examinations, you will able to see this suprabasilar split. You will able to see this suprabasilar split showing this row of tombstone appearance. This along with these features of oral lesions. This will be suggested of which of the following? If there is a flaccid bulla, oral lesions, and suprabasilar split, and the direct immunofluorescence shows this fish net appearance. Okay, and there is a presence of these oral lesions. What you will think of? You will think of pemphigus vulgaris. Okay, if there is only just the skin lesions, okay, it will be think of, you will think of pemphigus foliaceus. Okay, you will think of pemphigus foliaceus because it's a flaccid bulla. It's not a tense bulla. You will be able to appreciate, right? This is a flaccid bulla, and this one it is a tense bulla. Okay, remember. And fisted pattern and the flaccid bulla, all of this, these are these typical features for pemphigus type of disorders. Remember, if you are vulgar enough, means if you give some vulgar words by your mouth, so just remember, we use vulgar words by your mouth. So, oral cavity involvement, it will be seen in a case of pemphigus vulgaris. Okay? Pemphigus vulgaris. Fine. And if there is no oral cavity, only skin involvement, it will be seen in a case of pemphigus foliaceus. And if you are able to see a tense bulla on a old age or a elderly patient, okay, and on immunofluorescence, you will able to see a linear pattern. Okay, linear pattern of IgE, G deposition, it will be seen in a case of bullous pemphigoid. Okay, it will be seen in the case of bullous pemphigoid. Fine. Then, okay. Then if you're able to see a linear IgA deposition, it is seen in a case of linear IgA disease. And then if you're able to see this only along this papillary tip, okay, you will able to see this immunofluorescence. This will be seen in a case of which conditions? Yeah, Rose. Yeah, we're getting it correct. Yeah, Baisla. It is what it is seen in a case of dermatitis herpetiformis. It is seen in a case of dermatitis herpetiformis. Fine. Next, we'll move on to some other conditions. In a case of, this is a case of TB, in which what is the type of the nodules you will be able to see in a case of dioscopy? Yeah, what is the name of the nodules you will be able to see in dioscopy? Yeah, Kalibai, yeah, Baisla. I will be able to see this apple green nodules or apple jelly nodules, especially apple jelly nodules are seen in a case of, yeah, it is seen in a case of TB. Okay, TB of the skin. And if there is a TB of the lymph node and it is forming a sinuses and it being ruptured to the outside, so it is known as what? It is known as scrofuloderma. It is known as scrofuloderma. Just remember. Yeah, correct, Baisla. Fine. Next, this is what this is the. If you're able to see this along this, all over these flexural surfaces, so there is some red lesions, red telangiectatic lesions, and which aggravates on taking a coffee or a caffeine or any hot shower. So it is what? It is the acne rosacea. Okay, and and there are different forms of acne, right? And this is what the typical one. It is what? It is the formation of comedones. Okay, there is a formation of this comedones. Fine, and we know, yeah, and we know the most severe form it is the nodulo. This is what? This is the severe form. It is the nodulocystic acne. Okay, and we can use oral isotretinoin in a case of acne. Fine. Yeah, this is the comedones. Okay, are the blackheads, are the open blackheads. Fine. And in for this acne, we'll use this type of therapy, which is known as PUVA therapy. Okay, we use this type of therapy known as UVA radiation. We'll use this for psoriasis known as PUVA therapy. Yeah, correct, Rose. Correct, Baisla. Fine. With this understanding, we'll move on to the next part. If you're able to see this child which is having this type of dermatitis, what it is? The atopic dermatitis. This is what it is, the atopic dermatitis. And this is the cradle cap. Cradle cap, which is also seen in a case of atopic dermatitis. And if you're able to see some kind of dryness over this hands because of this repeated detergent use, It is what? It is the allergic contact dermatitis. It is the allergic contact dermatitis. Okay. And the most common cause, it is what? It is the nickel. Okay. Whereas if you ask some metal, means the most common metal is the nickel. Okay. Whereas what is the most common cause? It will be the detergent. Okay. And if you're able to see after, yeah, correct, Baisla. After after scratching with a blunting object, if you're able to see some kind of hyperpigmentation, it is known as what? Diarrhea sign. It is known as diarrhea sign, and it is seen in a case of Atricaria pigmentosa. Yeah, correct, Rose. It is the most common one. It is the detergent. Fine. Diarrhea sign. It is what? It is seen in a case of Atricaria pigmentosa. Okay, pigmentosa. Fine. Just remember. Next, we saw this means this is what? This is the sarcopsis scabi, and it produces a special type of lesions which are known as what? Which are known as burrows. Okay, and for treatment we'll use 5% permethrin. Okay, and next, if the scab is which is involved on a bedridden patients, it is known as what? It can cause a means like a very severe form. It is known as, yeah, correct, Lokesh. It can form a severe type of scab is known as Norwegian scabies. Norwegian scabies. Fine. Next, if you're able to see, this is what? This is the loves we studied yesterday. The loves as a spurt or the pet. Okay, out of which P stands for this? Pediculosis. Okay, pediculosis. Just remember. Okay, and there is also one more thing known as, yeah, correct, Basila. Correct, Lokesh. Yeah, correct. Yeah, you're just remembering the mnemonic. That's very awesome. Fine. And if you're able to see this kind of parts which can causes this pediculosis corporis. Okay. So, okay, means it involves this body parts. Fine. Pet again means like it's a mnemonic for this louse. Okay. This is the pediculosis. Okay. Next, it is for epidemic typhus and for lapsing fever and T for trench fever. Okay. Just remember these things. Fine. These are the four diseases which are being caused by this louse. Fine. Next one. If you're able to see, if you're unable to see this line of demarcation after this, after the infection, it is what? It is the cellulitis. If you are able to differentiate, it will be what? It is the erysipelas. Erysipelas, and we know this cellulitis, it can involve the subcutaneous tissue, and this air is lacking the subcutaneous tissue, subcutaneous fat, so it won't spread to this air. Okay, just remember these things. Fine. And if it is just a single one, it is known as what? It is known as furuncle. Remember, it is F1. In the case of F1 race, the F1 cars will be means used by only one single person. Okay, whereas in the case of normal carbuncle, normal cars, the carbuncle, it will be having this multiple openings or multiple inflammation of the multiple follicles. Fine. Just wait a minute. It is the multiple follicles. Carbuncle involves multiple follicles. Okay, just remember. Fine. Next. Fine. This is what? These are all the tinea disorders. Fine. If this is what? This is tinea capitis. This is cruris. Tinea cruris. This is what? Tinea pedis. And this is what? This is the tinea versicolor. Okay, versicolor. We'll be able to see this hypopigmentary patches. So what is the tinea versicolor? And we know tinea versicolor, which shows this. Yeah, correct. Lokesh rose. It is what? It will show this spaghetti and meatball appearance. Fine. Next, it means if there is a two persons who are presenting you with some hypopigmentary patches over the face. Okay, and if one which is being associated with hypopigmentary patch along with these features of hypoanesthesia, okay, this will be suggestive of leprosy. Okay, and mostly it will be a old age people, means like a younger or the adults. Whereas if it is a child who is presenting with this hypopigmentary patches along with the scaly lesions, so it is what? It is will be what? It is known as pityriasis alba. Okay, because it will be lead to the scales, because scaling leads to this pityriasis alba. So just remember. Yeah, correct. Yeah, correct, Baisla. Fine. It is the leprosy part. Fine. Next we'll come to this some kind of STIs. Fine. This is the features of this secondary syphilis. Next, if you're able to see some kind of ulcer which is being painful, if any painful ulcer, it will be the most one of the most common cause of this painful ulcer. It will be what? It will be the chancroid. Okay, it is the chancroid. Okay, this is chancroid, and it will be caused by this Haemophilus ducreyi. Okay, just remember Haemophilus ducreyi because of this painful. Yeah, Rose, yeah, Lokesh, yeah, basically. Okay, fine. Next, if you're able to see this red beefy ulcer, red beefy ulcer, it will be seen in a case of donovenosis. It will be seen in a case of donovenosis. Fine. And this will be seen in a case of donovenosis. And if you're able to see this kind of buboes, which is being formed, it will be seen in a case of lymphogranuloma venereum, which will be caused by this chlamydia. Okay, okay, caused by this chlamydia. Just remember, yeah, means painless. They are this LSD is painless. Okay, lymphogranuloma venereum. Okay, syphilis and donovenous, they are painless. Whereas this only one, which is this one, which is chancroid. Why he's crying? Because of ducreyi, which is causing this chancroid. Fine. This is the mnemonic you will be able to remember. Fine. We know this linear involvement along this along this lymphatics. It will be what? It is the sporotrichosis, and this is what? This is the mycetoma with discharging sinuses. Fine. This is the discharging sinuses. Okay. With this understanding, we'll move on to the next part. If you're able to see this umbilicated papules, it will be what? It is the molluscum contagiosum. Okay. Contagiosum. Fine. Okay, fine. These are the simple warts. These are the warty lesions. Fine. Then, if you're able to see this around the lips, there is an involvement of means there is a formation of this grouped vesicles, which will be mimicking what? Which is because of which of the following organism? Yeah, Baisla, yeah, Lokesh, yeah, Rose. It is what? Yeah, this will be by this HPV, and this will be by this HSV. Okay, they are this grouped or cluster vesicles. Fine. And if you're able to see different types of rashes on the different stages, okay, different types of rash, it will be seen in a case of chickenpox. Okay, and this one is having this dermatomal spread, it will be seen in a case of shingles. Okay, and if you're able to see a infection in which the skin is peeling out, it is what? It is the staphylococcal scalded skin syndrome. Okay, and here also the Nichols skin will be positive, means around the pseudo positive. Fine. Yeah, this shingles will be caused by this herpes zoster. For treatment of the pain, we'll use this gabapentin or pregabalin, whereas for this virus, we'll use this acyclovir. Yeah, Lokesh. Yeah, Neurexin. Yeah, Baisla and Rose. Yeah, we're getting it correct. Fine. Next, if you're able to see this pigmentary lesions, it is what? It is the incognitia pigmenti. Okay. Initially, there will be a vesicular pigments. Fine. Then there will be a verrucous, or it starts with verrucous, then vesicular. Then there will be a hyperpigmentation followed by this hypopigmentation. Fine. Next, if you're able to see some kind of rashes and photosensitivity, this will be seen in a case of xeroderma pigmentosa. Okay, this will be seen in a case of xeroderma pigmentosa. Yeah, Rose, it is correct. And could anyone tell me what is the defect which leads to the xeroderma pigmentosa? Yeah, guys, it is what? It is what? It is the nucleotide excision repair defect. Okay, nucleotide excision repair defect. Fine. Next, if you're able to see this, what? It is the same Salmon patch. Okay. Next one. This is what? This is the collodion baby, or also known as X-linked ichthyosis. Okay. X-linked ichthyosis. Okay. Yeah, guys, you are getting it correct. Fine. Yeah. Next, if you're able to see this type of ichthyosis, it is what? It is known as Harlequin ichthyosis. Okay, it is known as Harlequin ichthyosis. Yeah. Yeah, Lokesh, Rose and Baisla. It is what? It is the Harlequin ichthyosis. Next, if you're able to see this sign known as shawl sign, along with this Gotron papules. Okay, both of these things they will be seen in a case of dermatomyositis. Will be seen in a case of dermatomyositis. Which of the following? Which of the following? Could you please write in a single questions? I just missed your comments. Mm. Fine. Yeah, Ashwin, it is correct. It is what? It is the dermatomyositis. Fine. Next, if you are able to see this melanoma. This melanoma, it is a pigmentary lesion. Along with this, there will be a yeah, sure, I will tell you. Just wait a minute. Like there will be a pigmentation, there will be asymmetry, and there will be means, and these are the features for this melanoma. And there will be positive for HMB45 and S100 positivity. And we know basal cell carcinoma, there will be a ulcer along with telangiectasia. We know it is also known as a rodent ulcer. Fine. Next one, this is the squamous cell carcinoma, which shows this keratin pulse. Fine. Keratin pulse. Okay, just remember. Next, this in the case of HIV positive patient, if you are able to see this type of cancer, which is what? Which is the Kaposis sarcoma. It is the Kaposis sarcoma. Fine. Next. So your question is this: how will you be able to differentiate this Harlequin ichthyosis and this lamellar ichthyosis? Lamellar ichthyosis, you will be able to see the major difference. Like you will be able to see there is a membrane, means it looks like some kind of membrane being covered over the baby. It is also known as collodion baby. So it is what? It is collodion baby. It is what? It is the X-linked ichthyosis. Whereas this Harlequin ichthyosis, there will be more drying. Means because of this drying, you will be able to even see the fissures. So this is how you will be able to differentiate this Harlequin ichthyosis from this lamellar ichthyosis. Fine. Harlequin ichthyosis from this collodion baby. Fine. Right. So this helps you. Next, you will see some few features of some neurotics, means like syndromes. Fine. This is what? This is the cafe aureate spots, which will be seen in a case of NF1. Next one, this is what? This is the adenoma sebaceum, which will be seen in a case of which condition? Yeah, it will be seen in a case of tuberous sclerosis, and there is also known as Ashley macules, and this is what? This is the Chagrin patch. All of this following will be seen in a case of tuberous sclerosis. Fine. All of this following will be seen in a case of tuberous sclerosis. Basal cell carcinoma, it is the most common because it occurs because of sun exposure. So just remember, basal cell carcinoma, it is the most common one. Fine. Yeah. Yes, only it is the NF. Fine. And these are all the features of tuberous sclerosis. With that, we are completed with this dermatology. Then we are moving towards the surgery part. Fine. Surgery is the bigger chunk. If surgery is done, then we have the shorter one, which is the ortho. And if time permits, we'll do this anesthesia one also. Fine. Yeah, fine. If you're able to see this type of PUD orange, okay. And what is the pathology behind this PUD orange? It is due to the blockage of which of the following structure? Yeah, guys. Yeah, this PUD orange, it is due to this blockage of this subdermal lymphatics. Okay, and it will be staged as, because whatever changes in the B means bar stages, it will be seen outside. So it will be, yeah, correct, Lokesh. It will be staged as T4B. So B for bar, any ulceration of this PUD orange, it will be staged as T4B. Yeah, correct, Mantish. Fine. Next, if you're able to see, this is what this is the nipple retraction. If you're able to see, this nipple will be attached to these ducts. Okay. If there is any ductal involvement of any of this cancer, it will lead to this retraction of these nipples. Okay. So this is what? This is the retraction of nipples. Okay. And we know there is some circumferential ligaments known as Cooper's ligament. So if there is any damage to Cooper's ligament damage will present as dimpling or puckering. Okay, will damage us, will probably means will show us as dimpling or puckering. Okay, means by the formation of dimples or puckering. Yeah, correct, Rose. Yeah, correct. Then if you're able to see this enlarged and means like swollen or enlarged breast along with some red enlarged breast along with means like along with some redness and the features of inflammation. This will be suggestive of inflammatory breast cancer. And could anyone tell me what is the name of this staging you will give for this inflammatory breast cancer? What is the stage of this inflammatory breast cancer? Yeah, guys, think. Yeah, it is staged as, it will be staged as T4D. Remember this one, PUD orange, it is a T4B. It's not T5, it's T4D. Remember, it is T5D. Fine. Next, if there is any distortion of this nipple structure, it will be seen in a case of Paget's disease of Paget's disease of nipple. And remember, for diagnosing this inflammatory breast cancer and Paget's disease, there is means we don't need to have a definitive lump to make a diagnosis, whereas without lump also we can make a diagnosis of this Paget's disease and this inflammatory breast cancer. Fine. Next, if you're able to see this enlarged, like massively enlarged breast, means this bosulated appearance along with this some irregular borders. Okay, this irregular borders, it will be seen in a case of tumor known as cystosarcoma phylloides. Okay, it will be seen in a condition known as cystosarcoma phylloides. Okay, just remember. Yeah, Rose, yeah, Baisla, you are getting it correct. Next, if you're able to see this type of popcorn calcification. Popcorn calcification will be seen in the case of which condition? Yeah, guys, it will be seen in the case of, correct, it will be seen in the case of which condition? In the case of fibroadenoma. Fine. And if you're able to see, okay, if you're able to see this type of microcalcifications, this type of microcalcifications, this microcalcifications will be seen in a case of ductal carcinoma in situ, right? Are mostly in the case of ductal carcinoma. Next, if you see this type of pattern, which is known as Indian file pattern, Indian file pattern will be seen in a case of lobular carcinoma. Yeah, Rajeshwari, yeah, Rose, you are getting it correct. Fine. And next, for post breast cancer surgery, we'll use this type of flap. We'll use this type of flap known as tram flap. Okay, transverse rectus abdominis flap. Okay, before means like it is the most commonly used. Okay, most commonly used. Whereas the disadvantage is that we are taking muscle along with it. So now we are most preferring is that we are preferring is that we don't need to involve this muscular structure. So we are taking a flap known as deep inferior DIP flap known as deep inferior epigastric flap without this taking these muscles. Yeah, correct. Rose and Baisla, correct. Yeah. Next, what are the complications can happen after the mastectomy? Fine. If the initial complication will be means after any means you are able to see there is some lump which is being already excised or recently excised or some procedure which is being done. There might be collection of this fluids which is known as what? Seroma. Seroma collection. Okay, seroma collection. Okay, because if there is any serous fluid collection, it prevents this healing of this edges of this wound. Fine. Next, if you're able to see, this is what? This is known as what? This is known as winging of scapula. Okay, due to the involvement of long thoracic nerve. Long thoracic nerve. Fine. Yeah. Fine. Yeah, Rose. Yeah, we are coming to the next part. Yeah, Rajsa, it is winging of scapula. Next, we are coming to the next part. If you're able to see, initially there might be a lymphedema. Then, after means especially they will give you a typical history. 10.5 years after CA breast surgery. After CA breast surgery, means after 10.5 years, means you will able to see some kind of lymphedema. Okay, prolonged lymphedema. What is this name of resulting into a tumor known as lymphangiosarcoma. What is the name of this syndrome? Yeah, guys. Yeah, Manasa. Yeah, what is the name of this syndrome? It is known as Stewart-Treves syndrome. Okay, remember it is known as Stewart-Treves syndrome. Okay, just remember. Fine. Next, if you're able to see, there is a swelling in the neck. Okay, there is a swelling in the neck which moves with deglutination and protruding the tongue. Okay, this will be a feature of which of the following? This will be a feature of thyroglossal cyst. Okay, yeah, Somesh, you are getting it correct. Fine. If there is just a cyst, it's okay. But sometimes what will happen is this cyst can become inflamed and can connect to the outside structure. So this can lead to this formation of thyroglossal fistula. Okay, and for the treatment of this thyroglossal fistula, we'll use the surgery known as cyst trunk operation. Fine. And next means along this passage of, yeah, correct, Rose, Somesh and Baisla. Yeah, Lokesh, yeah, correct. Yeah. And if you're able to see along this tongue and along this course of this thyroid, means sometimes this thyroid won't descend down. So this leads to this formation of this ectopic thyroid. Okay. Ectopic thyroid. Okay. Ectopic thyroid gland. And the most common site, it will be what? It is the Sublingual one. It is the sublingual one. Okay, whereas the most common site of this thyroglossal cyst, it will be what? It is the subhyoid. It is the subhyoid one. Next, if there is a swelling around the superior border of this mm, sternocleidomastoid. Yeah, it will be what? Yeah, correct. Bharat, it is what? It is the sublingual one. Previous one. Okay, this is what? This is the what is this thing? Yeah, guys. Yeah, Rose, it is what is the branchial cyst. Yeah, correct. Next, if you're able to see this radioactive uptake studies, the malignancies, they will usually take this, they won't uptake, so they will become as cold nodule. Yeah, yeah, Murari, yeah, we're getting it correct. Yeah, Lokesh, yeah, correct. Yeah, Rose, this is what this is mostly the malignancy, they won't take this cold nodule. I say they won't take this cold nodule as uptake. Fine. Next, if you're able to see this image, in which you are able to see this formation of this samoma bodies, samoma bodies. Okay. In which of the following condition you are able to see this samoma bodies? Which of the following? Cancer. Mm. And also you are also able to see the same cancer. You are able to see this orphan and nuclei, orphan and nuclei. And this both of these things, yeah, correct. We remember this mnemonic as PSM. Both of these things will be seen in a case of papillary carcinoma of thyroid. Next, if you want to differentiate between the follicular adenoma and carcinoma, we need to do biopsy, and we know follicular carcinoma. Okay, there will be a means it will spread. Yeah, yeah, Manasa, yeah, correct. Yeah, Baisla, yeah, Somesh, yeah, correct. Yeah, this follicular cancer, it should involve this capsule. It should be having this capsular involvement along with this involvement of blood vessels. Fine. Next, if you're able to see this white color lesions, it is what it is the sorry, it is the leukoplakia. The red one, it is the erythroplakia. Yeah, guys. Yeah, yeah, Rose. Yeah, correct. Yeah, Rajesh is very correct. Yeah. Next, if you're able to see, there is a mucus extravasation cyst in the floor of mouth. It is what? It is the ranula. It is the ranula, and it also will be showing this brilliant transluminance. Fine. It will be trans-illuminate in nature. Fine. Yeah, correct. Rose, Baisla, and the Morarai, correct. Then, if you're able to see this type of esophagus, it will be seen in a case of candida. And if you're able to see this type of tracheal ring formation inside the esophagus, yeah, if there is swelling here also in neck, it is known as plunging ranula. Yeah, correct. Thank you for remembering, Rose. Yeah, it is the candida. Yeah, correct, Rajeshwari. And if you're able to see the next one, if there is a formation of this multiple constricted rings known as trachealization of the esophagus, it is known as what? Eosinophilic, eosinophilic esophagitis. Fine. And if you're able to see this type of serpentigenous ulcer, okay, it will be seen in a case of HSV infection. And if you're able to see this kind of punctured ulcer, it will be seen in a case of CMV. Fine, it will be seen in a case of CMV. Yeah, eosinophilitis, correct. Yeah, I'm good, Alok. कैसे हो तुम? Okay, like how everything is going on. I hope everything is going good. Yeah, guys, it is the serpentigenous ulcer. Next, if you're able to see the single constriction, it is known as what? Shadsky ring. Okay, and it will produce a typical type of dysphagia known as episodic dysphagia. It will produce this episodic dysphagia. Okay, remember, means on eating a large chunk, they will be having this dysphagia. Next, if you're able to see this type of bird beak appearance will be seen in a case of achalasia cardia. Okay, it will be seen in a case of achalasia cardia. Fine. Is this discussions? Yeah, like genetic images where there are few genetic we have been already discussed in the previous sessions. You can go through it. Fine. In the pathology part, especially. Fine. Next, yeah, this is the bird beak appearance, and if you're able to see this shouldering along with some irregularities, okay, and this rat tail, shouldering means irregularity shouldering along with this rat tail appearance will be seen in a case of carcinoma esophagus. Okay, will be seen in a case of carcinoma esophagus. Yeah, correct, Rose. Correct, Baisla. Fine. Next, this is the esophageal manometry. Fine. And if you're able to see this type of filling defects inside the esophagus, fine, this will be seen in a case of esophageal varices. This will be seen in the case of esophageal varices. Okay. Yeah, guys, remember these things. Fine. With this understanding, we'll move on to the next one. Yeah, it's not stricture, it is the esophageal varices. Alphia. Fine. Next, if you're able to see this condition in which the baby will be presenting around the 21st day, it's not the first week or the first 3 days, it will be comes around after third week. Okay. And in third week, the baby will be presenting with vomiting. Okay, there will be projectile vomiting, and there will be features of hypokalemic, hypochloremic, metabolic alkalosis. On an examination, you will be able to see this type of appearances. And Barham's follow, you will be able to see this type of mushroom sign and this double tracking sign. It will be seen in a case of infantile hypertrophic pyloric stenosis. And you will be able to see this olive shaped mass. Yeah, guys, that's absolutely awesome. And location is not Hirschsprung disease. Hirschsprung disease, it will be a means it will be a means around this rectum we'll be able to see this thing. But here it is this IHPS. Fine. Yeah, Manasa Somesh, like yeah, Lohesh. Yeah, now you got correct. Yeah, correct. Yeah, Rose, you are getting it correct. Fine. This is in a case of infantile hypertrophic pyloric stenosis. And we do this type of Nissen's fundoplications. This Nissen fundoplications will be done in a case of GERD. It will be done in a case of GERD. Okay, fine. Yeah, you'll be able to see in the mass, you'll be able to see this. There is a movement from left to the right side. Fine. Yeah, thank you for remembering. Next, if you're able to see this double bubble appearance, will be seen in a case of duodenal atresia. Okay, whereas this triple bubble will be seen in a case of jejunal. Okay, whereas if you see some multiple bubble loops which are centrally placed and are dilated, it will be seen in a case of ileal atresia. Yeah, Lokesh, yeah, Murari, yeah, Alfia, correct. Fine, yeah, correct. Yeah, Baisla. Next, if you're able to see this type of cerebriform rugae, this cerebriform rugae will be seen in a case of will be seen in a case of Meniere's disease. Meniere's disease, remember. Okay, this is the Meniere's disease. Right. Next, in a case of CS stomach, you'll be able to see these two typical features. Around this umbilical, there is a superficial lymphatic deposition of this metastatic tumor, which is known as Sister Mary Joseph nodule. Next, on the right, not left supraclavicular. Can you see about? Yeah, Meniere's disease. It's just this. I think it's because of this TNF alpha overactivity. We'll able to see this rugae, which is being means hypertrophy, and it will shows like a cerebrum, like a brain. Okay. Yeah, you will be able to get this PDF from this description link. There is a group known as Dr. Banu Prakash sir group. Okay, in which you will be able to get this PDF once the session is over. Fine. Next, you will be able to see this supraclavicular lymph node, which is being enlarged, which is known as what? This is actually what Virtuous lymph node, which is known as Trozier's sign. Okay. Yeah, correct, guys. It is known as the previous one. It is known as Sister Mary Joseph nodules. No, Sister Mary Joseph nodules. Fine. Next, if you're able to see, there is a passage of this red color stools or this red jellies stools along with side. You will be able to see when you palpate the right iliac fossa, there is a empty right iliac fossa because the empty right iliac fossa. On examination, on ultrasound, you will be able to see this target sign, pseudo kidney sign. Okay, and on gross, you will be able to see this appearance. What is this thing is? Yeah, location it is what? Yeah, it is not Meckel's diverticulum. The next one it is the Meckel's diverticulum. Fine. This is the intussusception. It is the intussusception. It is the intussusception. Okay, it is the intussusception, and the most common site. Yeah, there will be a class sign can be seen. There will be a spring sign can be seen. Okay. Yeah, the most common site it will be what? It is the elio. It is the iliocolic. Means it is the iliocolic. It's not ileocecal. It is the most common. It is the iliocolic. Okay, it is the iliocolic. It is the most common part to be involved. Next, the most common pulling force it will be by this kind of pair patch nodes or this Meckel's diverticulum. Just remember, fine. And we know the one after administration of one of the following vaccine, this it can produce this as a side effect. Yeah, Kavita, yeah, Somesh, you are getting it correct. What is the name of this vaccine which is we use in like which can cause interception as a side effect? It is what it is the rotaviral vaccine. Rotaviral vaccine can cause this as a side effect. Just remember. Yeah, yeah, correct. Mahatesh Soni, yeah, correct. Rose, yeah, Somesh, yeah, Gopinath, yeah, Kavita, yeah, it's correct. Yeah, Manasa. And next, if you're able to mm, see some extra added bubble structures, okay, around 2 inch means around this uh, 2 means which follows this 2% rule. This will be what? This will be the Merkel's diverticulum, okay, Merkel's diverticulum, and we know, and it will be the most common content. It is what? It is the gastric mucosa. So we'll use this technetium 99 per technete scan. Yeah, correct guys, correct Kavita, Mahesh, Lokesh, Anjumara, yeah, correct. And means we know this Nichols diverticum, it is due to this persistence of this vitello-intestinal duct. There is a persistence of vitello-intestinal duct. Fine. Yeah. Yeah, guys. Next, if you see this cobblestone appearance, we already discussed in the patho, cobblestone appearance along with this string sign of contour. String sign of contour. Yeah. Session kab tak hai? It will be for more 45 minutes to 45 minutes. Yeah. We are going in a right track, so it will be finishing in another 45 minutes, guys. Fine. And this will be, these are the features of which of the following disease? It will be the features of Crohn's disease, and we know Crohn's disease, it will be having the associations of fistula and stricture formation. Okay, stricture formation. Just remember fistula, and along with this, there is a formation of the strictures. Fine. Next, if you're able to see, yeah, guys, yeah, Murari, yeah, you are getting it correct. Next, if you're able to see, there is a formation of this pseudopolyps. Pseudopolyps, and very minima, you'll be able to see this type of colon, lead type colon, and there is a loss of astrations. You'll be able to see in which conditions? Yeah, mm, yeah, Somesh, it is what? It is the ulcerative colitis. Okay, it is the ulcerative colitis. And yesterday we studied ulcerative colitis. We have this antibody, which is what? Which is the PNK, whereas here we'll have this is ASCA antibodies. Fine, just remember. Yeah, guys, yeah, Dr. Khan, yeah, Anjumara, they were getting it correct. Fine. Next, if we move on, if you're able to see this air under diaphragm, this air under diaphragm will be seen in a case of, will be seen in case of inlet pump. There is no hastrations. If there is any hastrations, means there should be normal hastrations. But in case of lead pipe, there will be no hastration. Just remember. Fine. Ya Lokesh, Kavita, Anjumara, ya Manasa, ya Kavita, ya Ashish, ya Murari, you are getting it correct. It is the air under diaphragm sign, which is seen in a case of perforations. For this case of pneumoperitoneum. Fine, pneumoperitoneum. And for this, we need to do adequate IV fluids along with this. Yeah, you're welcome, anonymous Zozo. Like along with this IV fluid resuscitation, we need to go for emergency laparotomy. Fine. And if you're able to see this enlarged, massively enlarged colon, it is known as what? It is known as toxic megacolon. Okay, it is known as what? It is known as toxic megacolon. And if you're able to see the small outpoaching structures, and on very minima, you'll be able to see this type of, okay, this type of this type of kind of rose thorn appearance, or this comb appearance, it will be seen in a case of sawtooth, means, or especially like a comb appearance, or the sawtooth appearance will be seen in a case of sawtooth appearance will be seen in a case of diverticulosis. Okay, diverticulosis. Just remember. Fine. It's not hair sprung. We are up, means we yet to come for hair sprung. Okay, just have patience, guys. Okay, it is what it is, the diverticulosis. Fine. And if you're able to see, this is our hair sprung. If you're able to see, there is a tapering, means there is a constriction, there will be narrowing, which you're able to see in a case of Hirschsprung disease. Okay, and this is what? This is the Hirschsprung disease. And we know in case of Hirschsprung disease, in the case of Hirschsprung disease, it is because of this congenital aganglionosis. Fine, there will be a congenital aganglionosis. Just remember. Fine. Next, where you will be able to see this? Yeah, constrictive part is the disease, so we'll remove it. Okay, remember. Next, where you will able to see this thumb sign in abdominal radiograph. Yeah, guys, waiting for your answers. Where you will able to see this thumb sign? Yeah, you will able to see in a case of ischemic colitis. Okay, you will able to see this thumbprint sign. Next, if you are able to see this type of pulled up cecum, this pulled up cecum, it will be seen in a case of TB. In the case of TB, you will able to see this pulled up cecum. Remember, in TB, you will able to see this pulled up cecum. Next, if you are able to see this apple core appearance, yeah, apple core appearance in a case of colon cancer. Yeah, guys, you are getting it correct. Fine. Yeah. No, Achilles we won't see apple core. Just remember, means in a case of either CA esophagus or CA colon, we'll use this, we'll see this apple core sign. Fine. Just remember. Like maybe some of you are watching this video on some like few seconds or few minutes begin. Just click this live uh, means like live options in your video so that you will be in a right track with this class. Fine. Next we'll move on to the next part. If you're able to see this one means yeah coffee bean sign. This will be seen in a case of sigmoid valvulus and it also produces this type of beak known as bird beak appearance on enema. Fine. Yeah. Yeah, correct. Bird beak, yeah, correct. Yeah, Rosalfia, yeah, correct. Astis Lokesha, we're getting it correct. Fine. Next, the bird beak also seen in a case of Achilles, but that is barium that is barium swallow, but this is barium enema. Just remember. Fine. Next, how you will means in image they will give you how you will differentiate between this colostomy from this ileostomy. Remember, means this is this colostomy or ileostomy. How will you think of this image? Means this is in our hospital we took this image, like we did this procedure. So like yeah, it is what yeah, I will tell you. Just wait a minute. Yeah. Hey, it is not prolapse. Prolapse means you will able to see this much amount of content. Yeah, it is the ileostomy. Yeah, correct, Gopi. Yeah. If you see, if you make something, means in a case of ileum, we know the fluid material, it will be a liquid in nature. So what we'll do is, we'll make some sprout outside the abdominal wall. You'll able to see, right? We'll make some sprout outside the abdominal wall. So this is what this will be done in a case of ileostomy. And this is what, this is this loop ileostomy. Okay, this is the loop ileostomy. Just remember, fine. This is the ileostomy. Whereas in a case of colostomy, it will be exactly attached to the abdominal wall. So you won't see like a sprouting structure. You will see this like this. It will be exactly attached to the abdominal wall in the case of colostomy. Fine. Next, how will we differentiate the sigmoid valvulus from this cecal valvulus? In the case of cecal valvulus, okay, sigmoid it will be producing this bent tube appearance of this coffee, like mainly this kidney bean means like this will be bent tube appearance, whereas this cecal valvulus it will be a single one. So it will produce this kidney bean shape. Okay, so remember this cecal valvulus will produce this kidney bean shape appearance. Okay, don't forget. And based on the location, because sigmoid colon is here, so it will go and tend to bend in this direction. Whereas if you see the cecal valvulus, it will come and bend in this direction. So the direction also matters. Fine. This is how you will able to differentiate. Okay. Next, if you're able to see this image, that okay, this is how a rectal prolapse looks like. Okay, this is how this is also taken in our hospital. This is how this rectal prolapse. Okay, this is how this rectal prolapse looks like. Okay, fine. It's a huge rectal prolapse. Fine. They did laparotomy and means after that they pushed in, like they tried and they reinserted inside it. Fine. This is a rectal prolapse. Fine. And hemorrhoids. And hemorrhoids, we know there are different types. Okay, there will be first degree, second degree, third degree, and fourth degree. In first degree, it's just a bleeding. Okay, second degree there is a bleeding plus hemorrhoids. Okay, hemorrhoids means which is the mass will be spontaneously reduced. Spontaneously reduced. Whereas in a case of third degree, there will be along with bleeding, the mass needs manual reduction. Whereas in a case of fourth degree, there will be it will stay outside. Yeah. Is the glycerin gas? No, actually means it was the time was questioning, so we didn't put glycerin gas. Later on, we tried with glycerin gas. Fine, fine. Next, in a case of fourth degree, you will be able to see this. In a case of fourth degree, means there will be a prolapse. Okay, but it cannot be manually replaced. Fine, just remember. Then you will be able to see this type of fistula. Means if you are able to see this fistula, it will follow a rule known as Goodsall's rule. Okay, Goodsall's rule. Okay, yeah. This Goodsall's rule tells that whatever this fistula opens in the anterior part, they will open in this anterior aspect. Fine. Whereas this whatever this fistula which origin from this posterior surface, they will come and open around this 6 o'clock. So they will come in a curvilinear fashion. Whereas whatever in this anterior part, it will come and open as a straight line. Fine. Next one, if you're able to see this sentinel tag sign, it will be seen in a case of fissure in ano. And remember, they will give you means they will give in the questions. All of the following can be done in a case of fissure in ano. They will give this per-rectal examinations. Remember, per-rectal examinations will be contraindicated in a case of fissure in ano. Okay, क्विक PDF जैसे खत्म हो जाएगा सेशन उसके बाद मिल जाएगा, ठीक है. Don't worry Deepa. Okay. Next, if you're able to see this type of multiple sinuses which forming this abscesses, which is known as what? It is known as what? Around the means coccyx region. It is what? It is the pilonodal sinuses. Okay, pilonodal sinuses, and this pilonodal sinuses we will do this. Yeah, also known as not jumpers. It means it is known as uh, jeep jeepers disease. Fine, just remember. Yeah, Kalkabi means I just told the team to upload it. It will be shared to you as soon as possible. Fine, don't worry. Fine. And this is what we'll use this type of flap known as Limburg's flap. It is known as Limburg's flap. It is known as Limburg's flap. Just remember. Next. Fine. In the case of pilonidal sinuses, we'll use this rhomboid shaped flap known as Limburg flap. Yellowish. Fine. Next, if you're able to see, means in a case of Mantrill's course, which is being used for this appendicitis, we'll give this 2 points. We'll give this 2 points, just two things. One is for this tenderness, and next one is for this leukocytes. Okay, just remember these 2 points about this appendicitis Mantrill's course. Next, if you're able to, in a case of appendicitis, you can elicit two signs. Okay, this is what means there are different more signs, but now have given us two signs. Okay, one is this obturator sign. In a case of obturator sign, you will internally rotate, means you will keep this hip in a 90-degree and you will internally rotate and it will cause pain to the patient. So it is what? It is what? It is the obturator sign. Okay, next, in a case of in a case of same appendicitis, means undoing this extension, means undoing the flexion over the hip, you will able to see, you will able to elicit pain to the patient. So it is what? It is the source test. Okay, there will be a source test and there will be a obturator sign and the source sign. Okay, it is source test and eliciting the source sign. Next, if you see this patient who is presenting with this features of this chest radiograph, which shows the appearance known as colon cutoff sign. Okay, this colon cutoff sign, it will be typical for which of the following disease? Yeah, correct. Source and obturator. Yeah, Rajat. Yeah, Manasa. Yeah, Kavita. You are getting it correct. This will be seen in a case of pancreatitis. Okay, pancreatitis. And we know the pancreatitis mostly it is a clinical diagnosis, but in a case of acute stages, we can use this CECT and we can diagnose it. Fine. Yeah, Manasa, Rajat. Yeah, Rose, you are getting it correct. Next, this is how this image of an acute pancreatitis looks like. But if there is some hemorrhages, means you see, means this is a contrast enhanced one. So you will able to see some kind of hemorrhages. So it is what? It is the hemorrhagic pancreatitis. Okay. And if there is any chronic pancreatitis, it can lead to this collection known as pseudocyst. Okay, pseudocyst. And in case of chronic pancreatitis, it can lead to this formation of this known as chain of lakes. Means there is a multiple calcifications lead to this sign known as chain of lakes. Okay, then around this umbilicus, you will be able to see in the case of hemorrhagic, yeah, internal bleeding, yeah, correct, Dr. Khan. Yeah, in the case of hemorrhagic pancreatitis, you will be able to see this sign known as Cullen sign. Okay, and along the flank, you will be able to see this sign known as Great Anna sign. Okay, these are the two signs you need to remember about this. You need to know about this pancreatitis. Fine. Next, about this hernia. Like you will able to differentiate most of the hernias. Okay, the confusion arises here from this femoral to this inguinal hernia. How will you able to differentiate this femoral hernia from this inguinal hernia? Fine. Yeah, there will be a Fox sign, which if there is an inguinal discoloration, it is known as Fox sign. Okay. Yeah, Raja. Fine. Means you will need to differentiate between this inguinal hernia from the femoral hernia. Remember, below this inguinal ligament, you will be able to see this femoral hernia. Whereas if you palpate, if it is above this inguinal ligament, it will be what? It is the inguinal hernia. Fine. And if you use mesh for this hernia repair, it is known as hernioplasty. Okay. If you use mesh, it is known as hernioplasty. Fine. Yeah, means inferior epigastric artery. It is mainly to differentiate this features of this direct and the indirect inguinal hernias. Fine. This is the hernioplasty. If just suture is being done, it is known as what? It is known as herniorrhaphy. It is known as what? It is known as herniorrhaphy. Just remember, guys. Fine. This is how this umbilical hernia and sometimes it can go for strangulations. Okay, and in such case, yeah, in such case, we need to go for an emergency surgeries. Yeah, this mesh, it is the Prolin mesh. Fine. Next, you need to remember about this content of these two things. Okay, this is the triangle of pain, which where you know means you avoid using this cauteries. Okay. Next, it is the mm, triangle of doom, which is more prone for bleeding. So you will avoid clampings over this area. So in the case of triangle of pain, these pains will be mediated. Yeah. Thank you, Anonymous Yoga. Like, because I'm just repeatedly seeing these images and I'm oriented with this, so um I'm just I'm just able to memorize it in a much faster manner. Fine. Which of the following you want to zoom in? Rose, could you please describe it? Fine. If you're able to see this, it includes this nerves, like include this lateral femoral nerve, like means there will be a lateral femoral cutaneous nerve, and there will be anterior femoral cutaneous nerve, and there will be a femoral branch of genitofemoral nerve, and there is a femoral nerve. These are the means four things that means that those are this part of this triangle of pain. Okay, so just remember, in the case of triangle of pain, we avoid cauterization. We avoid cautery. Okay. Whereas in the case of triangle of doom, we avoid clamping because there is a internal iliac veins and this internal iliac artery. Fine, just remember. Fine, like sorry, external iliac vein and the artery. Fine. Next, if you're able to, there are few different types of hernia you need to remember of. Fine. If there is just now the complete hernia, if just a wall which is outpoaching, if just a wall is outpoaching or this just this wall, it is what it is the Richters hernia. Okay, it is the Richters hernia. If the content of this hernial sac, it will be if there is a if it is appendix. Okay, it is what it is the Litters hernia. Fine, we know appendix is a little, so it will if it is a content, it will be a Little's hernia. Next, if it is a Muckle's diverticulum, it is what it is Ammian's hernia. Fine, or if this herniated content, if it forms some kind of W kind of shape, it is known as, if you flip this W, it will become M, it is known as Meyd's hernia. Then, if you are able to see, if there is a, if this herniated part, if it forms the loop, it is known as Cantalum hernia. Okay, these are the special type of hernia you need to remember. Okay, if there's a, okay, these are the special type of hernia you need to remember of. Fine, this is the same Meyd's hernia. Fine. Next, if you're able to see, there is a history of trauma patient and an evaluation, you will be able to see this deep sulcus sign. Okay, deep sulcus sign. Okay, and an ultrasonography. This is the normal one. You will be able to see this image. What is the name of this image? What is this image signifies? Yeah, you are doing E fast. Yeah, correct. Yeah, this is the fast. Along with this two more views, which will be the E fast. Fine. It is what it is the normal one, it is the seashore sign, and this one it is the stratosphere sign. Stratosphere sign are also known as barcode sign. Okay, are also known as barcode sign. Just remember, guys. Fine. And for this pneumothorax, if it is a child, we'll put a white bore needle in the second intercostal space. Whereas if it is an adult, we'll put this needle in the fifth intercostal space in the mid axillary line. Fine. Okay, guys. Next, with this, we'll move on to the next part. We studied this same thing in the pediatrics. It is what it is the congenital diaphragmatic hernia, and this is this tracheoesophageal fistula. Just remember, they will ask you this thing. Yeah, correct, Somesh, correct, Kavita. They will ask you this question: what is the most common type of tracheoesophageal fistula? Remember, the most common type it is the type C. The most common type it is the type C. Fine. Next, if you're able to see, there is a means they will give you usually means they will give a history of prolonged flight travel, after which they will be experiencing some shortness of breath. Means this will be a typical case of DVT. Okay, but if there is a large thrombus, we'll be able to remove. But if there is a small and multiple thrombus, yeah, Kavita Manasa correct, yeah, Lokesh correct. If there is a small or multiple thrombus, then in such situations, we'll means we'll use this we'll use this IVC, means IVC filter. We'll use this IVC filter. Remember, we'll use this IVC filter to filter out this clots which is being traveled from this venous circulations of this DVT to this systemic circulations, fine. Okay, so it is a filter for DVT, and this is the Fogarty's catheter which is used for this embolectomy, fine. Next, if you are able to see this tennis ball appearance, it will be seen in a case of which condition? It will be seen in a case of aortic dissection. Okay, it is seen in a case of aortic dissection. Whereas if there is any symmetrical, means if there is any enlargement, oh, IVC, yeah, IVC. Yeah, Sai, yeah, Lokesh, yeah, Somesh, yeah, correct, yeah, Manasa, yeah. Then if you are able to see the circumferential enlargement, it will be what? It is the aortic aneurysm. It is the aortic aneurysm. Okay, just remember, it is the aortic aneurysm. Fine. With this understanding, we'll move on to the next part. Okay, and this is the choledochal cyst, means cyst formation in the cyst, means in the biliary tree. Like mostly they will ask what is the most common type. Here the most common type, it is the type 1, but they won't ask you the most common type. They will ask you this type 3. This type 3 which is being repeatedly tested, and they will ask you what is the management. Like we'll just remove this cyst, or we'll just give incision and we'll remove this. Just remember. Okay, so just remember this type 3. Okay, this is the choledochal cyst. Fine. Next, if you're able to see this strawberry gallbladder. Strawberry gallbladder. In which condition you are able to see this strawberry gallbladder? Yeah, guys. Yeah, guys. You will able to see this strawberry gallbladder in a case of cholesterosis. In the case of cholesterosis. Fine. Yeah, correct, guys. Yeah, correct. Rose. Correct. Khan and Manasa. Fine. Next, if you're able to see this one, this is the water lily appearance, which will be seen in a case of hydatid cyst. Fine. Next one, it is what it is the, if you're able to see, this is not ERCP or MRCP. If you're able to see, we are just putting some tube from outside. So it is what it is the T-tube cholangiogram. It is a T-tube cholangiogram. Okay, remember it is a T-tube cholangiogram. Yeah, correct side. Fine. Next, if you see in the case of cholecystitis, will elicit this sign known as Murphy's sign. Okay, will be elicited in the case of cholecystitis. Fine. Next. Fine. If you're able to see this gallbladder wall which is being calcified, and this type of calcified gallbladder wall, it is known as what? It is known as Portian gallbladder. Okay, this is the calcified gallbladder wall, and we know this Portian gallbladder, it is a pre-malignant in nature. It is a pre-malignant in nature. Yeah. Yeah, correct, guys. How to differentiate from ERCP? Means remember, in the case of ERCP, we will able to see this. Means in the case of ERCP, you will able to see this endoscope. Okay, fine. First thing you will able to see this endoscope, and next you will able means you will put dye from this pancreatic ducts. Okay, not from this CBD. Okay, you will able to see we are putting inside the CBD, right? So you are able to see, so you can delineate very perfectly. So in the case of ERCP, you will put, you will cannulate this means you will cannulate the major pancreatic duct, and there you will install the dye. Okay, whereas here you will put inside the common bile duct, and there you will insert the dye. Okay, this is the major differences. Fine. Okay, and if you see this features of pneumobilia along with this features of small bowel obstruction and gallstones, this will be suggestive of gallstone ileus. And what is the triad you will see in the case of gallstone ileus? Yeah, guys. Yeah, we know. Will this triad is known as Wrigley's triad. Okay, it is known as what? It is known as Wrigley's triad. Fine. We'll see in a case of, yeah, correct Sai, correct Rose, and correct yeah, this gallbladder stones will produce post-acute shadow. Yeah, correct. Rose, yeah, correct. Yeah, Lokesh, yeah, we're getting it correct. Fine. Next, we'll come to this venous disorder. In case of venous disorder, they are repeatedly testing about this classification. If you see this classification, you can easily remember. Means C2 means, remember, 2 means if you keep this 2, it will form this V. So this varicose veins, it is actually what it is, the C2. Fine. If C2 it will be starting, then remember 3. 3 if you make this 3, this is the E. Means so edema. So 3 C3 it will be the edema part. Okay. And C4 there will be different parts in the C4. There will be C4A, C4B, and C4C. And in this case of C4A, there is a pigmentation. Fine. There will be a pigmentation in the case of C4A. Fine. Whereas in the case of C4B, there will be a lipodermosclerosis. Fine. There will be a lipodermosclerosis means you are able to see this C4 means it's actually what it is a C4b. Okay. And C4c means there will be if there is any radiating vessels which you are able to see it is what it is the C4c. Fine. Then C5 it will be a healed ulcer. C5 it is a healed ulcer. Next, if you are able to see a recurrent ulcer or non-healing ulcer, it will be a C5, C6. Okay, remember, C3 is edema, 4 is, has three components. A is pigmentation. After pigmentation, it will go for sclerosis. And C for C, there will be a corona phleboctotica, means there will be a radiation of this veins. And C5 it is a healed ulcer, and C6 it is a recurrent of this active venous ulcer. Fine, just remember. Yeah, active venous ulcer it is the C6. Okay, fine. This understanding will move on to the next part. Means they will give this typical history of a young smoker, means who is having he's smoking and he's presenting with this features of this hand shown below. Okay, this is what? This is a feature of Buerger's disease. Okay, like it's not Buerger, it is what? It is the Buerger's disease. It is the Buerger's. Yeah, sorry, it is the same. It is a Buerger's disease. Okay. Remember this, like so that you won't get confusion like me. So Buerger's, remember, Buerger's means if there is a U, it is the vasculitis component. Okay. If it is Berger, BER means it is just a IgA nephropathy. Remember. Okay, fine. And they will means if just they given this young male along with a smoker, this clinical picture, it will tells the Buerger's disease. Whereas if they give the speeches of any alcoholic history, any coronary artery history, and if he is somewhat older age, then you need to think about atherosclerosis. Fine. Yeah, usually means in if it is a Burgess disease, yeah, Gopi, you are correct. They will ask about this. They will tell about this young male smoker. Fine, and it is a small vessel vasculitis, and this involves all of these three components. It involves nerves, veins, and arteries. It involves nerves, veins, and arteries get involved. Fine, and this is what this is the Raynaud's phenomena. You will see this PCR means there will be a pallor, there will be a cyanosis, and there will be a loss, there will be a redness. Fine, just remember. Yeah, yeah, Lokesh, correct. Yeah, Sri Sai, correct. Yeah, yes, that's awesome. Yeah, Manasa, yeah, Khan, yeah, we're getting it correct. Then we'll move on to the kidney part. If you see this kidney part, I will able to see this mouth eaten calyces or mouth eaten calyces. Okay, this will be typical for this TB of kidney. Okay, and this will be followed by this kidney known as putty kidney, and on bladder you will be able to see. Okay, and on bladder you will be able to see the small bladder which is known as what? Thimble bladder. Okay, thimble bladder. Okay, okay. This are you need to remember about this kidney. Okay, yeah, guys. And if you are able to see this recess on this kidney and on the liver, and on the liver and kidney, if you are able to see this, you will be able to see this cyst. It will be what? It will be the autosomal dominant polycystic kidney disease. Remember, okay? Autosomal dominant disease, it will show cysts on the both kidneys and the liver. Whereas autosomal recessive, it will show fibrosis over it. Fine? It will show fibrosis over it. Yeah, correct, Sai? Yeah, correct. Fine? Yeah, correct, Khan. It will produce fibrosis. Fine? Next, if you're able to see some kind of penicillin cup, no, egg in cup deformity. Egg in cup deformity. It will be seen in a case of which of the following? If there is any necrosis over here, it will, or any acute tubular necrosis, okay, it will lead to this. If there is a necrosis over this kidney, okay, or if there is any papillary necrosis, it will lead to this. It will lead to this egg in a cup appearance. Fine. Next, if you're able to see this appearance, okay, of this paintbrush, of this kind of paintbrush appearance, okay, this paintbrush appearance will be seen in a case of medullary sponge kidney. It will be seen in a case of medullary sponge kidney. Just remember this. Fine. Next, if you're able to see this drooping lily sign, it will be seen in a case of duplication of ureter. It will be seen in a case of duplication of ureter. Okay. and this is the normal, means it is a usual renal calculi, and this is what this how this ESWL which is being done, means which will be done for less than 4 centimeter stones. If it is more than 4 centimeter, we'll do this PCNL. Okay, fine. Next, if you're able to see this air around the kidney, it is what it is the emphysematous pyelonephritis, and we know the most common cause for this emphysematous pyelonephritis, it is what it is the E. coli. Fine. Next, if you're able to see this type of, means broken stones. Yeah, this is the iliac source muscle. It is the iliac source muscle. Fine. This is the normal kidney stones. Okay, it is the renal calculi. Okay, which is radio opaque. Fine. Next, if you're able to see this formation of the small stones which are being collected, okay, like a street. So this is what, this is known as what, street of stones, also known as Steinstree's appearance, also known as Steinstree's appearance. Okay, just remember. Fine. Next is our favorite disorder, which is the Staghorn calculi, and we know organism responsibility is the Proteus, or which are any other urease producing organisms, and it will show this presence of this triple phosphate type of crystals. Okay, just remember, and it will take the shape of the kidney. Okay, and the most common stone, it is the calcium oxide. Yeah, correct, Kavita. Fine. The most common is the calcium oxide, whereas here in a Staghorn calculi, it is the triple phosphate stones. Fine. Next, if you're able to see, this is what, this is the horseshoe kidney, and we know in the case of horseshoe kidney, it will be prevented, the ascent of this horseshoe kidney, it will be prevented by this IMA. Yeah, correct, Sai, you already put up the answer. Correct. Yeah, correct, Disha, correct, Murari, correct, Manasa. Fine, it is the horseshoe kidneys. Next, if you're able to see this type of fish hook type of ureter, it will be seen in a case of benign prostatic hyperplasia. And if you're able to see this reverse J formation, it will be seen in a case of retrocaval ureters. It will be seen in the case of retrocaval ureters. Fine. And this is what, this is the hydroureteronephrosis. Okay, this is the case of hydroureteronephrosis. Just remember, guys. Yeah, Dr. Khan, yeah, Rose, yeah, correct. Fine. Next, if you're able to see this adder head or this cobra head appearance, it will be seen in a case of ureterosil. It will be seen in the case of ureterosil. Remember, and this, if there is any duplication of the ureter, okay, if there is any duplication of the ureter, it follows a rule known as Vegas-Mayer rule. Yeah, snake one, yeah, snake like, yeah, correct, Dr. Khan, yeah, Dinsha, yeah, Manasa, Rose, yeah, Murari, you are getting it correct. Fine. Next, if you're able to see this kind of appearance, teardrop deformity, because like after finishing your FMGe, you think like you need to get rid of these books and you want to go somewhere, yeah, or make a trip to either Goa or now it's Lakshadweep, which is trending to this Lakshadweep, and you need to create some bonfire and you need to relieve your stress. Fine. And for this, like for this, imagine like you are going with your friends and you want to create a bonfire, and you are, there is a pear tree available, so you are creating a bonfire with the pear tree. So you will able to see this pear shaped bladder. Okay, and we know bonfire, obviously there is a fire. So if you're able to see this flame sign, okay, one, and once you met with your friends and you are done with your exams or FMG, then you will be crying with the happiness. Fine. So there will be a teardrop sign. Okay, teardrop sign. All of these things are these features of extraperitoneal bladder rupture. Okay, bladder rupture. Fine. Or whereas in a case of intraperitoneal bladder rupture, remember, if you keep on accumulating some sad stuffs inside your heart, some days it will burst and open. So if you're able to see this sunburst appearance in a case of intraperitoneal. Okay, remember. Whereas extraperitoneal, its most common cause, it is the pelvic bone fracture. Okay, whereas intraperitoneal, it's because of this any blow. Okay, it's because of this any blow. Fine. Next, if you're able to see this Christmas tree, will be seen in a case of neurogenic bladder. Fine. Next, this is a huge bladder calculi. Fine. Yeah, Murari. Yeah, Lalit. Yeah, it is what it is, the bladder calculi. Okay. And if you're able to see this bone forming or this sclerotic metastasis, okay, Okay, yeah, sclerotic metastasis along with this change in this frequency of urination. It will be seen in a case of, it is in CEA prostate. And remember, we know P for P, it involves this posterior lobe. Okay, it will involve this posterior lobe and posterior zone. Okay, and this is the procedure which we use to do for BPH. Fine. Yeah, teardrop sign also will be seen in a case of like lobe fracture of the orbit. Yeah, nice correlation. Yeah, prostate and breast, both of them, they will produce this spine metastasis. But remember, prostate produces this bone forming metastasis, whereas breast cancer can produce both. Okay, like, but mostly it produces the bone lytic lesions. Okay. Sorry, I don't have a group. So this, whatever the PDF it will be shared into the Dr. Bhanu Prakash sir's groups. Okay, don't worry, Dhananjay. Like, I will take care of it. I will tell them if they are awake. I will tell them to send to net. If not, till the morning you will get it. Fine. And this is the TURP procedure. Fine. It will be done for benign prostatic hyperplasia. To remember about this benign prostatic hyperplasia, remember the mnemonic of MPB. So it will involve this median lobe and the transition zone. Okay, which is seen in a case of BPH. Okay, remember these features. Fine. You are welcome then. Next, we have this urethral injuries. If the most common part of this posterior urethra which is being injured, it is the membranous urethra. Okay, membranous is the most common part to be injured in a case of posterior urethra, whereas in a case of anterurethral rupture, the most common part to be in a case of anterior urethral, it is what? It is the bulbar urethra. Okay, and you will able to see this butterfly. You will able to see this butterfly hematoma. Okay, butterfly hematoma. Yeah, guys. Yeah, Dhananjay. Yeah, Lokesh. Yeah, Kavita. Yeah, yeah, Rose. Yeah, Khan. Yeah, we're getting it correct. Yeah, fine. Yeah, there will be a features of this blood at the tip of the meatus. Okay, in both the cases, whereas in the case of anterior, it also presents with this butterfly shaped hematoma along this penis and this scrotum. Okay, just remember. Next, this is the CA penis. Okay, okay. See, this is the CA penis. We know the most common one, it is the squamous cell carcinoma, and this is the Farneus gangrene. Okay, Farneus gangrene, and we know it is because of this mixed infections, both aerobic and anaerobic. Both aerobic and anaerobic causes this infection. Next, the most common congenital anomaly of this means like male urinary system. It is what? It is the hypospadiasis. Okay, it is the hypospadiasis. Fine. Yeah, yeah. Nectar-eating facts. It is also, it's a similar one. Okay, but it will be more dangerous looking. Fine. Mm. Next, if you're able to see, there are two conditions. One is phimosis, next one is paraphimosis. If you are unable to retract this foreskin, it is the phimosis. If the retracted foreskin causes compression of the spinal musculature, it is what? It is the paraphimosis. Okay, okay, guys. Okay, with this understanding, we'll move on to the next part. If you're able to see this bag of worm sensations, it will be seen in a case of varicocele. Okay, and if there is a deformity known as bell clapper's deformity, usually there will be this tunica vaginalis, it will be inserted like here. But if it is inserted over above, then it will lead to this, means mobile testis, means the testis will be mobile inside the scrotal cavity. So this can undergo torsion. So this is the testicular torsion which is happening because of this deformity known as bell clapper's deformity. And this testicular torsion, it can be differentiated from this. It can be differentiated from the acute epididymoarchitis. Okay, by this by this sign known as fun sign, because in epididymoarchitis this sign will be positive. Okay, whereas in a case of torsion it will be negative. Okay, just remember this. Yeah, yeah, correct, Lokesh. Fine. Next, this is the hydrocele. Okay, and the hydrocele will be transluminant in nature, and for this hydrocele we'll do this procedure like Jobulis eversion of sac. Fine, means we'll just open the sac and we'll just close it in a opposite manner, so that whatever the fluid um, collection, it will go outside. Front test, it is what? It is this means like when the patient is coming out with pain, if you just lift up or if you support this testicles, means the patient will be having this relief in the pain, and this relief in the pain it will be seen in a case of uh, acute epididymoarthritis. Whereas in a case of testicular torsion, you are not able, you will be unable to see this relief in pain. The patient will be still complaining of pain. Okay, so if there is some resolving of pain, it is known as Schwann test positivity. Fine. Yeah, sure. Yeah, yeah, Kavita. Yeah, I'm done this. Fine. This is the hydrocele. No, front test will be positive in epididymoarthritis, whereas it will be negative in case of torsion. Okay, and this is the keloid scare, and this is the hypotropic scare. We know keloid it will grow outside the wound margin, and in history they will be given it will be persisting for more than 6 months. Okay, it is the keloid. Next, this is the sebaceous cyst, and this is the sebaceous horn. Okay, next means in now like few means like 1 years back they asked this question, like in which of the following zonal trauma you will do exploration, and you will in which of the following zone you will just do some observations. If you see first zone 1 means there are major vasculations. Okay, major vasculation. So if there is any trauma, if there is any blunt or any penetrating trauma, you will do exploration. Any of these cases you will do exploration or emergency laparotomy. Okay, whereas in the case of zone 2, okay, in the case of zone 2, if it is a blunt, means you will just do observation. If it is a penetrating, you will do emergency laparotomy. Okay, whereas in the case of zone 3, okay, if it is a blunt, okay, you will means if there is a blunt and if there is any bleeding inside, you will apply this external compression. So you will apply external compression, and if there is any penetrating, then it will what? Then it will you need to do emergency laparotomy. Okay, just remember this, guys. Yeah, because the zone ones it is can having this as vasculars like IVC and aorta will do exploration. Mainly there is also pancreas. Fine, and there are different types of ulcer. If you are able to see, means this is what around this medial malleus. If you are able to see this, this is what venous ulcer, and if you are able to see this some necrotic, it is what it is the because of loss of blood supply. This will be the arterial ulcer. Okay, then means along the base of the foot, it will be what it is the neuropathic or this diabetic foot. Next on the pressure zone, it will be what? Yeah, correct, Kavita, correct, Baisla. Means on the pressure zone, it is what? It is the pressure ulcer, and there is a history of bones present and ulcer present. It is what? It is the Marjolin's ulcer. It is the Marjolin's ulcer. Fine. And if you are able to see this type of stockings which is being done, or this type of device, it is what? It is the pneumatic compression device. Okay. Yeah, Nitin. Yeah, Rose. Yeah, Kavita. Yeah, Unisol Gaming. I were getting it correct. Yeah, Lalit. Yeah, yeah. Means this marginal ulcer can progress into this squamous cell carcinoma. Fine. This pneumatic compression device will use to prevent the formation of DVT. Yeah, correct. Baisa, Nitin, and Disha, Dr. Khan. Fine. Next, if you able to see, this is the negative pressure wound therapy, and for this will maintain the intermittent pressure, and the negative pressure will be around this minus 125. Okay, minus 125. Fine. This is the vicryl, and this is the catgut. Okay, both of them they are observable. Okay, remember this catgut will be made from not from the catgut, it will be made from this sheep gut. Okay, then this is how this simple interrupted suture looks like. And if you take as a continuous bites, it will be a simple continuous suture. And here the difficulty will arise from this two horizontal mattress and vertical mattress. In the case of horizontal mattress, you will able to make a hutch, okay, between this line. So it will be a horizontal mattress. Okay, one way you will able to remember. Next, you can remember this vertical mattress. This vertical mattress can be remembered by the correct Baisla. This vertical mattress you can remember means like um, first bite means like in Hindi they will tell dur se or pass se, means first you will take from this distant, means first bite you will take from the distant. Fine, you will come along. Okay, and the second bite and come along till the length or till the distant, then you will take this bite means then you will take the prick which is near, and you will take near. Okay, so there will be a means So like this amount means like this. First you will prick here and you will go here, and then you will take, you will come here and then you will do suture. Okay, this is what, this is the vertical matter suture. Okay, if they ask you, just do this, do so. Fine. And this is what, this is the posturing suture. Fine. Next, they will sometimes they will ask you how will you be able to differentiate the square knot and the granny knot. Just nothing. Do a just a line over here. If you're able to see both of this, both means if the same suture material is passing through this, means if you're able to see, this red one will be the above on both side. Yeah, Therish wiring we can use in a case of rectal prolapse. Fine. Yeah, we can use. Or like post, like closing up any of this like gut structure which are having this means luminous structure, we will use this positive sutures. Fine. Next means this is this square knot. Fine. Whereas in the case of granny knot, you will able to see this is the violet which is going above in the first one, whereas second one it is the pink. So this is how this granny is knot. Okay, so square knot the same will be passing, whereas granny is not the opposite, means like, means in two sides there will be different suture metal will be passing. Okay, this is how you are able to differentiate between this square knot and a granny knot. Fine. With this understanding, we'll move on to the last part of our surgery. Okay, and this is what, if you're able to see, this is what, this is the Joel's thyroid retractor. Next, you're able to see this is this is also a retractor which is mainly used for this laparotomy. Okay, yeah, correct. Yeah, this is used for this laparotomy procedures to keep this abdominal wall to be open. And this is what, this is the proctoscope. Fine. And this is also already we study. If you make N, it will look like a Doyens. So remember this Doyens retractor will look like a N. Then if it look like a question mark, it is a Diavas retractor. And if it's kind of a flat appearance, it is a Morris retractor. Fine. It is a Morris retractor. Okay. Yeah, Kavita. Yeah, correct. Next, if you're able to see this type of appearances, okay, okay, on the edge it will be this Alice forceps. Fine. Alice forceps. Next, if you're able to see kind of thin one, it is known as what? Thin means if you make L, it is a more thinner, right? So Langenbeck retractor, it will be a thinner one. Next, if you're able to see this two two things, it will be a bipolar cautery. If you just see the single electrode, it will be a unipolar cautery. Fine. Yeah, Alice will be having the tooths. Okay, just remember. Next, this is the towel clip which is used to hold this towel. Like in the case of delivery or during a table, means like setting up a tray, you need a towel clip. Okay. Next, in the case of needle holder, you will be able to see this depression inside. This is the needle holder. Fine. Next, this is the Humbee's knife which you use for this skin graft harvesting. Fine. And this is the straight artery forceps, and this is what, this is the backup forceps which is used for holding this any structures, and it won't cause any trauma. For example, holding a during a pomarized procedure, we need to hold this fallopian tubes. At this moment we can use this backup forceps and we can hold it. Fine. And this um, this is this is what are these few main instruments. Next you can learn about this one. This is the skin stapler. Okay, and this is the stapler remover. Okay, yeah, it is a skin graft. Yeah, correct, Khan and Baisla. And next it is what, it is the endostapler. For example, in a case of bowels, means you are doing any bowel anastomosis. Okay, after ileostomy, you need to do, means ileostomy in a case of after perforation, you did ileostomy or a defunctioning colostomy. Okay, after that, after some time, when the bowel heals, you need to do re-anastomosis. So for such procedures, you can use this stapler known as endostapler. Fine, you can use this stapler known as endostapler. Okay. Okay, guys, with this understanding, we'll move on to the last slide of surgery. Okay, last slide of surgery, we have few more slide of ortho. Okay, and this is what, this is the Romovac drain. Okay, which will generate this negative pressure and it will suck the secretions. Fine. And next, if you're able to see, this is the corrugated drain, means there will be a corrugations. For example, during a hydrocele operations, we need to see this secretions to be coming out. We'll keep this corrugated drain. Okay. Next, this is what, this is known as Jackson Prate drain. Okay. Okay, this also generates this negative pressure, but it will be handy in nature. Okay, yeah, correct. Next, this is what, this is the T tube. Okay, to check for any, for example, post cholecystectomy, to check for any trauma, to check for any bile leak, or to make any secretions. It will we use this. Yeah, we'll use this T tube. Fine, just remember, guys. Yeah, Lokesh Baisla. Yeah, after cholecystectomy, yeah, correct, Kavita. Yeah, Dr. Khan, yeah, correct. And this is what this is known as harmonic scalpel. Okay, because at the same time it can cut, and also at the same time it can seal also. Okay, this is the harmonic scalpel. Okay, with this understanding we're done with the surgery part, and we are moving on with this mm, ortho part. Like mostly will be try to finish by from another 10 to 15 minutes. Fine, there is 16 more, around 16 to 17 slides in the ortho. Fine, and we'll be going in a faster flow. Like there'll be much images only, we need to grasp. Okay, fine. Yeah, finally. Yeah, Baisla. Yeah, Kavita. Fine. If you're able to see, this is what this is the anterior dislocation. Remember, if you want to propose someone, like either a boy or a girl, okay, there is no any gender bias. You need to go and stand in front of them, and you need to open your hands, and you need to open your hands, and you need to propose. So remember, if yeah, anesthesia will do it. Will do it, Bruce. Don't worry. Fine. Yeah. Okay, and you need to go in front, and you need to propose them. So remember this thing. So we are going anteriorly. So in the case of anterior shoulder dislocation, the arm will be abducted. Okay, the arm will be abducted and externally rotated. So the arm will be abducted plus externally rotated. Fine, this is the case of anterior shoulder dislocation. Fine, then this is how this light bulb sign, which will be seen in a case of light bulb sign, which will be seen in a case of posterior dislocation. Fine, we were yeah, here there is also dislocation and there is also fracture. Yeah, guys. Yeah, there is a means tuberosity fracture of this humerus. Yeah, correct. Yeah, correct, Rajat. Means like I used to have this eagle eyes. Yeah, you will able to find this small details. Like I hope so. Like you will get means most of this image based questions correct in the exams. Okay, this is what this is the posterior dislocation. Fine, and the features will be this adduction along with internal rotation. And this is what this is the inferior dislocation, which will be what? Which will be showing this feature known as luxatio erecta. Okay. And this, if there is any recurrent shoulder dislocation, this will lead to this two lesions. One on the humerus, another on the glenoid cavity. Means on the humerus, means on the posterior lateral aspect, and the humerus on the posterior lateral aspect, it will produce a lesion known as Hill sac. Remember, if it is on the height, it will produce on the humerus. So remember, Hill sac on the posterior lateral aspect of the humerus, whereas anterior inferior part of this glenoid cavity, it will produces this Bankart lesion. Okay, glenoid cavity, and this is the humerus part. Okay, humerus. Okay. Okay, the lower one third of the shaft of humerus fracture. It is known as it is there is a special name for this fracture known as Holsten Lewis fracture. Yeah, Khan, yeah, Baisla, yeah, Kavita, yeah, Lokesh. Yeah, correct. You are getting it correct. Next, for this shoulder dislocation, we use two tests known as Dugas test, means in which we'll tell the patient to touch this opposite shoulder, in which he is unable to do. It means it is a definite sign. And then we'll use this ruler, means so that means in a case of shoulder dislocation, the counter of the shoulder will be lost. So we'll use this test known as Hamilton ruler test. Just remember, fine. Yeah, a shaft axillary artery means not shaft axillary artery. Okay, shaft there will be a brachial artery, also known as profunda brachii artery, and there will be radial nerve involvement. Whereas if you see surgical kneecap fracture, there will be a axillary nerve involvement along with this posterior circumflex humeral artery involvement. Okay, okay, don't get confused, guys. Next, if you will see, this is the supracondylar humerus fracture, and if there is any means improper healing of the supracondylar humerus fracture, it will lead to this cubitus varus deformity. It will lead to this cubitus varus deformity known as gun stock deformity. Yeah, Rose. Yeah, correct. Yeah, correct, Lokesh. And sometimes this can lead to this kind of nerve entrapments. The most common nerve which is being injured, it is the anterintocious nerve, followed by this anterintocious nerve, followed by this median nerve. Fine. Next, it can go and impinge this brachial artery. Yeah, yeah, Lokesh. Yeah, yeah, Abdul Siki. Yeah, correct. And it can, means it can go and impinge this brachial artery and can cause compartment syndrome. Okay, and this compartment syndrome can be relieved by this procedure known as phasiotomy. Okay, compartment syndrome. Okay, they will be given this question. Okay, okay, about this compartment syndrome, what will be the treatment? It will be the phasiotomy. Fine. Next, if you able to see if this muscles undergo necrosis, it will lead to this condition known as Walkman ischemic contracture. Okay, it will lead to this condition known as Walkman ischemic contracture. Yeah, Kavita, correct. Yeah, Rose, correct. Fine. Next, if you able to see, there is a contracture of this um means especially this ring finger. It is known as what? Dupuytren's contracture, and it is most commonly seen in a case of alcoholics. Yeah, correct. Yeah, and there's also it can be associated with one more disease known as Orman's disease, in which there will be a retroperitoneal fibrosis. Fine. Yeah, there is a trigger finger. It's a different entity. Means this is a contracture. Contracture means it will remain like this. Whereas trigger finger, it's just a inflammation of this pulley, where you try to pull. Initially, it will give resistance, but later on, it will snap and open. It will snap and open. Okay, remember. So it is what it is the trigger finger. Okay. So you try to differentiate. Means most of these things they are dynamic questions. Means you need to understand the question. The question how he is asking. Fine. It may looks like a trigger finger, but the question tells you whether or differentiates you whether this is a trigger finger or a difference contraction. Okay. Fine. Next, this is what this is the lateral condyle of this humerus fracture. Okay, and this lateral condyle of the humerus fracture can lead to this cubitus valgus, and because of this there is a tardy ulnar no palsy. Okay, yeah, okay, Kavita, fine. Yeah, this is what, because we know this medial border, it will be transmitting this ulnar now. If there is a if there is a if there is a no growth over this lateral part, this medial part tend to grow, and it will lead to this tardy palsy. A correct rules, Dr. Khan and Baisla. Fine. Next, there are means in forearm you need to remember about these few fractures. One of them is the Colles fracture. If you are able to see this Colles fracture, this is this dorsal displacement of this distal fragment. It is the Colles fracture. Okay, okay, and and both of the Colles and the reverse Colles, which is Smith fracture, it is a they are extra-articular in nature. And remember, you can have this mnemonic. You know, once you meet a Virat Kohli, means who is a cricketer, once you meet, first what he will do, he will do the handshaking. Okay, he will do this handshaking. So for this treatment, he will do this handshaking cast. Okay, and after handshaking, he will go and have a dinner. So means if there is any improper healing, it lead to this dinner fork deformity. Dinner fork deformity. Okay. Instead of dorsal displacement, if it go to this volar side, it will be a Smith fracture, and Smith fracture can lead to this garden spade deformity. Yeah, correct, Abdul Siddiqui. Correct, Baisla. Yes, yeah, correct. And this Colles fracture can cause this sympathetic stimulation known as Sudex dystrophy. Okay, Sudex dystrophy, and it's one of the second most common fracture which is being occurred after push injury in a osteoporotic females. Fine, remember the most common fracture is being the vertebral fracture. Okay. Next, if you're able to see, this is what isolated ulnar fracture. It is the nightstick fracture. Only isolated ulnar fracture. Next, if you're able to see this styloid process of this radius which is being fractured, is known as what? This known as Schoffer's fracture. Okay, isolated radial styloid process. Next, if you're able to see this, first we'll come to this. Musa means if there is any upper ulnar fracture, if there is any upper ulnar fracture along with superior radio-ulnar dislocation, it will be seen in a case of which fracture? Yeah, guys, yeah, that's awesome. Yeah, Kavita, Lokesh Khan, yeah, you're absolutely blasting with answers. It is what it is, the Monteggia fracture. It is known as what it is, the Monteggia fracture. Whereas the opposite of it, if there is any radial fracture, if there is any inferior part involved, it will be what it is, the yeah, correct, Somesh. You are providing this exact descriptions. That's awesome. Yeah, it is what it is, the Galizia fracture. It is known as what, Galizia fracture. Fine. Then yesterday we saw, means if this is what, this is the tibial fracture. Okay, this is the tibial fracture which is most commonly seen in the case of RTA. Fine. Okay, this is the scaphoid fracture. And we know when we discussed yesterday, in the case of scaphoid, nerve involves with explaining which of the following means I could get it, guys. Like in the case of Musa, like it's most commonly the PAN, posterior introsus nerve, which is being involved. Fine, fine. Yeah, scaphoid fracture. We use this correct. Somesh, we use this thing known as glass holding class cast, and this scaphoid can undergo into this avascular necrosis. And we know that there will be tenderness over this anatomical stem box. That's awesome, Kavita. Yeah, that's correct because this content of this uh, anatomical stuff box, it is the radial nerve. Correct. Yeah. Yeah. Okay. Yeah. Correct, guys. Yeah. This is the glass holding cast. Okay, next one. If there is any extensor extensor tendon damage, okay, then this will lead to this. If there is any extensor tendon rupture, we know remember by this mnemonic of med. Okay, if it is what it is known as mallet finger. Okay, mallet finger, there will be damage to this extensor digitorum tendon. Okay, extensor digitorum tendon. Whereas jersey finger, it is the opposite. It is the flexor tendon. It is the flexor part, and both of them they will use this type of splint known as frog splint. Okay, frog splint. Fine. Next, if you're able to see this type of arthropathies, yeah, yeah, correct, Kavita Murari. Fine. If you're able to see this type of distal nodules, this distal nodules, they are known as what? Herbata nodules. Whereas this proximal nodules, they are known as what? Bouchard nodules. Okay, Bouchard nodules. Both of them they will be seen in a case of osteoarthritis. Osteoarthritis. Okay, osteoarthritis. Whereas this Z deformity, Z deformity, Svanek deformity, Z deformity, Svanek deformity, and along with what is another deformity? Yeah, guys, goutness deformity. It's not gout. Gout will come back. Okay, come. Goutness, gout. It's a crystal arthropathy. It mainly involves this toe joints. Okay, don't confuse it. Okay, this is the goutness deformity. All of these things, mm, it will be seen in a case of rheumatoid arthritis. Yeah, Kavita. Yeah, Baisla. Yeah, Rose, Lokesh. Yeah, you are getting it correct. It is the rheumatoid arthritis. Fine. And this is what this is the psoriatic arthritis, and along this you will able to see this deformed joints over the DIP. Okay, it is what it is the psoriatic arthritis. It's psoriatic. Fine. What is the difference between osteoarthritis and rheumatoid arthritis? Yeah, means like the main difference is that both like means you can remember means remember osteoarthritis, it's a girl's favorite arthritis. No, not rheumatoid arthritis, it's a girl's favorite arthritis. Okay, why it is girl favorite? Because girls they want to apply their nail polish over this distal phalanges, so it won't involve this distal phalanges. Okay, and it involves this proximal means, and it involves this um, MCP joints and the wrist joints. Okay, uh, remember. And whereas osteoporosis, it will mainly involve this DIP. Okay, this is the major features which you can differentiate from this, which you can differentiate um, from the clinical features. Fine. And then there is also a few more things like osteoarthritis. It is there will be formation of the small clumps over the joints. There will be multiple mobile nodules. So it's in depth. Okay. So this is a simple thing on basic description you will be able to remember. Okay. Yeah, I think so. You got it. Like it's at the end of the day, you need to answer the question, right? They will absolutely they will tell you there is a wrist involvement and MCP involvement. There is a sparing of this distal interphalangeal joint. So you need to think of nothing. You need to just think about this rheumatoid arthritis. Okay, okay, fine. Yeah, guys. Yeah, osteophyte formation. That's absolutely awesome. Rose and Lalit, Dr. Khan. Yeah, fine. Yeah, welcome. We'll then move on to the next part. If you're able to see the same, if you want to propose anteriorly, you need to abduct and externally rotate. So remember, if there is an anterior hip dislocation, also there will be a abduction plus external rotation, whereas posterior it will be adduction plus internal rotation. Fine. This is the same one, which is the where you will able to see this femur which is being adducted. Here you are able to see this femur which is being abducted. Here you will able to see there is a acid means there is a fracture of this acetabulum and this head of this femur which is being pushed inwards. It is what it is the central fracture and dislocation. Okay, dislocation of hip. Okay, remember this, guys. Okay, central fracture and dislocation of this hip. Okay. Then, if you're able to see in a case of hip fracture, we can use this type of screws known as dynamic dynamic hip screws. Okay, dynamic hip screws. Okay, this dynamic hip screws. Next, if you're able to see this, which is known as what? Means this type of prosthesis, which is having this 2O. Okay, this is known as what? Austin Moore, means 2O, 2 for Austin Moore prosthesis. Okay, fine. Yeah, correct, Rose. Yeah, it is what? Yeah, it's having this holes. It is what? It is the Austin Moore prosthesis. Fine. Next, if there is no any holes, it is what? It is the Thompson. Thompson prosthesis. Fine. Yeah, guys. With this understanding, we'll move on to the next part. If you're able to see, this is the hip spica. Okay. It is not done for hip fracture. Remember, it is done for the femur fracture. And yesterday we discussed. Okay. Wow. Yeah, like yeah, you can take screenshot like Somesh has given some absolutely nice um few comprehensions. Yeah, correct. That's awesome. Yes. Yeah, that's awesome. Fine. Then if you're able to see this application of this cast, it will go and compress this superior mesenteric artery, and in this superior mesenteric artery go and compress this duodenum. Okay, and this syndrome, it is known as what? It is known as what? Cast syndrome. Okay, remember this. This is known as cast syndrome. And what is this was? What is this thing? It is the CTEV. Okay, for CT, what is the name of the splint we will use? Yeah, correct, guys. It is what? It is the Dennis Brown splint. Okay, we'll use this Dennis Brown splint for this CTV. Okay, fine, and we use this menu known as Ponseti serial manipulations. Okay, Ponseti serial manipulations. Okay, and we know it's a child, so it will play with kites. So we'll use this angle known as kites angle. Okay, and we'll use this angle known as kites angle. Fine. Next, if you're able to see, if you're able to draw the line, means this hip is outside. So it is what? It is the developmental dysplasia of this hip. Fine. And for developmental dysplasia of the hip, we'll use this harness known as Pavlik harness. And what is the name of this splint we'll use? Means like means it's not there is any age restrictions. It can be started from this 2 months as early as possible, or less than one age. We'll start this Ponseti serial manipulations. Fine. And this is what? This is known as what? This is Pavlik harness. What is this image? This known as what? Von Rosen splint. Okay, Von Rosen splint. Okay, and in this we do two tests known as Barlow's and Watanabe's. Fine. In the case of Barlow's test, if you're able to see, are you able to see this Barlow's test? Okay, remember, if you go to a bar, if someone goes to the bar, they keep on adding. So what they will do, will do adding. Means we'll do adduction. When we do adduction, means after some packs, they will become saturated and they will be abducted. Means they will be abducted from this wall. So remember, so or so initially will cause adduction and the hip means in the hip joint, the femur will pops and comes out. Okay, so this is the Barlow's joint. Fine. Whereas in the case of Watnadi, it will be the opposite. We'll try to means mm, we'll try to abduct the joint. Okay, here we'll try to abduct one. In the case of Watnadi, we'll try to abduct. Okay, okay, just remember this thing. Okay, or else you can remember Barlow, you will keep on adding the packs and you will be dislocated from this world. Okay, you will try to dislocate in the case of Barlow's test, whereas you try to reposition in the case of Watnadi test. Fine. If you're able to see this pepper pot skull along with this rugger jersey spine, okay, along with this radial resorption over this phalanges, and there is a formation of the small brown tumor. All of this suggests which of the following conditions? Yeah, yeah, correct. Bhavnesha one. It is what? It is the hyperparathyroidism. Yeah, Dr. Khan, yeah, Dr. Kavita, and Dr. Rosalfia. It is what? It is the feature of hyperparathyroidism. Fine. Next, if you're able to see this type of fish mouth vertebra, fish mouth vertebra will be seen in a case of osteoporosis. Okay, and if you're able to see this kind of intervertebral means calcifications of this intervertebral discs. Okay, along this it will be seen in a case of which of the following condition? It will be seen in a case of ankylosing spondylitis, and there will be a typical history of the male who is having sacroiliitis, and they will be unable to bend forward, and there is a features of HLA B27 association. Okay, it will be seen in a case of ankylosing spondylitis. Fine. Okay, next, if you're able to see this champagne glass pelvis along with this trident hand. Okay, both of these things will be seen in a case of achondroplasia. Okay, yeah, dagger spine, they also known as bamboo spine. Yeah, correct, guys. It is also known as bamboo spine. Okay, bamboo spine. And if there is any calcification over this anterior ligaments, it will lead to this sign known as dagger spine. Fine. And this is what? This is the what is this one? This is what? This is the fibrous dysplasia. This is a fibrous dysplasia. Okay. Yeah. Where you will able to see this shepherd crook deformity. Yeah, correct, guys. Correct, Rosalfia. Correct, Lokesh. Correct, Somesh. Guy, are getting it correct? Yeah, fine. Yeah, fine. And this is what? There are few tumors, like few malignancies we need to remember. If you're able to see this triangle, okay, this is what? And this is what making this triangle. This is what? This is this osteosarcoma. Okay, it will show this Codman's triangle along with this presence of this appearance known as sunray appearance. Okay, and if there is this fallen leaf sign, this fallen leaf sign will be seen in a case of simple bone cyst. Fine, and if there is any multiple this bony lesions, but this growth plate, if not, it is fused. Fine, yeah, it's not osteomyelitis, it is osteosarcoma. Okay, don't get confused. Okay, don't get sleepy. Like we'll have another for 5 to 10 minutes, then we'll go and have a sound sleep. Okay, don't worry. Fine. And if this is what this is not GCT. That's where the confusion is. Okay, fine. If you're able to see this growth plate, if it's unfused, it will be what? It is this aneurysmal bone cyst. Okay, it is this aneurysmal bone cyst. But whereas if this growth plate is fused, if the growth plate is fused, then it will be what? Then it will be the GCT. Okay, don't get confused, guys. Okay, this is the typical blunder we do. Okay, don't get confused. If this first, if there is any sobable kind of lesion, just see this. Just see this growth plate. If it is unfused, it will be what? It will be the unusual bone cyst. If it is fused, it will be the giant cell tumor. Fine. Next, if you're able to see, this is what? This is the exostosis. Fine. This is the enchondroma. Fine. This is the enchondroma. Fine. And okay, fine. And this is what? This is the, if you're able to see this some kind of nidus, it is what? It is the osteoid osteoma. This is the osteoid osteoma. Fine. Okay, guys. Fine. Next, if you're able to see, where you will be able to use this aeroplane splint, in which condition you will be able to use this aeroplane splint? Yeah, we'll use this in a case of brachial plexus injury. We will use in a case of brachial plexus injury. Fine. Next, where you will be able to see this cylindrical cast. Yeah, guys, correct. They were asking where is Ewing sarcoma. Means in Ewing sarcoma means Ewing sarcoma, it's less likely visible on radiology because you will see, means they will tell there is a, you will able to see this onion peel appearance, but it's not very prominent on radiology. So mostly the Ewing sarcoma, it will be history based, and there will be a positivity of the CD19. Okay, and it will produce this onion peel appearance. Okay, this cylindrical cast will apply on patella fracture. Okay, patella fracture. Yeah, nice guys, nice Kavita, nice Somesh, nice Dr. Khan and Maruri and others Baisa. Fine. Yeah, it is a done in a case of patella fracture. Fine. Next, this is what? This is the hanging cast for humerus fracture. This is the hanging cast for humerus fracture. Fine. Yeah, correct Kavita. Correct Baisa. Fine. Next, this is what? This is which splint? This is the knuckle bender splint. It is the knuckle bender splint. Okay, which will be used for It will be used for which of the following? It will be used for this claw hand. Yeah, guys, it is used for this claw hand. Yeah, correct. It will be used for this claw hand. And this is what? This is known as what? This what? This is the cock up splint. Yeah, Dr. Khan. Yeah, Rose, you are getting it. This what? This is the cock up splint is used for radial. No, fine. And to identify this type of scoliosis will means the reason for the scoliosis will use this test known as Adams forward bending test. Okay, and this brace will use this known as what? Milwaukee brace. It's used for scoliosis. And remember, we'll use one more angle. What is the name of this angle we'll use for scoliosis? We'll use this. Yeah, guys, it is we use. Yeah, guys, yeah, Murari, yeah, Lokesh, yeah, we will use this Cope's angle. Next, you'll be able to see this brace is known as what? Taylor's brace. This Taylor's brace will be used for TB, TB spondylopathies. So, fine. Yeah, guys, yeah, correct. Yeah, Maruri, yeah, Kavita, yeah, Somesh, yeah, you are getting in track, you are on track, fine. And the last one, it is what? It is the Jaipur foot. Okay, it is known as what? Jaipur foot. Just remember. Next, if you are able to see this fixator. Okay, this is what? If it is a round, it is what? It is a Ilizero fixator. Fine, this is the Ilizero one. And then if you are able to see this, these are all this Ilizero fixator. Fine. If it is a ring, it is Ilizero fixator. If it is flat one, then it will be a rail fixator. It will be a, yeah, right. Jaipur foot, if it is used for this, after this amputation over this ankle, we'll use this Jaipur foot. Fine. This is what? This is the rail fixator. Okay. Means like a rail track, we will be able to see this track. So it is what? It is the rail fixator. Whereas this one, it is the Ilizero fixator. Fine. Next. This is what? This is the tension band wiring. Okay, which can be done in a case of when there is a excessive muscle pull. For example, we can do in patella, and also we can do in a olecranon fracture. Yeah, Rajat. Yeah, Somesh. Yeah, Kavita. Yeah, you are getting it correct. Yeah, Rose. Yeah, tension band wiring will keep this KYS in the figure of 8. Okay, in the figure of 8, we'll use this KYS and we'll make this tension band to counteract this tension pull. Yeah, Bhavanish Chavan. Correct. Next, the last part of this orthopedics is what? It is this image. This is what? This is the bone cutter. Okay, and this is what? This is the curate. Bone curate means which we use for this unusual bone cyst. Fine, which will use for this unusual bone cyst means we need to do the curage known as extended curettage. Okay, because there will be multiple cavities, you cannot do a single curettage. We need to go on into each cavities and we need to do this curettage. Okay, guys. Next, this is the bone cutter, and this is what? This is the bone nibbler. This is the bone cutter, and this is the bone nibbler. Fine. Yeah, fine. And like these are about this orthopedics, and we have few more slides, and it will be done within within 7 minutes. Will be done with means 7 more slides will be done with anesthesia, and they'll be done for the session. Fine. Just be here for 7 more minutes. Will be done. Fine. Hmm. In anesthesia. Okay, guys. Yeah, Kavita. Thank you for coming this long. Okay, this long. If you have came means just wait for a few more minutes. We'll be done with anesthesia. Fine. Yeah, let's get it done. That's the spirit, Kavita. Yeah, yeah, Baisla. Yeah, that's awesome. Fine. If you're able to see this type of laryngoscope, which is having this curved blades, this being used for this adult, it is what? It is the Macintosh type of laryngoscope. It is what? It is the Macintosh type of laryngoscope. Okay. Next, if you're able to see this straight blade. Okay. Okay, if you see this straight blade, it is what? It is the Miller's type of laryngoscope, and this Miller's type of laryngoscope will use for this pediatric patients. Fine. Yeah, correct. Baisla, Rose, Kavita, Murari, Dr. Khan, and um, Charan, Charanjeev, and Somesh. Yeah, correct. Okay, fine. Next, if you're able to see, this is what? This is the endotracheal tube. It is the ET tube. And ET tube, you just remember, means this is the cuff. This is a cuffed ET tube. Okay. Whereas infants will use uncuffed ET tubes, whereas adults will use this cuffed part. Fine. This is what, and there is a one eye known as Murphy's eye. Okay, means which provides additional means means if there is any blockage to this inferior structure, means this Murphy's tube, Murphy's eye can be supportive and can produce ventilation and provide ventilation. Okay, and this cuff will be low pressure and high volume in nature. High volume. Okay, and the remember the resistance of this tube. The resistance of this tube is depend on the resistance of this endotracheal tube is yeah, correct, Katri. The resistance of this yeah, will push around 10 to 15 ml, around 10 ml will push. The resistance of this endotracheal tube is based on this diameter, not the length, based on the diameter. Fine. Yeah. No. Mm, double lumen yeah, double lumen ET tube will be held in a case of thoracoscopic surgeries. Okay, thoracoscopic surgeries. Fine. Just remember, this is this double lumen. This is the double lumen ET tube. This double lumen ET tube, what it does is means it will inflate this two lungs separately. Means one lung will be ventilated from this and another lung will be ventilated from this. So, in the case of any thoracoscopic procedure, we'll use this. In the case of any thoracoscopic procedure, will use this double lumen ET tube. Fine. Next, in sometimes, for example, you are doing any subject surgeries in the back, for example, any sebaceous cyst, yeah, correct, Somesh, yeah, you are coming with absolute numbers, like which will be like it is very hard to memorize. That's awesome. You are knowing this much stuffs, yeah, fine. The size usually for adult men it will use 8 to 8.5, whereas females will use around 7 to 7.5. Fine, yeah, correct, guy. Fine, and this is what in the case of any surgery we need to do in a prone position. In such surgeries like sebaceous cyst or any myelomeningocele repair, means we need to put this ET tube. If it come like this, it will kink. So we'll use this type of tube known as kink resistant. Okay, you'll able to see, right? This is the normal one which is being kinking. This is another tube which is not able to kink. So this is what this is the kink resistant ET tube. Okay, and once you put this ET tube, means there is a tongue, right? And you when you give a general anesthesia, the tongue will tend to fall back. Okay, to prevent this fall back of the tongue, we'll use this airway known as Goodell's airway. Okay, Goodell's airway. Okay, whereas you want to do some simple procedures or you want to do some daycare surgeries, in such cases, what you will do means you will do this. You will put this airway known as laryngeal mask airway. You will use this airway known as laryngeal mask airway. You just go and keep over the larynx and you just inflate. Okay, but one of the prerequisites that means the patient should be having the NPO because there is a high risk of aspiration in a case of LMA airways. Fine, and there is also one more version of this LMA known as LMA Prosil, in which to prevent this aspiration will be attaching this NG tube. Okay, this is this LMA Prosil. Fine, yeah, guys, yeah, I were absolutely blasting with answers. Yeah, Chiranjeev, yeah, Baisla, Lokesh, yeah, Dr. Khan, yeah, Murari, yeah, that's awesome. Fine. Next one, this is this classification. This is the Mallampati classification. This is the Mallampati classifications. If you see this Mallampati classification, you will able to see means if you are able to see this tip of uvula. Yeah, thank you, Keshav. Yeah, like yeah, proud to be have you as a junior also. Like thank you for attending sessions. Like just keep on going. Like it's just a flow of motivation. It should be spread from one to another. Okay, that's it. That's the motive of the sessions. Fine. Yeah, Rose. Yeah, Chiranjeev. Yeah, Lokesh. Yeah, Baisla. Yeah, Murari. That's awesome. Fine. You're giving this like exact answers which I wanted. That's really like boosting my confidence. Fine. And if you're able to see this Mallampati scoring, means if you're able to see this um, tip of the uvula, it is what it is the class 1. Okay, if you're unable to see this tip, but you will still able to see this uvula, soft palate and this hard palate, it will be what it is the class 2. Whereas in the case of class 3, you will just see this soft palate and hard palate. Whereas class 4, you will able to just see this hard palate. Okay, so and we know this class 3 and 4, there will be a difficult in airway. Means there will be a difficult. These are this difficult airway. And Mallampati is 0 when we tell them to open the mouth, if you see this tip of epiglottis, means if 0 is this, if you see this tip of epiglottis, okay, it is what it is the Mallampati class 0. Okay, no, it's not previously, means like there can be history of intubated, like because of the there may be one of the reasons. Okay, but if you're able to see this tip of epiglottis, it will be what it will be classified as Mallampati 0. Fine, that's it. Next one means we need to know about this few instruments. Fine. No, in 3 we able to see the soft palate. See, in 3 we able to see the soft palate, whereas in 4 we unable to see the soft palate. Fine. Just remember, yeah, correct, so much. And next one, these are this. Initially, when a patients come, we'll put them on this nasal cannula, and then you will shift to this, means because this nasal cannula can deliver up to 0.45% or 45% of this oxygen and around 2 to 6 liters. And if the patient is still not maintaining, you can shift them into this mask known as Hansen mask or the simple mask, okay, where you will able to deliver this FiO2 up to 0.60, fine, and you can deliver up to 6 to 8 liters of oxygen per minute. Then if still he is not unable to maintaining, then you can shift to this mask which is known as Venturi mask. See, this is same mask. If you connect here, it is the normal mask. If you attach this tube, it will be a Venturi. It will become a Venturi mask. Fine, and it is based on this color coding. You will able to see this is the type of Venturi mask you will able to see, and both are the saving producing the same FiO2. Okay, but the difference is that means it will produces around 6 to 8 liters. It will use means output of 6 to 8 liters, whereas this will give around 12 liters of oxygen per minute. Fine. Next one, this is this anesthetic mask, anesthesia mask, which can give up to FiO2 up to one matlab means can give up to 100% of oxygen. Fine. And with this same simple mask also we can provide this 100% of oxygen. Okay. Yeah. Yeah, I will tell you. Okay, means if you add a reservoir bag to this mask, means this can even deliver up to 100, means around this 90% of oxygen. So this is what this is NRBM mask, means non-breathable mask along with this reservoir bag. Okay, this is this reservoir bag. Fine. Means how will you measure this NG tube? Means to measure this NG tube, what you will do is means you will start with this tip of your nose, then you will go along the ear, okay, and then you will go along this zipisternum, okay, means tip of the ear, means then go along this triangle pointer, and you will go till this zipisternum, then means then you will mark the point, then you will put this nasogastric tube, okay. These are the things you need to know, guys. Next, if you're able to see, this is the amber bag, okay, this is the amber bag, which is a pediatric one, okay, which can deliver up to 250 ml. Fine, I think so. It's yeah. Just remember, it is the amber bag which can deliver up to 250 ml of air. Okay. Then this is the rotahaler, means there will be a powder capsules. You need to crush, means you need to put, it will automatically crush, and you need to inhale. And this is what this is the meter dose inhaler. Fine. This is the meter dose inhaler. Next one is the cannula. Okay. And cannula, I think so. You know the story. Means there will be a lava inside, which will be orange in color, followed by the soil, which is be brown in color, and no, not only ear to sternum. Means if you keep ear to sternum, means it won't give you a perfect length. But means nasogastric, just remember, means just apply the simple principles. Nasogastric means you need to put into the nose, and it need to go along the nasopharynx. Then it need to go into the esophagus. Then into this means then into the stomach. Fine. This is the funda. If you keep the ear, means you are just measuring from here. You are not measuring this nose and into the nasopharyngeal length. This will be measured when you choose from this tip of the nose. Fine. This is you need to remember. Yeah, like someone buys like yeah, you know this much mathematics. Like I should have learned from you, because like doctors they will learn less maths. Okay, less maths. Fine. Like if unable to remember this, I will just tell you a few simple trick that you can remember. Fine. The grass will be green in color. Then there will be this plant which will be green in color, and this pink flowers, and along with the blue sky and a yellow sun and a purple galaxy. Fine. If you yeah, correct. Means if you unable to know, means or you are not able to, in exam they asked you one question and you were remembering soil, then tree, then there is a flower, means it will take a decade for you to get answer. So remember means 18 years you will get green flag for everything in your life. Okay, so it is a 18 years you will get a green flag. So remember, it is 18 as green. And girls means girls favorite color is pink. So girls, they always want to be in their sweet 20s. So 20 means girls favorite color, which is the pink. Okay, if you remember these things you can remember above and below. Yeah, correct, Somesh. Yeah, again you are coming with absolute numbers. Yeah, violet, which is the 26 gauge, which is actually not given here. Violet, which is be used for especially for the newborn. Yeah, correct, so much. That's awesome. Fine. Next one, if you're able to see this alternate bands. Okay, bends in the needles. It is what? It is the two-hoist needle. It is known as what? Two-hoist needle. What is this? Yeah, yeah. You're welcome, Kavita. Means two-hoist needle will be used for this epidural anesthesia. Fine. Okay. Okay. And these are these other needles like Spotty and Vitakis. They are non-traumatic and they are dura separating needles. Whereas the spin keys, they are dura cutting. Okay. Because they can produce this pain. Yeah, correct. Murari, Kavita, Lokesh, Baisla. Yeah, you are getting it correct. And once we once we given this spinal anesthesia, we'll make this position as Trendelenburg position and reverse Trendelenburg position. For example, you want to do a lower cesarean section, then you given anesthesia, and you want to this anesthesia to be flown down and to anesthesia. Yeah, and to be anesthetized this nerve roots, so that you will fill the table and keep it in a reverse Trendelenburg position. Okay, fine. Whereas this Trendelenburg position, if you keep, it can go into the cardiac tissue and it can cause bradycardia. So, okay. And this reverse Trendelenburg position, it can be kept in such surgeries where you don't need some bloodless field in the lower surfaces. Fine. Yeah, post-dural headache, it will be most common in the case of dura cutting needles like Quincus needle. Fine. Next, if you're able to see, this is this over this mucosal application or the skin application for any needle. Needle procedures will use this cream known as Emla cream, which will be made up of 25% of or 2.5% of lignocaine and 2.5 percentage of prilocaine. Fine. Yeah, correct. Somesh Kavita, Dr. Khan and Rosalfia. Next. And this procedure, it is what? It is the IVR, intravenous regional anesthesia. For this, the systolic BB means the cuff should be inflated. The cuff inflated should be systolic plus 50 in upper limb, whereas systolic plus 100 in lower limb. Okay, this is the intravenous regional anesthesia, and this is our IV anesthetic, which is all. This is the propofol. Okay, this is the propofol. Fine. With this understanding, we'll move on to the next part. There is two more slides left. Okay. Yeah, propofol, it is used in the case of daycare surgery, and it is a milky white solution, and and it is antiemetic in nature. Okay, just remember. Fine. And propofol false BP, so it will cause decrease in the BP. Fine. Yeah, this is the anesthesia machine, also known as Boyle's machine. And in this unit identify, this is this vaporizers. These are this vaporizers. These are this flow meters. Next unit identify this one, which is what? Which is the CO2 absorber. This is how this CO2 absorber looks like, because in most of these nerve setups we'll use this closed circuit, because the patient will breathe and the inhalational anesthetic will come back along with this carbon dioxide, and the carbon dioxide will get absorbed. Okay, once it absorbed, this carbon dioxide means mainly it will be made up of the soda lime. When it absorbs this carbon dioxide, the color of this chamber will be changed. Fine, it will be made up of soda lime. Okay, just remember, it will be made up of soda lime. Next time they will show this marker and they will ask you what is this. Okay, fine. Just remember these things. Fine. This understanding will move on to the next part. Next one is the capnography. This is how this normal capnography looks like, because after doing intubation, we need to check for a few things. Okay, yeah, there will be a pigment known as phenolphthalein, which has been used in this used in CO2 absorber, which turns this color into pink around the violet, so that it will tell us this needs some replacement. Yeah, again so much here, like the IV array, it's also a daycare procedure. These are all the properties of the propofol. Yeah, correct. Yeah, it can cause AIP. Yeah, correct. Yeah, it is also used for the insertion of this laryngeal mass cavity. That's correct, Somesh. And yeah, means we know, like, once the ET tube is being placed, okay, we need to know whether it is exactly in the lung, means in the trachea. So we will measure this EtCO2. Means EtCO2, it will show there will be a lice, and the curve will be of this shape. Okay, and if there is any drugs which you are giving, for example, if the patient is undergoing PPH and you are mm, mm, giving this cabergoline, means you are giving any of the drugs which causes this bronchospasm. Fine, carboprose, for example, you are giving carboprose which causes this bronchospasm. If there is a bronchospasm, it will produces this type of this shark fin type of grafts. Okay, and if if the patient is in anesthesia, okay, he's in general anesthesia, but now his anesthesia being means he's returning back to this normal state. Now what he can do is he can self-extubate. If there is any self-extubate, then this will become 0, right? Or if you're doing an esophageal intubation instead of a tracheal, this curve will become flat. Okay, remember. Okay, these are the things you need to remember. Okay, yeah, fine. Yeah, if it is CO2 rebreathing, the the height of the curve it will become increased. Fine, that's you need to know, guys. Fine, and to know this depth of anesthesia, we'll use this index known as BIS. Okay, bispectral index we'll use for depth of know this depth of anesthesia, and also in this one of this is to know this um, now means BAS we use this monitoring of this now. Here we are monitoring this ulnar now. Okay, we are monitoring this ulnar. Fine. Next one about this anesthesia circuits. In anesthesia circuits, you need to remember just Mapleson A, D, and F, E and F. Fine. Remember A, it is for A and D for adults. A, D, U, L, T. So D and D for adults. Okay. So A and D for adults. So adult means they can do their things spontaneously. And C and D is for it is also known as brain circuit, which is for controlled ventilation. So remember DC means D circuit is for controlled ventilation, whereas A is also known as Nagel circuit. It will be for this spontaneous ventilation in adults. Fine. Then Mapleson E, it is what it is also known as IRSTPs. Fine. Whereas Mapleson F, it is also known as means Jackson modification of this iris TPs, and both of this E and F they are used in a pediatric patients. Fine. Yeah, correct. A is Nagel, D is Bain, F is Jackson and Reese. They are correct, Somish. Fine. Next is about the cylinders. If you're able to see, if you're able to see this black body with white shoulder, it will be what? It is the oxygen cylinder. Okay. And we know means oxygen. What is the pin index of this oxygen? Hi, Arman. Yeah. Yeah, remember it's not 3,5, it is 2,5. Remember the pin index of the oxygen it is 2,5. Okay, because remember means whatever this the air contains two things. One is this nitrous oxide, another one is the oxygen. So nitrous oxide and this oxygen. Okay, if you see this nitrous oxide, it means both of them the posteriorly. At last they will be having this 5. Fine. This oxygen. Yeah, yeah, no problem, no problem, Murari. Fine. At last, if you're able to see, there will be having this 5. Fine. If you're able to see, oxygen it is having this 2, so it is 2. Fine. Whereas this nitrous oxide it is having this 3 letters N 2 O, so it will be having this 3 5. Fine. Whereas this N-Max will be having a special pin number known as 7, which is a mixture of now it's a rostron. Yeah, black with white shoulder it is oxygen, blue with this blue which is what? Which is Neela, which is for this nitrous oxide. Fine. And C or this cyclopropane which is in orange in color. Fine. Yeah, correct. Yeah, that correct. Yeah. If it is a white shoulder with black blue body, it will be what? It is a Intermax. Yeah, guys, that's awesome. Yeah, I'm really impressed with your answers. Fine. Yeah, and means for carbon dioxide we use this gray color cylinders. Fine. Just remember, and these things this will be enough. Fine. And if in case of any emergency procedure, if you attempted any intubation, but this intubation fails, in such scenario, you will able to do this first procedure, which is known as what? Which is known as what? You are doing this first procedure, which is known as cricothyroidotomy. Okay, cricothyroidotomy. Initially, we can do with needle or we can do with tubes also. Fine. Next one means the definitive management. What we can do is we can do this tracheostomy, and you can see this cuff here also. Fine. Next one. This is the last part of this anesthesia. Last slide for the day. Fine. And the CPR. CPR means if there is any protocol means CPR. First, what you need to know means what we need to know is the scene safety. Means air it is this 1 and 5. Air it is 1 and 5. Okay, just remember air it is 1 and 5. Fine. It is if it is know the CPR, first you need to check for the scene safety, because while resuscitating, if you are hidden by a means tractor or a car, means it will be a very drastic one. Someone needs to give CPR to you. So remember, first we need to see the scene safety. Then we need to check first. Next we need to check for the response. Okay. After checking the response, means if you are alone, we need to get some help. Okay. When you get some help, or means when you call for help, next, what you will do is first you need to open up the airways. Remember, first is for this airway maintenance. Fine. First, you need to open up for the airways, and you need to check for any breathing. Okay, and then you need to start compressions. Okay, first you need to maintain this open airway, so that patterned airway, then so that he can, if he resuscitates, then he can, yeah, first if there is no help available, yeah, you can start first help and then severe, but first should be the scene safety. You need to, if if there is an accident, if this patient is lying, if the person is lying in the middle of the road, means you cannot just go and call help and later on you will just come and ring. First you will ensure the scene safety, fine. And if he's responding, what is the need of help, fine, fine. Just remember, then we'll start this chest compressions and to breathes, fine. In adults, just remember the in adults it is what, it is the 30:2, okay, whereas in child it will be 3:1, fine. Okay, fine. Management of GTCS now means like in a case of uh, in a case of acute status epilepticus, you just turn the patient to the left lateral side, fine. Means in adults the ratio will be 30 compressions to 2 rescue breaths, whereas in children it will be 3:2, or mainly of infants, fine. These are all about this. And for children will means for mainly of infants, will do this technique known as thumb encircling. Means we'll hold the chest and will press using our thumb, okay, thumb encircling. Whereas in normal, means in adult patients will use our palm and will give pressure, fine. And these are all about this part for the day, and about our IBQ sessions. And that's a simple saying, means just do and show to the world. Okay, just instead of saying that means saying till now, just there is few more days left. Just do better in your exams and just show to the world that you can do it and you can do better than anyone else in the world. Fine. Yeah, this session, if you ask me, direct images, they can come up to from minimum from 10 to anywhere between 25, and there will be descriptions like any questions, any clinical scenarios, it will show. There will be descriptions, there will be description of these images, fine. That's what, Manasa. Yeah, thank you, Kavita. Yeah, Lokesh, like after choking, yeah, after choking we need to do Helmish maneuver. Yeah, Vaisla, thank you. I also feel so good, like after meeting you guys, like it was really, yeah, really yeah, good 2 days. Yeah, like I'll be remembering this on every day, fine. Yeah, thank you, Rosalfia. Thank you for answering, guys. Thank you for being a part of it. Like you guys did my session. Like I enjoyed because you are answering very repetitively and you are answering more correctly, more accurately. Fine. Yeah, thank you so much. Yeah, all the best for you guys. And Murari, Kavita, yeah, thank you. And Swanson Buser, thank you, sir, for this. Yeah. Yeah, sure. Yeah, yeah. We'll be having the more sessions. Like once I'm free, like we'll do more sessions. Don't worry. Yeah. Thank you, Lokesh. Thank you, Manasa. Yeah, yeah. We'll meet you up in some success sessions, and like wish you all the best for your upcoming exams, and take care of yourself. Just have a calm mindset. You will be having a good exam because you have come across till this way to mm, to get this exam and to show to this world that you can do anything in this world. Okay, that's it, guys. Thank you and all the best. Okay, don't worry. Good things will happen. Yeah, I'm good. Tasif, how are you? Fine. Yeah, good night, guys. We'll see you on the next session. Fine. On any other sessions, like for any NEET PG and the upcoming exams. Fine. Yeah, sure. Yeah, yeah. My blessings will be always with you, and I will pray for you. Fine. Don't worry. Fine. Have a good night. Okay. Yeah, sure, guys. And you will be getting the PDF. Don't worry with the PDF. Like it's my responsibility. I will just insist them to share as soon as possible, if possible tonight or by tomorrow morning. Fine. Yeah. Good night, boys. Good night. Bye. Okay. I will see you later. Bye, bye, guys.